Now, we welcome Dr. Head of Emergency Medicine at the prestigious AIMS Rishikesh. So, Dr. Nidhi, please, the stage is all yours.
Good morning, everyone. I am Dr. Nidhi Kaile, Head of Department of Emergency Medicine at AIMS Rishikesh, and I'm going to talk about evaluation and management of a patient with a stroke in emergency department. So, what do you mean by stroke? Stroke is defined as an abrupt onset of neurological deficit that is attributable to focal vascular cause. So, the definition includes both the clinical and laboratory studies, including the brain imaging, to support the diagnosis. There are two underlying mechanisms of stroke. One is the ischemic and the hemorrhagic. Ischemic part is further subdivided into thrombotic, embolic, or hypoperfusion. Now, this is the basic blood supply of brain, which is of importance to us to understand the various the cortical stroke syndromes. So, if we talk about the anterior circulation of the brain, it is supplied by bilateral internal carotid arteries, and basically the ICA divides into anterior cerebral artery and middle cerebral artery. Now, let us talk about the middle cerebral artery first. The cortical branches of the middle cerebral artery, it supplies the lateral hemisphere, except a strip along the superior medial border of fronto-parietal lobe, which is basically supplied by ACA, and lower temporal and occipital lobe, which is supplied by the PCA. That is the posterior cerebral artery. Another important thing is that every artery, like if you talk about your posterior cerebral artery or your anterior cerebral artery or your middle cerebral artery, everything, if to remember, you can remember this way, that everything is divided into M1, M2, P1, P2, and A1 and A2. Similarly, so in the what happens in the sylvian fissure, your MCA, it gets divided into two parts, that is the superior division and an inferior division. MCA superior division basically supplies the Broca's area, and inferior division supplies your Wernicke's area. So similarly, if your superior division is affected, you will have Broca's aphasia, and inferior division is affected, you will have your Wernicke's aphasia. So this was more of for MCA. Now here anterior cerebral artery, it has two components. One is the A1 and A2. What happens is A1. A1 is actually joining the anterior communicating artery with the internal carotid artery. Anterior communicating artery with the internal carotid artery. That is the A1 segment. Whatever is distal to the origin of anterior communicating artery, it is called as the A2 segment. Now, if both the segments, both A1 and A2, they arise from the single limb, then the patient would have profound abulia will be there, bilateral pyramidal signs will be there, patient will be deeply comatose, patient can have urinary incontinence, or patient can have bilateral paraparesis. Similarly, your posterior cerebral artery syndromes are divided into P1 and P2 syndrome. Now, P1 is basically is supplying the midbrain, subthalamus, and thalamic regions, and P2 is supplying P2 syndromes is P2 area is supplying the temporal and occipital lobe. So you will have the visual signs can be there, or your memory can be affected. Whereas P1, with the P1 syndrome, you can have your everything, your Weber syndrome or your Claudius syndrome, your subthalamus and thalamic region is affected. And very important is your lateral medullary syndrome. Most common artery involved is your vertebral artery, followed by posterior inferior cerebellar artery, that is the pica artery, which is involved. This is the circle of Willis, which everyone should know. And then the vertebral artery is divided into four parts. The four parts of vertebral artery are important. That is a V1 arises from its origin, and it transfers to fifth and sixth transverse foramen. V2 is the second part, which is basically it transverses from C6 to C2. V3 it arches around the C1 vertebrae and pierces the dura of foramen magnum. And the fourth segment will join the artery of the opposite side to form the basilar artery. So this was about the anatomy. We should know what all basically your MC artery is basically involved. Then you have contralateral hemiplegia, hemianesthesia, if the and hemianopia. And if your dominant lobe is involved, then you can have the aphasia. Or if the non-dominant lobe is involved, then you can have apraxias, constructional apraxias, or anastognosias. All these syndromes will be there. Now, this was about the basic symptomatology according to the artery involved. Now, how do you recognize these stroke patients in the pre-hospital setup? There are certain scales, certain stroke scales, which can be really helpful in a pre-hospital setup. Now, one of them is Cincinnati pre-hospital stroke scale. That is, everyone knows that is facial droop, arm drift, and slurring of speech. That is called as FAS. Okay. The other important scale is FAST ED scale. That is Field Assessment Stroke Triage for Emergency Destination, which includes, apart from your FAST, that is facial palsy, arm weakness, and speech changes, patient will you have to look for eye deviation as well as denial or neglect. Then the other one is the rapid arterial occlusion evaluation scale, which is facial. You look for facial palsy, arm motor impairment, leg motor impairment, head and gaze deviation, aphasia, and agnosia. Most important score is your NIHSS score. That is a stroke scale. It consists of 11 segments. It basically includes your wakefulness, your vision, motor and sensory and language component. Okay, the total score is 42. 0 means no stroke, 1 to 4 is minor stroke, 5 to 15 is moderate, 16 to 20 is moderately severe, and 21 to 42 is categorized as having severe stroke. And if a patient they say, if it is very important to know this score completely, and we should be regularly doing this score, NIHSS score, in the emergency department. It also helps us to decide whether the patient requires thrombolysis or a dual antiplatelet agent is required, whether it is a disabling score or a non-disabling score, whether one has to go for thrombolytic therapy or not. So prior to thrombolysis, this score is done. Another important score is most of the studies are using is modified ranking scale. So this is used to measure the degree of disability in patients who have had stroke. So most of the important trials have used this score as an end outcome, whether there was improvement in modified ranking scale or not. It is basically used to measure the disability in patients who have had stroke. So the maximum number is 6, and the 0 means no symptoms, and then you have the slight symptom as 1, slight disability as 2, like that goes on. Okay, now what is minor stroke? This is very, very important. One should know what is disabling score versus non-disabling score. Now, when there is complete hemianopia, that is more than 2 on NIHSS, severe aphasia more than 2 on NIHSS, visual or sensory extinction more than 1, any weakness limiting sustained effort against gravity more than equal to 2 score on NIHSS, inability to walk, any remaining deficits considered potentially disabling by the patient, family, or treating practitioner. So after doing the scoring, we should always try to rule out what are the differential diagnoses of a stroke patient. So the patient can have history of seizures. So the patient can present as torch paralysis. Then the patient can have hypoglycemia or hyperglycemia, migraine, syncope, meningitis, encephalitis, conversion disorder, structural mimics. Patient can have cerebral tumors, subdural hematoma, intraparenchymal bleed, or cerebral abscess. What about the initial management? So any patient being managed in emergency, we should always remember your airway, breathing, circulation, and disability and exposure, of course. So you have to assess your airway, breathing, circulation. How do you assess if a patient is able to communicate? That means your airway is secured. Then breathing, you check for the respiratory rate. You do a local examination if bilateral air entry is present or not. And circulation, you check for your blood pressure. If the oxygen, you have to give oxygen if your SpO2 is less than 94%. Accordingly, treat hypotension or hypertension, whichever is present. Blood sugar should be maintained between the range of 140 to 180 according to the American Stroke Association. Immediately send the patient for CT scan, and if thrombolysis is required or not, decide on that. This is the initial management of a patient or stroke. Now, what are your management goals? You have to activate the stroke team with immediately, start the brain imaging within 20 minutes, interpret brain imaging within 45 minutes, door to needle time is 60 minutes. So just remember these goals, and because quicker action is required in these patients. Now this is a CT scan which can look normal, but there are certain subtle signs of ischemia on CT scan which everyone should know. You may not get an apparent infarct on a CT scan within 24 hours or even 48 hours. The CT can appear normal, but you should be able to differentiate between normal and abnormal CT scan. So these are the subtle signs. You can have loss of insular ribbon sign, obscuration of lentiform nucleus, hyperdense arteries, loss of cortical gray white differentiation, hemispherical sulcal effacement. Okay, now this is very important score. This is called as aspect score. Aspect score is basically Alberta stroke program early CT score. This is measurement using household unit values when selecting patients for stroke thrombectomy. So you basically, it is for MCA territory infarct stroke. You divide the whole MCA territory into 6 zones, and you give 10 marks for each zone. So this is basically divided into your M1, M2, M3, M4, M5 and M6. So it can be basically, this is the frontal aspect, this is the temporal aspect, and like that the parietal aspect, and then M4 is basically superior to M1, M5 is superior to M2, and M6 is superior to M3. So this helps in selecting patients for stroke thrombectomy. This score is very important and everyone should know this. CT angiography and MR angiography is done for selecting patients to know which artery is basically involved. If it is to rule out large vessel the occlusion, and if you are going for thrombectomy or not. Okay. So if your internal carotid artery involved, or your PCA, or your MCA or ACA is involved, then you can actually suspect large vessel artery stroke, and then you can go for thrombectomy. So that is why CT angiography or MR angiography are done. Now, perfusion imaging is very important. Now, perfusion imaging, what is the role of perfusion imaging? It is basically contrast enhanced study to differentiate between salvageable brain tissue from the damaged infarcted brain. It is, again I repeat, it is basically to differentiate the salvageable ischemic brain tissue from the damaged infarcted brain. The core is defined as the pink one, and the penumbra is the green one. So this is the salvageable tissue, the green one, and the core is defined by the pink one. Now this is a diffusion weighted image, and this is a perfusion weighted image. MR diffusion weighted hyperintensity for earliest detection of infarct. You go for diffusion weighted image, and perfusion is basically whatever is the salvageable. It helps us to again to differentiate between the penumbra and non-salvageable tissue. This is a flare image, and this is the diffusion weighted image. Diffusion weighted image shows us the earliest sign of the hyperintensity suggestive of earliest sign of infarct, and flare is basically, it is nothing but like a T2 MRI image. So again, these are the image guided decisions. This is the diffusion weighted, this is flare, this is perfusion weighted, and this is MR angiography. Now, talking about systemic thrombolysis, these are the various landmarks trials which everyone should know at least the names, and which one was the most important, which gave us the direction as to which the thrombolytic agent we should be choosing. Systemic thrombolysis, as the history goes, streptokinase was used by ASK, MAST Italy, MAST Europe, MAST E trials. Then desmoteplase was used by DIAS 2 and DIAS 3. It failed. It was not recommended. Both these were not recommended in final version. Altiplase was finally used by NINS 2 and ECAS 3. NINS 2 trial was the landmark trial which showed benefit if altiplase was given within 3 hours of onset of stroke. ECAS 3 extended benefit up to 4.5 hours of onset was recommended. We all know the dose 0.9 mg per kg, 10% bolus, 90% infusion over 1 hour. Then the important one is the wake up trial. Wake up trial, when the last known well time is unknown, there is unknown onset of the patient of the stroke. And there is, you can go for diffusion weighted MRI versus flare. There is flare mismatch. That means your MRI flare image is normal and diffusion weighted image there is hyperintensity. Then you can go for thrombolysis. That shows that probably the stroke has the onset is within 4.5 hours, and you can go for thrombolytic therapy. Then another was done for extend trial. Extend trial was done, and it was further extended. The time was further extended between 4.5 to 9 hours. However, it did not show much benefit. So we still are following the wake ups to the results of wake up stroke trial only. Now this is a summary of all the basic trials. So NINS 2 was done, that recommended less than 3 hours thrombolytic therapy should be done. ECAS 3, it extended time for 3 to 4.5 hours. Wake up more than 4.5 hours, it can still be done if the last well-known time is not known. That means onset is unknown to us, and there is diffusion weighted imaging and flare mismatches there, then we should go for thrombolytic therapy. Now, these are the various contraindications of the systemic thrombolysis. I'm not going into detail again. The important part is if you're going for thrombolysis, according to the wake up stroke, when your onset of stroke is unknown and there is mismatch between diffusion weighted, MR diffusion weighted, as well as the flare image, then there are some indications and there are some contraindications which is different from the usual thrombolysis which you're doing within 3 hours. What are those contraindication? Number one, if your NIHSS score is less than 25, then only you're going for thrombolysis. If it is more than 25, you're not doing it. If age is more than 80 years, we are not doing it. If the patient has prior history of stroke, it is a contraindication. If the patient is diabetic, it is a contraindication. So these are few contraindications which are different for systemic thrombolysis, which we follow in patients for extended period where the onset is unknown for us. What is our target for blood pressure management? So if we are using a thrombolytic therapy, we are going, then the target should be less than 185 by 110 millimeters of mercury. And if you are not thrombolizing, then the target is more than 220 by 120 millimeters of mercury. These are the various common drugs. Most commonly used is labetalol. And you know that we have already spoken about tenecteplase is the most common drug which we are using. Altiplase versus tenecteplase. Altiplase, we already know the dose, 0.9 mg per kg. 0.25 mg per kg tenecteplase we are using. This is a dose. Now, what about the endovascular therapy? Intra-arterial thrombolysis. These are the common landmark trials, that is PROACT 2 trial, EMS trial. Now, mechanical thrombectomy recommended over intra-arterial thrombolysis. It may be considered within 6 hours if there is contraindication to altiplase, intra-arterial thrombolysis. Mechanical thrombectomy, the two landmark trials is DAWN trial and Diffuse 3 trial. Diffuse 3 trial recommended mechanical thrombectomy up to 16 hours. DAWN trial, it recommended between 6 to 24 hours. Now, this is a summary of Diffuse 3 and DAWN trial, which basically suggested that mechanical thrombectomy can be done between 6 to 24 hours by DAWN and 6 to 16 hours by Diffuse 3 trial. Antiplatelet agent, aspirin can be used is recommended within 24 to 48 hours. However, if you've given IV thrombolytic therapy, then aspirin should not be given within 24 hours. What is the role of dual antiplatelet agent? Dual antiplatelet agent If there is NIHSS score less than equal to 3, patients who are not receiving IV altiplase and there is high risk TIA, then dual antiplatelet agent can be given for 21 days as per the CHANCE trial. Now, this is the basic management algorithm which everyone should know. So, suppose a patient has come with signs and symptoms of a stroke, then we have to rule out hypoglycemia, immediately go inform the neurologist, immediately go for NCCT head, establish time of onset is very important, calculate your NIHSS score. Then again, you have to categorize the stroke according to the NIHS score as per disabling versus non-disabling. Consider divide the time of onset as 0 to 6, 6 to 24, and more than 24 hours. So if it is between 0 to 6 hours, disabling stroke is there, then consider giving RTPA if less than 4.5 hours. If yes, then you have to thrombolize. If no, then go for MRA, that is MR angiography or CT angiography, and decide if you can go for mechanical thrombectomy or not. And if the NIHS score is less than 3, and if you just see if the patient is eligible for dual antiplatelet therapy, it can be given for 21 days. And if you're not thrombolizing, eligibility for aspirin should be checked, and within 48 hours, where you should start your usual antiplatelet agent. Now, when to involve the neurosurgeon? When to involve the neurosurgeon? It says that malignant MCA infarct, decompressive hemicraniotomy was associated with better outcomes as per your Destiny, Decimal trials, and Hamlet trials. Destiny 2 trial, there is benefit in patients of more than 60 years. And there are certain controversies regarding the cardioembolic strokes. As per the AHA, according to the severity of the score, whether disabling versus non-disabling, there is no hurry to start the anticoagulation in cardioembolic stroke. In ED, you can always wait for 48 hours before starting anticoagulation. If the patient is having non-disabling stroke, if the patient is having disabling stroke, then we should wait for at least 14 days before starting anticoagulation. So this was the summary of my topic on stroke management and evaluation. I hope you've understood few points. Thank you so much.
Thank you, Dr. Nidhi. Now I open it for queries, questions, comments. It's early in the day. Nice to see Dr. Nidhi out here. Hello, Dr. Nidhi. Yeah.
Good morning,
Yeah.
ma'am. Thank you for the opportunity
Yeah.
to speak on this prestigious forum. I thank Dr. Ashima and Dr. Nachal Einstein for the opportunity. Thank you so much. Yes,
So,
ma'am.
sir.
Excellent presentation,
Thank you.
Professor
Thank you, sir.
Nidhi. So, one of my question is like hemicraniotomy. What is how many patients with Rankin score of like 0 to 3 when you do hemicraniectomy for malignant cerebral edema?
Sir, yes, sir. Sir, if the patient is having malignant infarct, and there is a midline shift of more than 7 mm, then our neurosurgeons and the GCS is on the better improving side. Then the neurosurgeons do take up the patient for hemicraniotomy, and this is as per the consent of the patient because the risk is always involved. And but then we should be encouraging our neurosurgeons and our young physicians to go for this procedure because it definitely has shown to improve the mortality rate in these patients.
I understand it improves the mortality, but I want to know whether it improves the ranking score. Like 0 to 3 is like they can be independent. Yeah, they can walk. 3 is like they can walk. But because
Hmm.
if somebody is vegetative state and they are like always in the bed and they are not knowing what is
Yes,
going on,
so that's what they do is usually we are not following those patients up to like most of the studies. The trials are like they've followed the patients at 30 days or something like that, and they've repeated the modified ranking scale. Now, most of the neurosurgeons they do, they see the GCS of the patient. If there is scope of improvement, if the patient is already GCS of 3, then they do not take up these patients, irrespective of the midline shift and the malignant infarct. But if the GCS, if there is scope of improvement and the GCS is on the improving side, then they take up these patients. And the lacunae as an emergency physician is that we are not following these patients in the ward. What happens after this? So I can't comment much on that, but definitely if the GCS is better, then only these patients are taken up.
thank you.
Thank you, sir.
So thank you. Thank you, Dr. Nidhi. Thank you for joining us. Please stay on the Zoom link. Please stay on the live.com. The link is already circulated in various groups. We have our next, we'll just let the We have our next speaker, Dr. Deepak Sharma, who is joining us from Guwahati, Assam. Sir is the head of department, professor and head of department of Government Medical College, Guwahati, Assam, and he has been running emergency medicine seats for quite a long time by now. Sir. He'll be talking. So have you given him the host? You have to give him, na? So your PPT is already there. Are you able to hear us? We are not. Can you just say hello so that we can see whether we are able to hear you?
Yeah.
Yeah. So we are able to hear you, please. Please start, sir.
Good morning, everyone. And thank you all, and thank you particularly for the organizing committee and Dr. Aeme ma'am for giving me this opportunity to talk in front of you in such a prestigious, audience. So I'll talk today on this early management of wound in ED. So basically, wounds are a very common presentation in ED, and it has been seen that there should be adequate knowledge as well as one should know how to evaluate and how to do an appropriate management of acute wounds that is necessary in ED. So a wound is a break in the, okay, next slide.
We are making you the host so that it becomes easy for you for changing the slides. Please, we have given you the host.
Oh yeah.
Yes, please.
How do I change it?
You can accept. They have just sent you. They have just made you the host. The technical team has just made you the host, sir. Sorry for interruption.
No, yeah.
Yes. Now, can you just see if you can change the slide from your side, sir? Okay. Okay, we can do it. So we'll do the
No,
next.
it's not going home yet.
Okay, no problem, sir. You just have to say next slide and we'll do that.
Yeah. So basically, a wound is a break in the skin's epithelial integrity and with disruption of possibly deeper tissues, including dermis, fossa, as well as muscle. And sometimes it goes up to the bone. So there are some principles in initial evaluation, particularly in ED. So it begins actually with the initial evaluation of the patient. That means overall assessment is very essential. And one must remember that the life-threatening injuries that they need care before you're treating the wound proper. So sometimes it may happen that the wound itself may be life-threatening. So in that case, one should be very careful to evaluate the wound, and if it is life-threatening, it should be treated first. So how will you care? How will you care a wound in a, emergency room? So next slide. So before evaluation, one should remove all the rings that are there in the body and circumferential injury, jewelries. So these should be removed beforehand because this may cause an obstruction, because when the edema develops and there will be some sort of, obstruction beyond that point of obstruction. And similarly, the clothing should be removed about the injured areas so that there is no infection later on. And also one will be very much comfortable to examine the wound properly because exposure will be good. So if there is an amputated finger or extremity, it should be wrapped in moist, sterile and protective dressing. So one should remember that they can be retransplanted in some cases where facilities are available. So they should be placed in waterproof bag and placed in a container of ice water for preservation and for future reattachment if it is possible. So next is how to, examination. So in history and physical examination, one should see for mechanism of injury, an initial treatment plan, as well as prior associated injuries, the medical, surgical and immunization history, the known medical allergies, as well as all injuries that are identified with appropriate prioritizations. So that once those who are prioritized, those who needs early management or early treatment, they should be considered accordingly. Then careful neurologic as well as vascular examination should be done beforehand, particularly the distal to the site of injury, because many injuries they may cause, either vascular or neurological damage beyond the point of injury. So there are different types of wounds. So basically, one is called bruise or contusion and hematoma. This type of wounds actually requires no specific treatment, bruise. But hematoma, if it is small, it resolves spontaneously. But if it is a larger one, then one should either, surgically drain it, or in some cases, you can use your white bone needle to drain it out. Abrasions and friction bones, then most abrasions are healed by epithelial lesion, so you do not have to do anything. And friction burns are treated similarly at the line of burn. Puncture wounds and bites. The puncture wounds are treated by wound irrigation because most of the time they may be infected or there may be dirt inside. So antibiotic treatment, that tetanus prophylaxis should be given according to the type of the wound. So at least all foreign bodies should be removed. And bites maybe is a combination of deep lesions and as well as crushing. So careful wound excision to avoid deep infection should be done. Similarly, laceration there should be done, surgical inspection should be done, there should be cleaning and closure. And if deep structures are damaged, so they must be repaired. And tractions and avulsions, they're causing deglobing injury. And in those cases, most areas of devitalized skin, as well as if you get it, you remove it. And at the same time, if it can be defatted, so fat areas should be removed so that it can be used as a full thickness skin graft later on when it is necessary. So avulsion injuries actually have hands or feet may require immediate flap replacement. So this cannot be done by an ED. So this should be referred to the proper department, either the surgical department or according to some that is the plastic surgery department. The crush injuries are a variant of blunt injury and often accompanied by deglobing injuries as well as a compartment syndrome. So one must be very careful that compartment syndromes are very dangerous, situation. So in those cases, if necessary, a physio to be done immediately and should be done by ED physician if no surgeon is available nearby. So the prolonged crush injury needs careful handling to avoid causing renal failure. Now, next slide. So next, I have shown some of the, this type of injuries, the different types of wound that are here as shown in the picture. So previous slide, please. Previous slide. So that we can get some idea that these are the different sorts of wounds that type of wounds that we see easily in ED. Next slide. So there are, it can be again called as simple, complex, and complicated wounds. A simple wound is involved, particularly subcutaneous tissue. So in simple wounds, there are no damage to the underlying tissues or associated complication is there. A complex wound is associated with a significant tissue loss. There is significant tissue loss, as well as there is devitalized tissues are there, and which communicates sometimes with viscera and sometimes with your body cavities, sometimes with joints, and sometimes it or prosthesis, and it has associated injuries or paths which are leading to vital structures. So these are actually a complex ones. And complicated ones are actually, these are when there's an infection, there's an ischemia, flap necrosis, hematoma, and compartment syndrome. These are termed as complicated wounds. Next slide. So surgical wound classification may be again done in a different way. That is, we call it clean, contaminated, as well as deeply infected. So these are, it will depend on the type. So this is a surgical wound classification. So actually, next slide, please. Next slide, please. So the most of the ED presentation will fall within the clean contaminated or contaminated wounds. The clean or clean contaminated wounds should be actually closed by primary closure intention, but which clean contaminated sometimes it may be necessary to irrigate the wound as well as takes proper precautions so that there is no existing infection prior to the closure. The contaminated dirty wounds should be done by irrigation, debridement, and formal closure in the procedure room or the theater. The classifications of wounds, there is another type of classification which is known as your tidy wounds or untidy wounds. So tidy wounds are actually, it is very easy to find out that they are actually caused by the sharp instruments that contains contains no devitalized. So there is no devitalized in, your tidy wounds, and more or less they are, cut wounds, and their skin wounds are usually single. The tendons and arteries, if they are injured also, they are not, not severely damaged. So, but on the other hand, if it untidy wounds, that you will see that there will be from crushing wound, that as I told you, tearing, avulsion, and muscular injuries to burns, these are actually untidy wounds. Most of the untidy wounds may have contaminated or devitalized tissues. The tendons, arteries, and nerves may be exposed, but it is not necessary that they will be always divided. So this is common, particularly usually in, if there is fracture. Fracture is not found in case of your tidy wounds, but usually if fracture is found in non-tidy wounds, or that is your untidy wounds, in those cases sometimes you'll get multiple fractures. So if it is there, that our idea is to find out in the treatment, our idea is to make untidy wounds to tidy wounds so that we can easily repair them. So next is your how to make them. So next is an important part, that is your wound excision or wound toilet or debridement. So for this, we need some anesthesia in some cases. So this anesthesia is local anesthesia is used, and mostly to relieve the pain and anxiety, as well as to give to give assistance to the surgeon or the ED physician to do it properly. So lidocaine uses, xylocaine is most commonly used as, and it's a fast technique. It's 1 to 2 minutes time it takes, and the dosage is 1%. And it's a lidocaine, which can be used 10 milligram per ml per kg. So what actually the dose is 3 milligram per kg without adrenaline, and 7 milligram per kg with adrenaline. So that is a total weight. So adrenaline used to prolong anesthetic effect of lidocaine. So here what happens, the risk of arterial inhibition is always there. So if it happens, there will be toxicity. So one must do what to do. One must aspirate it beforehand so that no blood comes before pushing the injection. Before pushing the injection, no blood comes to the needle, to the, your syringe. So one should shake it so it is not going to a vessel. Next is wound cleansing. So wound cleansing is a very important part. So it just means that you get toileting to flush out the dirt particles. So dirt particles. So it helps in to assess the anatomical extent as well as the determine associated injury in the underlying process. So wound cleansing should be done best irrigated with warm saline. So ringer lectin can also be used with a pressure of 8 to 15 psi. So it can be used by using a needle which is almost your 18 or 19 gauge IV catheter or needle, which can be about 35 to 60, ml of syringe. So if you give a pressure with that, you will get almost 8 to 15 psi. So if you want to give more than that pressure, so one can use battery powered irrigation system. So this is helpful, particularly when you need a sufficient amount of irrigation fluid to wash out that particular wound. So abrasion, if you get during the process of this, so this be scrubbed properly. So because sometimes small dirt particles may be there inside those areas. So this must be clean. So next is your after wound cleansing, one should do proper hemostasis. So there are different methods of hemostasis. The most common hemostasis that particularly if it is not very profuse and so we can do it, give a direct pressure over that area. You can use it or either a pad or with a gauze piece, whatever it may be, according to need. So sometimes you can do elevation of the limb too. So minimize the bleeding. So one can use a tourniquet. And in ED, sometimes we use, most of the time, not sometimes, most of the time we use blood pressure cuff to control the bleeding. And if it's available there, you can use electrocautery, you can use suture ligation, and you can use also hemostatic clamps. But when one is using the hemostatic clamp, he must be very careful in the sense he must have some anatomical knowledge of that particular area. Because once if he does that, and if some vital structure which are nearby the wound may be damaged. So instead of suppose holding that particular bleeding point, if he holds some artery or some vital structure, it will be more disastrous. So it must be done by a person who is very much, anatomically aware of that particular situation. So next is your exploration. So in exploration, what we do, we should be exposed carefully for foreign bodies. Sometimes the foreign body may lie in the deep, and so in that cases, you'll have to see the extent of the injury. Unless you expose it properly, the injury may seem very small one from outside, but it may be a deeper one, or it may go to a deeper extent also. So similarly, you'll have to see whether there is any foreign body anywhere lying deep inside. This should be also be removed. And you'll have to take multiple X-ray views. So it may be useful in locating the radio opaque, FBs inside it. But there are some situations that are very difficult to locate in a foreign body, difficult to locate a foreign body. In those cases, there are multiple foreign bodies. In those cases, it must be done in an operation theater. So it will be easier because you can take help of the anesthetist also to see if there is any underlying deep foreign body. Next is called your debridement. So debridement is a very important part, particularly for traumatic breaks of the skin. When you see there are irregular skin areas, you can trim them, you can make them finer, and surrounding zone of skin, which are and tissues which are under impact, they are not very properly seen. So in those cases, you need judicious sharp debridement. And all foreign bodies should be removed during the point of debridement. So when you do a debridement, it should be done in a particularly in a fashion manner or in a particular manner. Suppose you start from one area, then you go to another area, and ideally it should be gone from superficial structures to deep structures. There are many methods of doing it, but the idea is so that no area is left behind during the debridement. So basic idea of debridement is all devitalized tissues should be removed. And particularly if you suspect this area is either whether it is viable or not viable, it is better to remove it and see whether there is a fresh oozing from that particular area. So our idea is that we do not leave any devitalized tissue over there, which may be a source of infection later on. And it will also hamper the healing. So in those cases, blood vessels, nerves, and tendons, if you identify, you leave them just as such, and expose in the cellular writing. The idea is to go like clean wound, which is having a skin margin, but this skin margin is bleeding. It's not dead skin margin, bleeding skin margin. So there will be some amount, maybe small oozing from that area, and it overlies the healthy tissues. So debridement is very important, particularly for infected wounds. Then wound closure. So there are many factors. Want to do wound closure. So one is your amount of contamination. If there is huge contamination, heavy contamination, it is better not to do a closure. And it also depends on the amount of time that wound is has occurred. So what is the that period? Particularly when the wound is more than 6 to 8 hours, it should not be closed. So there are some other wounds that should not be closed, like human bites. Then wounds that with gross infection, possibly exception is the facial wounds, because facial wounds have a very good arterial supply. Then you can see the puncture wounds and more than 10,000 bacteria per gram tissue. If you have any microbiological, evidence that there are more than 10,000, bacteria per gram tissue, so it should not be closed. So how do you close? There are different types of closure. So one closure is, as you know, is a primary closure. One is called delayed primary closure, and another is called secondary closure. So primary closure is done for those clean cut wounds when there is no infection, particularly when you do an operative wound, like if there is a cut by a glass or by something like that, clean cut wounds, they can be immediately, close it. So this is actually healed by epithelial lesion. But there is one more point, that when you suspect that there is a possibility of infection and which can be controlled within a short period of time, within 48 hours. Sometimes we do a delayed closure. During this period, we keep the wound open and do irrigate, do all care of wound closure. And if you find that it is okay, it is non-infectious after 24 to 48 hours, you can close it. This is a delayed primary closure. If there is infection, if suspect that infection is still there, it should not be closed. Then it should be allowed to heal by secondary intention. So in secondary intention, the idea is to heal the wound by granulation tissue. So in those cases, you do not have to do immediately the closure. The closure will be done later on closure will be done by nature itself. So there is a possibility of a contraction also in this particular situation. So what are different methods of closure? So as we know that there are different methods of closure, and particularly we'll speak about what the closure that are made in ED, because there are many other types of closure, by closure of skin, flap, etc. So this is not necessary for ED person. So most commonly you use a suture, the surgical staples, the skin closure tabs, and adhesive. These are most commonly used, but mostly we use surgical sutures. Next is your suturing techniques. So there are different sorts of suturing techniques. These are actually different or simple interrupted suture. This is most commonly done, because, and particularly when they suspect that there is a possibility of infection, it is better to give an interrupted suture, or you can use a continuous suture also. A continuous suture should not be given if you suspect there is infection. Otherwise, in clean cut wound, sometimes you can give a continuous type of suture. This continuous type of suture usually takes less amount of time. So this is useful if you are in a hurry. But there are other types also, that continuous suturing may be sutured, or they may be locked, or may be unlocked. So there are different types of mattress suture also. This mattress suturing is maybe a vertical mattress suture or a horizontal mattress suture. So next slide. So these are different photographs, different methods of suture techniques. Those suture techniques should be taught to the ED physician, particularly if skill lab is available. It is very much easier, but sometimes if skill lab is not available, it can be done in the ED itself under guidance of a senior surgeon or senior ED physician. So one must be very comfortable, particularly in suturing, because in ED it is almost necessary, so that if you suture the closure at the earliest, particularly if it is a clean wound, so it will be easier for a person following up the particular patient in ED, that infection, chance of infection will raise. The next slide, please. So next one is our tetanus prophylaxis. So risk of tetanus is there in all cases, almost all cases, particularly in traumatic wounds, and one must be very careful to find out the tetanus history. So anti-tetanus, whether prophylaxis has been given during beforehand, and it to be counted also, and accordingly let us choose a prophylaxis. But risk of tetanus is more in few situations, like wounds more than 6 hours old, then your contused or abraded wounds, then wounds more than 1 centimeter in depth, then significantly contaminated wounds, then wounds with denervated and as well as in ischemic tissue. So in these cases, the tetanus prophylaxis should be always there. Then wounds due to burn or cold, which we are not discussing in here, they also need tetanus prophylaxis. Similarly, high velocity wounds, they also need similar type of prophylaxis. So next is whether we should give antibiotic or not. So this is again a question of debate. So particularly prophylaxis. The routine from antibiotic prophylaxis, some people say this is for small disease, have no scientific basis. But particularly in clean wound, but still some people want to give it, so that they want to prevent infection, in the sense that prophylaxis will help it. Next one is one must remember that if it is infected wound, or it is a wound which is open more than 6 to 8 hours, in those cases it is not an alternative. Antibiotic is not an alternative for healing. The most important part is there is a good wound debridement, cleansing, debridement, and then, as I told you earlier, so other methods. It is not, antibiotic cannot be an alternative. Only antibiotic can be a supplement. But there are some situations where indications of, prophylaxis prophylactic indications of antibiotic are there. They are actually uncompromised and immunocompromised patients, that patients with prosthetic valves and other permanent implanted prosthesis, presence of intestinal and genitourinary infection, an infection that is likely to develop, or any infection if develops, if may cause partially disastrous consequences. And therapeutic antibiotics will be given if one is there is a culture. If you get a culture, positive, and accordingly you should get it. And that's why antibiotic should be used judiciously. So, in brief, this is a short, brief discussion on, wounds that are presented in AD. Thank you, everyone.
Thank you so much, sir. We are running a little short of time, and we'll be posting questions on the Zoom link chat box for the students who would like to ask sir on this. Thank you, sir. And
Thank you,
thank you
everyone.
so much. And there is one more talk. The room has warmed up to many participants. So we have Dr. Nand Maruju, sir, who is the head of Department of Emergency Medicine at Jipmer, Pondicherry. Sir is has scheduled, his mom got operated, and still he's come online with us to deliver his talk. I request all of you to let us hear him first, and then we'll continue with our sessions. Kindly, please, we'll go ahead and we'll be taking Sir's talk first. Dr. Nanda, are you able to hear me? Okay, we can run his talk. He is there. He is there. In the meantime,
I'm here very much.
Yeah,
I'm here very
thank
much.
you. Thank you so much.
Thank you so
Yes, we are
Yes.
running your talk, sir.
Yes, ma'am. Please
Thank
go
you.
ahead.
Okay, sir, just a minute, sir. We'll be. Sir, do you have your talk with you, sir? It is there.
Well, no, I don't have it. I'm at a different
Okay,
place. I'm not
yes,
prepared
yes.
to talk straight away.
Yes.
Is it not playing?
Okay. We have some delay in sorry, sir. We have some delay in the system for finding the talk. We'll do that. Uh,
Yeah. Maybe you could go ahead with the next
yes,
item
sir.
on the agenda and
Yes,
then come
sir.
back to this.
Yes, sir. Yes, sir. So,
Thank you.
Dr.
Yeah.
Sanjay, sir, I'm so sorry, very sorry, but we start with our the program for today, and we have program sheet is here. So we have Dr. We have it? Yes. Okay, done.
Good day to all of you, and I'm sure you're having a great time at this splendid conference. At the outset, I thank the AEME leadership for creating such a wonderful platform and for inviting me to the same. I have managed abdominal trauma for more than 20 years, starting from the days of the traditional casualty, and now I'm managing them through a more modern emergency department. And I think that qualifies me to stand here and talk on this topic. So let us get started. The pertinent point to note in trauma is the changing role of surgery in managing the injured patient. There was a time when there was no surgery performed for trauma patients more than 100 years ago. With the world wars, surgery became almost a routine for every injured patient. And subsequently, as questions were raised whether surgery was required in all, that saw the increasing adoption of non-operative management in many cases. And in that scenario, the importance of initial assessment and management becomes much more significant. Broadly, we talk of blunt and penetrating abdominal trauma. Overall, blunt trauma is much more common than penetrating trauma, among which you have stab and gunshot wounds, and gunshot wounds are the least common. However, gunshot wounds happen to be the most fatal, as well as the ones which require maximum intervention in terms of surgery. In this presentation, I will focus on stab wounds for the sake of brevity and clarity. In the assessment of an injured patient, we must pay attention to a few important zones. The thoracoabdominal zone extends down from the nipple line to the costal margin, while the abdominal zone lies inferior to it. The thoracoabdominal zone is important because injuries here could involve the thorax or the abdomen in almost equal measure, and one has to be careful not to miss them. Flank is the space between the costal margin and the iliac crest, in between the two axillary lines, the anterior and the posterior axillary line. The structures at risk are determined based on whether the wound is in the anterior or the posterior part of the torso. For anteriorly placed wounds, you have intestines, great vessels, diaphragm, mesentery, spleen, liver, kidney, pancreas, gallbladder, adrenals. These are the ones which get injured. More specifically, for posteriorly placed injuries, colon, kidneys, duodenum, aorta, IVC, you'll notice that these are predominantly retroperitoneal injury structures that are involved. This information will help us estimate what are the likely injuries that a given patient with a stab wound may have. In seeing a patient with trauma, there are a few questions that we need to ask. What was the instrument that was used? The injury inflicted depends on the weapon used, the type of weapon used. Also, the dimension of the weapon will give an idea as to how deep the cut was. The position of the victim and the assailant, and the path traversed by the instrument add to the idea that one can construct when getting the history from a patient. Another very important information is to know what was the amount of blood loss at the site of the injury. A significant blood loss is an indicator of grave vascular injury. When it comes to assessment of these patients, I cannot overemphasize that the ATLS approach to trauma management is as good for penetrating abdominal trauma as it is for anything else. And therefore, we always need to start with the ABCDs. Beyond that, it is important to completely undress the patient. Stab wounds camouflage themselves quite easily, and one really needs to search the creases and corners to look at all. Sometimes the most obvious wound may be a harmless one, while a more life-threatening wound would be lurking in an unsuspecting corner. Therefore, assume all patients have multiple stab wounds unless otherwise proven. Now, one of the principal reasons why we assess initially is to identify indications for immediate laparotomy. Broadly, the indications for initial laparotomy are a hemodynamically unstable patient, obvious peritonitis, impalement, evisceration, blood on the nasogastric tube, or rectal examination. Presence of these factors is a straight signal to you to ship the patient to the OR, except in a few cases where the patient is in extremis or too sick to be shifted, and there could be a role for resuscitative thoracotomy or Rebova to stem incessant bleeding. If there are no immediate indications for laparotomy, that is, once the patient has passed the test for immediate laparotomy and is deemed not to have any of those indications, that is where the role for further evaluation lies in. The tools that are commonly used are the following, and I'll quickly take you through each one of them. You have physical examination, that is serial physical examination, local wound exploration, plain radiograph, ultrasonography, computed tomography, DPL, and laparoscopy. Serial physical examination is a safe and reliable means to detect significant intra-abdominal injuries after stab wounds to the abdomen, if performed by an experienced clinician on appropriate patients. Now, there's no reason why each one of us cannot train ourselves to be that experienced clinician. It's important to conduct a thorough zone-wise examination and also to do a thorough examination of the neurovascular system of the lower extremities as a clue to what could have happened in the abdomen. However, serial physical examination may be unreliable in patients who have head injuries or spinal cord injuries, who have altered mental status, for example, intoxication or the need for general anesthesia. Local wound exploration is another nifty tool that one can use. The premise of local wound exploration is to identify peritoneal breach as an indicator of a potential need for observation, if not laparotomy. What is performed is after the infiltration, the wound is explored to see whether the anterior rectus sheath is breached, and that could indicate the peritoneum is breached as well. The limitations to local wound exploration are a lack of expertise if you're not confident doing it, or you have a very obese patient with us. Plain radiographs have very little utility in assessing these patients, mainly because at most you could get free intraperitoneal air, and the significance of that is not great. It could be just the plunging knife into the peritoneum that could push in air, not necessarily a visceral injury. However, they're very useful in locating foreign bodies, maybe a broken blade or a bullet in the body. Ultrasonography, and talking about ultrasonography to this audience is like preaching to the converted. To summarize, it is extremely useful in ruling out thoracic or abdominal injuries, especially when the injury happens to be in the thoraco-abdominal area. You could quickly have a look at the chest or as well as the abdomen and identify if there's an injury. It's also useful as a preliminary investigation to other investigations. It gives you a pathway as to what is the next investigation that you need to choose. A CT is perhaps the best friend of a surgeon as well as an ED physician. It provides excellent anatomic information, especially in establishing a visceral or vascular injury. It is an important tool to decide conclusively in favor of non-operative management, and some may have even gone as far as called it a gold standard. But my concern is that overuse of CT is a problem, and careful physical examination will help us in rationalizing this extremely useful investigation. A word of caution that a negative CT does not necessarily rule out visceral injury, and I personally have opened a few abdomens about a day or two later following an apparently normal CT. So a negative CT in the presence of doubtful physical findings should be taken with a pinch of salt. I'm mentioning DPL and laparoscopy mainly for completion's sake, and that application in current day management is very limited. There is very little expertise for DPL. Those of us who trained in the pre-CT era would routinely do DPLs, but after the advent of ultrasound and CT, the role of DPL is markedly reduced. Laparoscopy is performed in dedicated centers, but you must note that it does require general anesthesia. So whether you should do it straight away or reserve it for certain cases is a question. So using the tools that we have learned, let us build an algorithm for penetrating abdominal traumas. We have a patient with penetrating abdominal trauma. We first do the ABCDEs. We initiate resuscitation. And the question that we ask is, are there indications for laparotomy? If the indications for laparotomy are present, hemodynamically unstable patient, obvious peritonitis, impalement, evisceration, blood on nasogastric tube or rectal examination, then the patient is a candidate for urgent resuscitative laparotomy. If these are absent, the next step is to look for peritoneal penetration. We do local wound exploration and or FAST. If peritoneal breach is present, then the choice is between a laparotomy or non-operative management with adjuncts, and that is a purely clinical decision. If a peritoneal breach is absent, then the patient becomes a candidate for safe discharge. A quick look at the management options. One is, of course, laparotomy in those where it is clearly indicated or where you have a strong doubt as to what's happening inside the abdomen. Second is selective non-operative management. The problem with selective non-operative management is it's not suitable in all kinds of centers, mainly because you are going to conserve a patient with the idea that you can operate on this patient as and when required, which means you've got to be ready all the time. And therefore, this is ideally done in a facility that has continuous monitoring ability, has 24/7 operating rooms, anesthetists and surgeons, preferably interventional radiologists available on call, and has reliable blood banking so that large volumes of blood can be transfused at short notice. You notice that the resources required for non-operative management are definitely much more than what you need for a laparotomy. So if you're working in a small center where you don't have these facilities and you have nowhere to go, a laparotomy may be a easier and safer alternative. To summarize, the key questions that you need to ask will help us in estimating the damage. A thorough physical examination is very, very essential in deciding the future course of management and often may be the only thing that you need to do. We need to identify patients requiring immediate laparotomy, and for the rest, we have tools available which will help us decide whether the patient requires further observation, potential laparotomy, or a discharge. Non-operative management is the mainstay in almost 80% of stab wounds. So that's all from me. Thank you very much for your patient listening.
Thank you, sir. This was good and a crisp presentation on the management of abdominal trauma. The students are here. Anyone having questions? Yes, Dr. Sandeep, please.
Yeah, I'm happy to take questions.
Yes.
Good morning, sir. Can you hear me?
Yes, I can hear you loud and clear.
So
Go ahead.
my name is Dr. Sandeep. I work in CMC Vellore. It's a very nice talk. So I think a lot of ED residents especially would benefit from the fact that there are surgeons who are very proactive in managing a penetrating trauma. You mentioned something about REBOA, sir, in cases of penetrating trauma, an unstable patient. What is your experience with that in your center, sir? Has it been done?
We have not done REBOA using the standard kit. So we do borrow catheters from cardiology, from the cardiothoracic surgery,
The IABP
cardiology
pumps,
unit.
yes.
Yeah. Can you hear me?
I can hear you, yes, please, go.
Yeah. So very, very little, because what happens is we have a quick surgical shift in the system that we work in. And I think we have an emergency physician who is trained in performing REBOA, one of our faculty members. And when he's on the floor, we've had an opportunity to perform, but we've not gone to the point that we are saying we can confidently train our residents in REBOA right now. We're very, very early in REBOA. I don't know if there are members in the audience who have done this much more frequently, and maybe they can add to what I'm saying.
Is that safe for high thoracolumbar injuries though, sir? Because without fluoroscopy, it's very difficult to know if you're going.
In the ED, no, I don't think so. Yeah. In the ED for very lower injuries maybe, but beyond that you would require further instrumentation.
That was my doubt, sir.
Further
thank
imaging.
You. Yeah, thank you,
yes.
Sir.
Yeah, I wouldn't recommend this routinely. It's something that requires a high level of experience and expertise before you start. I mean, I don't know if somebody has seen the Good Doctor episode where the doctor just does a REBOA with a catheter in the ED. It looks nice on TV, but in reality, it's very messy and very, very difficult.
Thank you, sir. Thank you so much for joining, and thank you for being there with us.
I really appreciate it.
Thank you, sir.
Thank you.
So we move to our next sessions, which will be our sessions for the day. They were sessions on neurology. Dr. Nidhi has already talked with us on the virtual platform in the morning. So we now move to Dr. Venu Gopal, sir. Sir needs no introduction, but sir, yeah.
Good morning. So today I am starting with this first session in the neurology, dangerous headaches presentation in emergency department. Maybe emergency department we cannot work at least like 1 or 2 cases every day. So it is the 4th common ED presentation in ED generally. But what is want to do, sometimes this headache going to be a headache for the treating physician. So what is important in headache is to identify the patients are at risk for deterioration and for morbidity and morbidity, and also focus the high risk headaches and provide appropriate treatment. Definitely, sometimes the stable patients will create more problem that you have to manage other way. But don't miss it, the dangerous headaches in between. Definitely for that matter, you need a focused history, clinical examination, particularly, and also like the rightly taken decisions, that is more important. And when you just go through our books and all, these headaches are related to the organs in the head, like it can be CNS vessels and vessels, but definitely more the dangerous one is included that we know, like the critical diagnosis is always here with the SIH, carotidization, venous thrombosis. Definitely other few things are coming as the emergent diagnosis. And also, sometimes we will forget about that metabolic causes or the toxins, the carbon monoxide sometimes may cause problem, and also like temporal arteritis. These are coming that serious diagnosis, critical diagnosis. Think about, don't forget about the eye. Definitely, infectious causes like meningitis and encephalitis are the dangerous causes. Others, fine. Also, we have to think about. So history is, I think, the most important because many of the things you have to evolve from the history. We should not forget because always try to answer the questions like how did the pain started? Is it a gradual or it is a sudden? How long it has been there? Then what time of the day it is present and when it is worse? And what are you doing when the pain begin? And what does the pain feel like? And where is the pain, and does it make better or worse now this time, and what medication you taken, and you have to what is the pain score, what is the pain, was the different from what the previous one, like that. This it is to get a correct diagnosis, history is very important. So definitely we are very well versed with PQRS T in ECG. Similarly, pain also you must analyze with PQRS T. For the EC, remember first residence and all. P it is in the progress, presentation, progression, precipitating, like that, and also palliative. Q, you assess the quality of the pain, what kind of pain, what type of pain, or relieving factors, and just radiate the pain to somewhere else. Then yes, assess the site and severity. T is treatment, and is temporal pattern. Also specifically ask that thunderclap. That is something, a big clue where to which direction we will move out. So as usual, as with the ED people, we will do the primary. So every point we have the clues, the diagnosis. Our ABCD is the primary survey and do the vitals. All these diagnoses will give some clues in the primary survey, some clues in the vitals, deviation of the vitals, and definitely do that sample history, particularly the anticoagulant history. All this will give us clue. And starting from the head, from the pupil, face, neck, everywhere there are some clues are sitting there. To consolidate that, do the essential labs, and this I am just queuing up because not going to the minor details. Just I am taking the tips of these things. So this is our approach. Naturally, this will end up into differentials, and finally will the management and will the dispose. These are all our ED people are doing. This is the way we are approaching. So maybe the headache CT is coming in one of the predominant role. But you know, like CT is particularly is helpful in acute intracranial bleeds, raised ICPs and hydrocephalus. And this is CT is more important in first 24 hours, and after 24 hours, its role will be gradually declining. And headache and immunocompromised patients like HIV inspection, maybe like the contra CT will be helpful, particularly to diagnose the toxoplasmosis. And definitely the CT will help us to diagnose SAH, particularly in the first 24 hours. Here you can see that the toxoplasmosis, you can see in the contrast CT. MRI, definitely MRI has got a high sensitivity than CT for detecting CT after 24 hours. And also MRI is very useful for detecting the non-hemorrhagic strokes, and also like particularly MRI is superior over the CT in visualizing posterior fossa tumor lesions, localizing the tumors, focal infections. Again, identify the cavernous sinus thrombosis, carotid artery dissection, etc. SAH, definitely, when you an LP, xanthochromia, previously people are very new, I don't know if, not so frequent, but it is something very useful. Sometimes you are in an undifferentiated one. Now, I am just go through that few red flags. That is more important for an emergency doctor. There are many headaches will come, and who is going to be dangerous and going to what are the red flags in the headaches in the ED setting? This is like looking at onset. The red flags in the onset: a sudden onset, following a trauma, and following an exertion. These are red flags, something dangerous inside. Taking the symptoms, and headache with altered mental status, headache with seizure, fever, neurological symptoms, and visual changes. Again, it is dangerous. We cannot leave him in the corner of the ED. We have to look into aggressively. Certain medications. Medications, particularly patients with anticoagulant, antiplatelets, recent antibiotic use, immunosuppressants. If this is there, yes, red flags. Taking the past medical or surgical history. Particularly, there is no prior headache, but there is a change in the quality of the headache now, and a headache which is progressive and worsening over the last months and weeks. This again, careful. Again, the associate conditions, dangerous, the red flags, particularly headache with pregnancy, post-emergency status like an SLE, then certain diseases like vasculitis, sarcoidosis, cancers. This all keep in mind, sometimes going to be, maybe that's meds and other things. Taking the physical examination, again, yes, headache with altered mental status, fever, neck stiffness, papilledema, focal neurological signs, red flags. So next, I will go to this is something, thunderclap headache. If this is there, definitely a danger inside. Again, what are the causes for the thunderclap? Immediately something coming into our mind is SH. It's not only SH, few other causes also will present with thunderclap. So the causes, we will, hemorrhagic causes like intracranial hemorrhage, sentinel aneurysmal hemorrhage, again a spontaneous intracranial hemorrhage. This is all mainly, it's like the hemorrhage is concerned. Again, the other, sometimes there will be vascular causes also there for the thunderclap headache. These include carotid or vertebrobasilar dissection, reversible cerebral vasoconstriction syndrome, then cerebral venous thrombosis, posterior reversible encephalopathy syndrome. These are the things you have to keep in mind. And few other group like the others, a mixture of many things, which include that coital headache associated with Valsalva, spontaneous intracranial hypertension, and acute hydrocephalus, pituitary apoplexy, acute angle closure glaucoma. This also, all these will cause a thunderclap headaches. Next one, like again some clinical clue. It's a cardinal presentation in the ED and how we derive that differentials. Particularly coming a patient with a sudden onset of headache, and it is associated with a thunderclap, a decreased mentation, positive focal neurological finding, or many meningeal signs of irritation, intractable pain, where our possibilities can be SAH, this dissection, cerebral thrombosis, or angle glaucoma. Similarly, sudden onset with recurrent thunderclap or stroke-like symptoms. If this is there, we have to think about reversible cerebral vasoconstriction syndrome. And a worst headache in my life. Somebody, this is the worst headache I have felt in my life. If so, and this is a sudden onset, then definitely SAH, cervical artery dissection, cerebral venous thrombosis. This way you have to sort it out. Sometimes a near syncope or a syncope with a sudden onset of headache. Definitely, again, think about SAH, cervical artery dissection, and cerebral artery thrombosis. Sometimes patient with increased jaw pain and headache. Here it is associated with a clicking, snapping, or pain movement with the jaw movement. Definitely, these TMJ diseases. Again, a facial pain with the fulminant pain on the forehead area or the maxillary sinuses or the nasal congestion. It is mainly a sinus pressure or a dental infection. And the jaw pain, but it is with the forehead temporal area pain with temporal artery tenderness, temporal arteritis. Again, periorbital or retroorbital pain with a sudden onset definitely two things we have to think about: temporal arteritis or acute ankle glaucoma. So sometimes, like in SAH, the Ottawa subarachnoid rule will be help us. This is useful those patients with over 15 years with a non-traumatic headache and with an intensity of once it is 1 hour. Definitely it cannot be cannot be applicable with new neurological deficit, prior aneurysm, prior SAH, non-intracranial mass, or the chronic recurrent headaches. So these are 6 components will be there in the Ottawa route. These are very familiar, nothing new, but this will be in ED when we are working with, it will be very useful when taking decisions and all. Patients with, if the patient is more than 40, neck pain or stiffness, weakness, loss of consciousness, headache, onset during exertion, thunderclap, limited neck flexion. If this is not there, SAHS is ruled out. Or if something is there, SAH should be in our diagnosis. Similarly, if you this Hunt and Hess grading will be help us, particularly to define or to tell the patient the morbidity, and particularly patients with grade 3, 4, and 5. You know, like a grade 5 and 77% mortality. And with this small presentation, I'll conclude with it from few take-home points. Like, SAA should be considered in patients who present with the first or worst headache in their life. And also, SAH and meningitis must be considered when a change in the character, location, or intensity of pain during the presentation. On examination of both eyes should be always be performed patients with a headache, because sometimes it is an acute angle glaucoma. A patient with idiopathic intracranial hypertension, usually they are belonging to young, overweight, with acne, and a fundoscopic examination typically give the papillary edema picture. And a normal CT and an elevated open pressure in the LP is confirmed this diagnosis. So, a papillary edema with a normal CT, but elevating pressure during opening pressure in the LP will confirm the diagnosis. Another thing, like, the carbon dioxide poisoning should be considered in headache with the nausea and vomiting, especially many members in the family. Like we have carbon dioxide poisoning in Nepal. All of them are brought in ED with, as a dead body. So like that, particularly the cars and the warmers, heaters is all bit dangerous. And giant cell arteritis to be considered in elderly presenting with unilateral headaches. Another thing, CT scanners are always 100% sensitive for detection of SAH. And so a negative CT must be followed by a negative LP for ruling out this diagnosis. So thank you for your patience.
Thank you, sir, for your excellent presentation. My question is, like, if a patient comes with a headache, like 10 hours, 12 hours, sudden onset, do you do the CT scan? The patient is like 30 years old.
What is the age?
30.
30.
Doesn't have neck stiffness, but he had a sudden onset of headache.
Sudden onset, it is a safe side, go for the CT. Nowadays, otherwise, but a sudden onset, severe headache, something, it is, as you described, is something like a thunderclap. Something dangerous will be. One point I want to tell most of the like EG doctors, sometimes like every time there will be a headache presentation in the ED. But in fact, that ED doctor's role, suppose an already diagnosed migraine is not to re-diagnose the migraine. We have to look into that any danger is in the head. Is there any danger lying in the head, particularly the blade, rule out a blade. Otherwise, sometimes we'll be true. Sometimes we observe the patient may deteriorate. We have like that kind of issues. When like a big leader, he's in Calicut, he's collapsed in the railway station, Plus, like, he is just unconscious in the railway station. People brought to one hospital. They saw some symptoms of like quick headache, but they totally missed the bleed. And they, in fact, that they give some heparin also. Finally, that hematoma is developed, and maybe they may think about the shock because the CT role is because maybe that is the doorstep. Without this, you cannot go this direction or that direction. Yeah, definitely.
Thank you, sir. Excellent presentation. Just sometime what happens that in the next subgroup of patient where patient came to the emergency in with extreme headache, and you do CT and you find nothing. For example, in CVT or carotid artery dissection, vertebrobasilar dissection. So, what needs to be done in those cases, and what is your practice at your center?
If it is normal, means it is happy, I believe. But definitely, some of the bystanders, at least in Kerala, may not be very happy. If you are asking them to do a CT and is CT turned to normal, they will start blaming on the ED doctor why you did that kind of costly investigation. But definitely, CT is normal, we can observe. Okay, if required, like along with the neuro support and maybe some finding will miss in CT, where particularly that focal neurologics and other things that will be more delineated in MR. But our high index of suspicion, that is headache means we must be a bit of suspicious. or we should have some kind of obsessive compulsive neurosis. That is the best policy to treat this. Sir,
Venu, that was very enlightening. That's good. But I think the point that Jamshed is trying to make is that there are certain headaches where the CT can be normal, but it doesn't mean that you put them away for observation. That's the point he's trying to make.
Exactly. I agree with you, sir.
So therefore, there are certain aspects and differentials which require intervention of a different kind and not just masterly inactivity. No. So therefore, what is important, and this is especially important for all you young people, when you're looking at a patient in whom there is a sudden onset of headache, and you are not able to find a reason for the headache, and most importantly, if the headache still persists, it is important not to just to observe. It is important to get a second opinion. That's the point that Jamshed was trying to make. Am I right? I can read your mind. Dr. Jamshed is not a junior person. He's the professor and head of AIIMS Delhi. So there is a reason why he's asking this question, because the place has got residents who cannot think beyond a bleed. Please do not hesitate to talk to your seniors and get a second opinion if there is a patient who's got a headache for whom you have not made a diagnosis and in whom the headache is persisting. Okay?
Yes, sir.
I think if the CT is normal, we have to still think of subarachnoid hemorrhage and do a LP to rule out, number one. Number two is sometimes we have to do CT angiogram because cervical artery dissection, vertebral artery dissection. Usually if they have dizziness, I had a patient who was doing like sudden cough and he had a severe headache. I thought he was having subarachnoid hemorrhage or something, but CT was normal, but CT angiogram showed a dissection of the vertebral. So, but he also had dizziness also and vomiting. So neurologically, he was talking about like normal neurological and things. So if there is any neurological symptoms, we have to proceed further, and sometimes we have to think about like, cavernous sinus thrombosis and sagittal sinus cortical venous thrombosis, delta sign, pseudo delta sign and all those things.
Thank you so much. This was all very enlightening, and I'm sure good take-home points, sir. Thank you, sir. So we have Dr. Sanjay, sir, coming from Kokilaben, Dhirubhai Ambani Hospital for our next talk. So,
So very good morning to everybody. My special thanks to Dr. Ashima, and I am here only because of her.
Thank you.
So we'll hit the target. So why are we talking about stroke and the door to needle time? You know, we had a talk earlier in the morning about the treatment of stroke, and we got some idea what we are talking about. So it is one of the top 3 killers in India and the world. Number 2 killer in the world, number 3 killer in India. And it is actually very underscored in our treatment. You know, the MI treatment has gone leaps and bounds, but the stroke treatment is still rudimentary. It is the number 1 cause of adult disability, having a lot of economic impact on the family, the society, and the country. So we need to look into it that how we can treat stroke patients better and prevent disability. So eventually we come to this door to needle time. Now when I talk to my other colleagues in our stroke team, which includes neurologists, the radiologist, and the intervention neuroradiologist, you know, nobody is on the same page. You know, for them, time is not brain. They say that concept is old. You know, now it is nothing to do with time. You treat anything, anytime, it is fine, because the window is increasing to 3 to 4.5 to 6 to 9 to 24. And I said, I don't agree with that. And it has been quantified in this beautiful paper that how many neurons, how many weeks of life, and how many years of life can be affected depending upon, you know, so I am the only odd man out. And my last slide will also endorse this. So when in our hospital, which began in 2009, in the early years, we were trying to organize a stroke team and start thrombolysis. This was the early years when the thrombolysis concept was building up. So this is a person, I won't go into the details, only 10 minutes. So I won't go into the details. So I'll only highlight that this was in 2012, the door to needle time was 120 minutes. Because we did a detailed evaluation, a detailed MRI, including a perfusion and this, and took 1 hour in the MRI and went on discussing what is this, and then discussed what treatment we should give and all. I said, technically we did a great job, but you know, for the patient it was not good because it was 120 minutes. And our whole exercise has been how to reduce this door to needle time. So these were the few reasons which we found that informing the stroke team, the radiologists, the neurologists, the intervention people by mobile phones was taking time. And another time was because we had to save every minute here or there. The problem with us is that we do MRI in all the strokes and not the CT, so it requires a lot of additional logistics, and that is a separate talk, you know, MRI versus CT in stroke. So when the bed with the patient goes to MRI, they shift to a MRI trolley, then the trolley goes inside and they shift to gantry, and then back the same, gantry to trolley, trolley to bed, and back, so it takes a lot of time, and I'll talk about it. Then the availability of MRI 24 hours. CT is usually available 24/7 in most of the hospitals, but MRI is not. Then many times we need a creatinine value before we are able to inject contrast in the patient, both for CT as well as MRI. And doing it without creatinine may be harmful, though it is not unethical. Then earlier we used to do everything MRI, CT, and then have the diagnosis and then discuss with the patient and counsel them about thrombolysis or no thrombolysis. And that was taking time, and we reorganized that. From the MRI and CT, we were transporting patient back to the ED to do the thrombolysis. And we changed that also. Then one of the biggest challenge was that we used syringe infusion pump for TPA, and none of the infusion pumps in the world is compatible with MRI 3 Tesla machine. Okay, so I extensively searched. So we only have a rack, and you put the infusion pump inside that rack and shift it into the MRI gantry. So, you know, these are all the logistics. and the information and consent. So when a patient has an acute stroke, at that time you are trying to educate the patient, this is a stroke, this is the anatomy, this is the physiology, this is the treatment, this is that, they get confused. So they take more time to, and delayed consent is one of the main reasons for delay in the door to needle time. So how to shorten challenges? So in a stroke center, which has all the components of being called a stroke center, according to me, the most important thing is having a written protocol. Otherwise, many people will say, yes, we do this, show it on paper, and nobody has on paper. So we started writing our stroke protocol in the very early times, and we identified all the things which I think it is not readable, it is not to be read also. So we identified that what will be done in A&E, what will be done in the radiology, then back to A&E and this and that and blah, blah. And then we modified it in 2014 and put the timings. You have a laser pointer? Okay, I'll do it here. So we put 0 to 15 minutes, then 15 to 20 minutes, and then 45 minutes, and thrombolize in 60 minutes. Okay, so all this. Then in 2016, we again changed the timings and made it 30 minutes, door to needle time of 30 minutes as our benchmark. Not that we achieve our benchmark all the times. In 2016, we again changed the activities, the consent, and also the thrombolysis. We shifted from A&E to the MRI only. So now we are thrombolizing on the CT gantry or MRI gantry wherever the patient goes. And the consent is also obtained at the entry point, and the written consent signature is taken right in the beginning. So when we have a diagnosis, there is no further delay of talking and moving and all that. So in 2017, we again changed our protocol. And this is in 2018, we finalized our protocol, which we are practicing still now, which has a door to needle benchmark of 30 minutes. With an idea that if we keep 30 minutes, we'll probably do it in 40 or 45 minutes, and that's what is happening. In 2022, I have made it 20 minutes now, but this is a challenge I have to give to myself, and my residents are here. They'll be very unhappy with this because I keep on pushing. So now we want to achieve 20 minutes. Now, why 20 minutes? I'll tell you later. And this is the registry which we have, because in order to improve anything, you have to capture all measurable elements and then try to analyze them, try to find out what's going wrong and try to fix it and remeasure to prove that your interventions have been successful. So the first in logistic is that have these patients picked up by an ambulance, preferably your own ambulance. So if you get a call, send your own ambulance so that half of the pre-stroke, pre-imaging workup is done in the ambulance, which like glucose checking, IV access, NIHS scoring, and sometimes changing the uniform also. Because we do MRI, and to send the patient to MRI, we need to change the uniform. They don't agree on patient's clothes. Even if there is no metal on that beeper, they say, no, we won't allow. That's the bottom line, and we said, fine, we'll do that. Then all these patients have to be triaged as triage category 1. Many times in the ED, the recognition of strokes take time because all strokes don't present typically in stroke syndromes. Then how to activate the whole team, code stroke. So earlier we were using phone, but now we are announcing on the PA system. So we have given some color, our current color is code purple because all the other colors are occupied by other codes. In some hospital, they have code silver. So I said, why not we keep code gold? But that we have reserved for MI. So this is the code purple or code stroke and the roles and responsibilities of all the individuals according to the timelines. So this was the logistic which I was talking about of shifting the patient on bed from A&E. So to overcome this, what we had is we have a MRI compatible trolley now with A&E. So we take patient directly on this and then we save one step, which is good 5 minutes. Now, you notice that whenever we lift a stroke patient who is unable to move by himself, so you have to lift him totally 70, 80, 100 kg, whatever, and then move from bed to trolley to gantry and back and all, it becomes very difficult how to pick. So now we keep the shifter, this Indian improvisation, this shifter on the bed, and we take the patient on this only so that, every time it takes 15 seconds to lift and put on another system. Now we have a point of care, I think most of the ERs have, which should give creatinine. There are glucometer-like machines also which are now available for creatinine. So you just do a finger prick and it tells you creatinine within a minute and it helps. So this is the rack, which is the MRI rack. So it opens, the door opens and you put your infusion pumps inside that, and this rack can be wheeled into the MRI room. Otherwise, what the alternative is, otherwise you will have to keep syringe infusion pump outside and have 3 extension tubes, over about 15 to 20 feet of extension tubes going to the patient. And I don't like that. The availability, so we made MRI available. So few years back, our ratio of MRI to CT was 60-40 in acute stroke, but now it is 90% MRIs. So CT is only when MRI is sometimes very busy or the patient has a contraindication for MRI. So just one slide on what imaging to be done. So many people won't agree that we should do MRI in stroke, but so we prefer for whatever reasons. So if you sit with a radiologist during making a stroke protocol and make a protocol for acute stroke, then it takes 15 minutes to do an MRI for acute stroke, and it takes 10 minutes for a CT. But practically speaking, it evens out, so not recently, but couple of years back, I did a small sample audit of CT-based thrombolysis versus MRI-based thrombolysis. And to our surprise, the median time for MRI-based thrombolysis was 40 minutes and CT-based thrombolysis was 45 minutes. So it is a myth that CT is faster and quicker and it should be done, so that we have been able to disprove that myth. So we keep a stroke kit with the emergency and which is an identified list. So it goes with the stroke patient, it has everything to sedate the patient, to treat the blood pressure and to thrombolyze the patient in the MRI or CT gantry. And this is the patient education leaflet in which we try to explain quickly. So these are all the components which we identified that they cause delays. And then we try to say 1 minute, 2 minutes, 3 minutes everywhere, and then let us see what happens now. Oh yeah, and without training, we cannot achieve anything. So training of the doctors, nurses, HCAs, everybody. So we saw the standards of door-to-needle time. So the AHA, ASA says that the DTN time should be 60 minutes in at least 50% of the patients, and a secondary target of 45 minutes in at least 50% of the patients. Now you can adopt these or you can improve upon these. So the best DTN time was reported from Netherlands, which is a median DTN time of 25 minutes and a DTN of less than 30 minutes in 71% of the patients. That is exemplary. So I thought, can we achieve this? Can an Indian hospital achieve this? What is the best in the world? And recently in December 22, the Canadian stroke guidelines have come, which have told that we should be achieving a door-to-needle, a median door-to-needle time of less than 30 minutes. So now we are not talking of 60 minutes. Now we are talking of 30 minutes door-to-needle time. And how to achieve this? So let's see, in 2014, we have this patient who was brought by our ambulance call. So it saved a lot of time. We even changed the uniform in the ambulance and then directly shifted to MRI, and the door-to-needle time was 19 minutes with MRI. 2016, we were ready to thrombolyze at 9:50 a.m. Patient gave consent at 10:20 a.m. So the door-to-needle time is 50 minutes. But then it is because of patient-related factors. So we can do a dissection of hospital-related factors and patient-related factors and all that. So 2019, door-to-needle time was 17 minutes with MRI. 2022, door-to-needle time was 20 minutes with MRI. So we set our targets, door to needle time of less than 60, 90, what all, so that's fine. And from our registry, we try to find out what are the reasons of delay. So you can see that the various reasons which we have found out here is that the CT MRI is busy. Sometimes it may happen that there is a pediatric patient on general anesthesia in the MRI and no way you can take that patient out. Sometimes the MRI machine is switched off, means that MRI is not working and we have to call the technician and activate it, but it has become now available almost 24 hours. That is why we are able to do MRI in most of the patient. Many patients are out of window, so we delay MRI a little bit and don't pull out patients otherwise. If the NIHS is less than 2, then we don't rush these patients. Some patients have ABC stabilization before doing MRI and that may delay the door to MRI time. Some patients give delayed consent and there are other causes. So other causes, one of the causes which we have come out across lately is when they come, many patients vomit. So the vomiting has become one of the factors which we see many times, so especially the posterior circulation stroke and the IC bleeds, many times they vomit. One patient passed urine on the MRI gantry and that gantry got damaged to 30 lakhs and 24 hours to repair that. So now we put a diaper to all the patients whom we are shifting for MRI. See the improvisation. So this is a door to needle time analysis of 2022. So we have a 60-minute compliance of 84%, but if we exclude the patient-related factors, then it becomes 93% for the hospital-related factors, which are clinical decision delay, clinical decision delay, clinical decision delay, and MRI activation. So clinical decision delay is by a neurologist and discussion. So I think that is now becoming a big factor. After we have sorted out all the correctable ones, this has remained as an incorrectable ones. And I still have to meet a neurologist who is concerned about door to needle time, which means I have met very few neurologists. So this is the DTN compliance over the years. Don't want to go into those too many figures here. So if it is so easy to do, if an Indian hospital can achieve it, then what is the problem? Then you can see the trends. This is the US paper and you can see that the compliance is only 26% for DTN of 60 minutes in acute stroke. And after some corrective measures were implemented, it improved to 41%. This is the British paper which says that the compliance is 35 to 66%. But an Indian hospital has achieved a compliance of 93%. So let's talk about median time. So over the years in our hospital, we achieved a median time of 31 minutes in 2018, but again it has increased. Mainly those were COVID years, and still, there are many factors by which we need to bring down our median time. If you see the global trend for median time, it is 65 minutes, 68 minutes, or 72 minutes. And the Canadian guidelines now say that we should have a median time of less than 30 minutes. Now there is this paper, it came in 2017 when we were discussing DTN, door to needle time. It says that the maximum benefit is achieved when we have an onset to needle time of 60 minutes. So from door to needle time, the focus has shifted to onset to needle time in 60 minutes. So how much we can compress in the hospital? Okay, so the best calculation is that if we have to do it in 60 minutes, then this will be the initial ED evaluation, this will be the imaging, and this will be the thrombolysis. So it will take at least 20 minutes, which means the patient has to come to us within 40 minutes. So a lot of work in the EMS. And then we will be able to achieve and do something for the society, for the families, and for the country's economy. So it requires a lot of coordination, training, planning, mitigation, and hundreds of these adverbs. But according to me, it requires one thing, and that is leadership. So if somebody wants to do it, it can be done. If you can do it in one patient, it can be done in every patient. Thank you.
Thank you, sir, for the nice session. Before I pass on the mic, sir, I have a question. Being a paramedic, as you had mentioned about the timing and everything, according to the NHTSA of the US Federation, that is the National Highway Traffic Safety Administration, they have established the scope of practice model for the EMR, EMT, advanced EMT and paramedics. So the paramedics have also been given rights for thrombolytics initiation, of course under the online medical direction of the physicians. What's your opinion about it in India, sir?
So that is applicable only in acute MI, where you have a ECG and you can transmit ECG and the person who is controlling gives you a command that yes, go ahead. But in stroke, we cannot thrombolyze without a brain imaging. So for that, you have to have a stroke ambulance with a mobile CT scanner. So there are very few in the world. In India, there is one, I forget, some in Northeast, Manipur or Mizoram or somewhere, they have purchased a stroke ambulance. At one time, we had also finalized the deal, but then I backed out because it's not worth it. It's
Thank
not
you, sir.
cost effective.
Thank you, sir. Any questions, please?
Excellent presentation, sir. Just wanted to ask one thing, that in our center, it is very difficult to get a CT angio when patient's creatinine level is not normal, within normal limits. Radiologists will not be able to say, will not be able to do it, citing the reason that it will further worsen the renal parameters of the patient. So what is your say? The patient needs angiography. If MRI is not available, MRI angio is not available.
Yeah,
So in that condition, multiple papers are available which says that even if you give contrast by using the LRI principle as low as reasonably achievable, you can do it. So what is your message?
Yeah, so good question. So today I talked only about the door to needle time and not door to revascularization time like mechanical and penumbra and trio and all those things. So the standard international guidelines say that you can do a plain CT and thrombolyze the patient, but you have to accept that 20% of the patients in all the trials have been non-strokes who have been thrombolyzed. Okay, so either you accept that or you try to do MRI. Now, I understand the logistics in AIMS and such places, the MRI would be too busy and but that is why you have to have all the people in stroke team on the same page. And unfortunately, they are not. So I'm the biggest fighter, so my maximum fights are with radiology team. We have fought, we have cried and this and that, everything, but I said, if you have to achieve something, you have to do all that.
Sir, do you use Viz AI? Viz AI is that, I practice in Seattle. So there, if a patient goes to the CT and CT angiogram is done, even before the patient comes to the emergency department, that film goes to the emergency physician's iPhone, it goes to the neuroradiologist iPhone, and it also goes to the neurointernist. And the AI diagnoses that there is a large vessel occlusion, tongue, and that guy wakes up, even in the middle of the night, wakes up and he calls me, oh, there is a patient with large vessel occlusion. So how is the patient doing? In 20 minutes, the patient is in the lab for thrombectomy.
Yeah. So in our
So this has decreased the time a lot for intervention. Like we did an audit and the intervention is within 60 minutes of door to intervention time.
Yes, that's great. Yes. So what we do is from the emergency department, when we send a patient to CT and MRI, one emergency doctor always accompanies the patient and he is trying to coordinate and do a teleconsult with all the stakeholders, especially beyond the office hours. But the senior person in the emergency is sitting on the console on PACS. And as the images are coming there, we are seeing live. And as soon as we see a diffusion and there is an infarct, we start, loading TPA and, preparing things. So actually, we don't wait for radiologist or a neurology consultant we just inform them, this is it, we are thrombolizing, they say, yes, go ahead, and we just go ahead, because the patient is going to be admitted under them, so they are going to own up the patient later. So actually, the emergency physician, and in Indian setting, I can say that this target will only be possible if the emergency physicians do it, and the emergency physicians do it fully and wholly without involving anybody. The moment you involve neurologist, your DTN will go to 2 hours.
Why is that?
Because they have their own calculation, they want to see the angiogram, they want to see the penumbra and all that, and that is not required.
No, for TPA that is not required.
Yeah, but that is what we are seeing practically.
If the CT is negative, plain CT is negative, automatically we give TPA or TNK. Nowadays, TNK is very easy. You push it, one dose, weight based. TPA you have to, is an infusion, you have like 10%. So I think in our setting, the neurologist accompanies the patient. It's patient code stroke. The patient from the field, we have a software called Pulsera. So the EMS gives all the details to us. Like they give the detail that the patient is on Coumadin, is this, is last known normal, is blood sugar, is blood pressure, everything, the history, everything, so that we don't have to repeat all those things. Yeah. And that itself cuts down significant of time. All the contraindications for TPA, if the patient is on Coumadin, we have to know the INR, and aspirin, Plavix, whatever medicines they are, the EMS tells that, puts that in Pulsera, and it goes to everybody, the neurologist, to the emergency nurse, emergency physician, and then, so by the time the patient comes to the ED, we know his blood, last known normal, blood glucose and all those things. And the patient directly goes to CT. They don't even come to the ED. Already registration is done, and they go to the CT directly. And my shortest time is door to needle time was 17 minutes.
So can I say something?
Yeah.
So in this whole presentation, in my about 12 years at this hospital and all, only one patient we got by our ambulance, in which I showed, which cut short the time. So American versus Indian hospitals, so this DTN time is without pre-notification, without EMS, without pre-availability of history. This is the patient shows up at your door and says something is wrong, and then you try to figure out it is a stroke and all. So I think it is all the more creditable for Indian hospitals to achieve these targets vis-a-vis. I'm not underscoring but you have a tremendous EMS, very strong EMS. Yes. And if we had such EMS, it would be very easy for us to achieve a DTN, because most of the time is the pre-imaging time.
Correct. That's what I'm saying. And even like,
Sanjay, I know you have always been passionate about stroke for the last 10, 12 years that I've known you. But right now, when I sit in this auditorium, I feel I'm sitting in a Grand Prix. All I see is zoom, zoom. That's all the vehicles are going past. There are two people who are talking about two different things. And we are all these spectators sitting and trying to figure out, where are we now? Okay, well, that is true. You see, Sanjay lives in an ivory tower. Okay, he has established probably the reference stroke center for the country at the moment. But we also need to take into consideration, because this for the rest of you, because we are all in centers where we do not have a CT which is functional. Leave alone the fact that we have an MRI available for our stroke patient evaluation. So we've got a situation where we see what is the resource that's available for us, and we need to see what is evidence-based information. Just like the debate that we had yesterday, we could have another debate on whether to do CT or MRI for strokes. Okay, there are enough number of papers to talk about for and against both these imaging modalities. But what we need to always keep in consideration is how do I effectively establish a stroke protocol for my hospital, for my patients? Because not only do we have an institutional constraint where we do not have an imaging modality available at our beck and call, we also have a financial constraint. You see, we have in the corporate hospitals, we don't have a problem. Money is not at all an issue. Any amount, doctor, I just want to be back so that I can continue to make my millions. I mean, what's a couple of crores for me? I don't have a problem. Fly me, get me straight, I don't mind. But for us, for the rest of our patients, that's not the situation. We work in government hospitals, we work in corporate hospitals, which are taking care of the lower middle class and the middle class. They're private hospitals, they're actually not corporate hospitals. So in such a situation, we need to actually look at having a protocol for the country where we take into consideration the majority and look at consensus of evidence-based literature, because here we have in Seattle, they are doing CT. We are sitting here in Mumbai and doing MRI. I've got a problem with MRI in my hospital, so therefore I do CT. Why? Because I do CT because I want my students to know that when they go out, they will be able to do that because that's enough evidence. All I want to know is there is no bleed. I don't want to do a contrast. I don't need creatinine, but I will get it soon because I'm getting my point of care, which is going to include creatinine. The point I'm trying to make is we need to look at the length and breadth of the situation, try to put it all together, and see what we can conceptualize and implement realistically in our own respective institutions. So it's good for you all to be listening to all this, okay? But finally, you need to sit down and decide and plan what is best for the place that I work and for the patients that I serve, okay? And this has been fantastic. This is the debate that you want to see and learn from that, okay?
One thing which improved our door to needle time, it was around 65 minutes, like 15 years ago. And now it has come down to like 32 minutes of all patients, I'm saying. Yeah. So we had a team, like a representative from the emergency department, representative from the radiology department, representative from the neurointervention, and neurologist. Everybody sit down in the table, and we have a code stroke committee from all these people. And we go through each case which went above 60 minutes and find out why there was delay, who was delaying, whether the emergency physician took time to diagnose, or whether there was a delay in getting the CT or imaging, whether the radiologist took so much time to, whether the neurologist. So when you have like this, then they all come, man, I should not be, tomorrow in next month in the review committee, I should not be the problem. So they will be like, oh my God. And how it happens is, when we get a code stroke, when the CT is done, the image goes to the radiologist and it comes, it's red, flashing red. They have to stop reading all the other CTs, and they have to do it, and they call me. Within like 1 minute, they say CT head is normal, because there is medical legal, because even if there is a hemorrhage and there is a small punctate hemorrhage somewhere I missed, then they will say, are you the specialist? Now this guy has a hemorrhage. So there is a lot of medical legals. So we are not supposed to, even though we know it is, and and so even like pharmacy, how much time it takes to mix the TPA and to come from that, from ordering. The pharmacy person is also there. So you have to involve that. You have to have a code stroke committee, and we have to go through all the code strokes, why the time was exceeded. Sometimes there will be a legitimate reason. Patient has a high blood pressure, and to bring down the blood pressure, or the family is not giving consent. I mean, there are other reasons for the delay. Sometimes the diagnosis is not clear-cut. When it's a clear-cut, it's fine. But somebody has like a chest pain, and you have to rule out dissection before giving this and things like that. So there are other reasons. So you have to have a committee, and the committee, everybody has to be there, And they have to go through why it was delayed in each, and who is responsible, which department, and how. It's not like pointing fingers, it is just we are all for the same goal, that try to get the door to needle time. So if you just talk to them, they will say, different thing. But when there is a committee, and we have a dedicated people from representative who all want to decrease the door to needle time, and they are all working together. Not all neurologists will be there, but one neurologist will be very much interested in bringing the door to needle time. So 1 year. So I think, and then we have to go and tell the respective department. So this is what we did. Oh, this patient, there was delay in diagnosis, like that. I think that will be done.
I think great. Yeah.
Yes.
Promise I won't exceed 10 seconds. It's really impressive what you've achieved. Really, really impressive. Sitting here, hairs on goosebump kind of situation. In an Indian hospital, what you've managed to achieve. Yeah. One question is, you've had to do a lot of process optimization in achieving what you've achieved. Did this improve the quality of other process-related emergency care that whether it is MI or other things? Has it helped in moving the department forward in achieving other targets?
Yeah, naturally, when you plug all these holes, it overall helps in the department optimizing various other collateral processes, like getting imaging done and getting reports online, and sorting out issues with PACS and all. So we yet have to come to your level of AI and processes and all. We are not that. But whenever there is a delay, and now most of the delays are because of neurologists. Don't put me on record. So as soon as that happens, I shoot a SMS to them. We were ready to thrombolize at this time, but your intervention, we could thrombolize, it got delayed at this time. Please look after in future. I am not afraid to send such SMS.
So why do you have to wait for the neurologist to thrombolize? I don't wait for the neurologist.
So in Indian hospitals, we have to have them on the same page and have a concurrence with them.
Similar to your CT by the radiologist, there is a medical legal implication which allows only the neurologist today to diagnose a stroke and plan the management. The emergency physician, Dr. Ashima, can I have you? The emergency physician has not yet been empowered. Or we don't know if we are empowered. That's the best part. I would put it that way. Okay, because the law does not really tell you what to do. If you look at the law, what does the law do? The law does not tell you what to do. The law tells you what not to do. That's the problem. And we always presume that, we are not yet empowered. But they've taken the bold step to go ahead and do it. And nobody is going to question them, because there is no law which says that you cannot do it. Okay, but they will talk about you have to be specialized. What's specialized? There's nobody more specialized than them as far as stroke is concerned, as far as the early management of stroke is concerned. Nobody can discredit them. Whether they go for an expert panel, or whether they go for the law, or whether they look at other systems, they look at the US system, nobody is going to discredit them. But they have taken the bold step. That's actually the crux of it, and that's why you have been successful. Yeah. So there's one more thing I will tell you. When it comes to strokes, way back in CMC, like what you said, you need the support of people. We had a young neurologist who came back, interventional neurologist who came back from the US, and together he and I decided we will start the stroke protocol in 2011. How many years is that now? It was about 12 years ago. Okay, we started the stroke protocol, and we were both young, enthusiastic, aggressive. We achieved a door-to-needle time of 40 minutes, 40 minutes. Okay, we were doing only CT. And then after the CT, after the discussion, he was willing to do intra-arterial intervention with thrombolytics, if required. So that was his plan. And he did a big paper on that, and I'm sure Sanjit Theran is somebody who's known to many people who are, you've heard of Sanjit, I presume, Sanjit Theran. There are lots of papers by Aaron. So that's him. So we were able to achieve door-to-needle time of 40 minutes when we do not have the same system. See, you have an EMS, your ambulance goes out and comes, you get you have a ETA time of the patient who's going to arrive, you already have done some kind of interventions while en route. Here, whereas the doors open and then, okay guys, CT. So that's how it was for us. So it does require a lot of support, and it does require, and I have pushed myself, the patient. Sanjit on one side, I on one side, we are pushing the patient to the CT room. In fact, I met one of the radiologists day before yesterday at a wedding when I was in Berlin. He said, "Sir, you remember the time that you used to bring the patients to the CT room?" I said, "Yes." Sir, nowadays nobody does that. I said, "Well, days have changed."
Thank you. This is not working, so I'll pick this up. Thank you, Sanjay sir. And I'll just add one thing for Sanjay sir. I've been an assessor to so many places, but if I have to choose one place where everything was clean, clear, in place, is his department. A big round of applause for sir. Thank you, sir. Thank you so much.
Sorry, this topic took a lot of time, but I was not the only one responding. Many people responded.
So we invite our next speaker, Dr. Girish sir. Sir is the principal of Amrita Institute of Medical Sciences and the professor in the Department of Emergency Medicine. And I know how much pains he must have taken and permissions he must have taken to come over here, because NMC would not allow it him so easily. So thank you, sir, for joining us for your talk. Please place our slides.
Good morning, all. Good morning, madam. So my topic is altered mental status in ED. So after this presentation, you should not develop altered mental status, because it's a very huge subject. Even after reading these slides, I am getting altered mental status. That is a problem. But whatever it is, it's the benefit of PGs. PGs will get maximum benefit from this type of topics. When we take ICU rounds, I still take ICU rounds every day. 30% of our patients are having altered mental status. We have to find out what is the reason for the altered mental status in that patients. So I'll just rush through the slides and we can discuss it afterwards. Now, when we discuss about altered mental status, that shows the patient's alertness, attention, memory, and awareness. So when we see the patients in our ED or ICU, there are three important things we have to see. One is whether the patient is having delirium, coma, or dementia. Dementia, we leave that, because most of our patients who are in elderly individual who is having Parkinsonism, Parkinson plus syndrome, we get many patients who is having Parkinson plus syndrome. So in that type of patients, we can get altered behavior due to some other reasons like hyponatremia. That is the most common cause. But delirium is the one we are going to discuss now. That is acute confusional state. Due to various reasons, we get acute confusional state. But remember, in emergency room, when we have a huge college, like our campus is having 5,000 students, many students come with altered behavior. They are actually malingering, because on the exam day, I am the principal. So unfortunately, sometimes I have to go and see this type of students also. So many students come with altered behavior to emergency room, especially during exam hours. Okay. So coma is defined as unarousable, unresponsive. I am not going to the details of all these definitions. You all know that. Dementia is one important problem in emergency room, because nowadays our elderly population is increasing. Many patients who is having dementia come with especially Parkinsonism. That is one important diagnosis you can see in your emergency room. They come with aspiration. That is the most common mode of death in Parkinsonism. But many of these patients can have hyponatremia. We don't know what is the reason for hyponatremia. Many a times it may be because they are not taking adequate fluid, salt, all these things. Because they have, most of these Parkinson patients can have difficulty in swallowing. That you will learn that when you see these patients, they may not be taking adequate salt every day. So in emergency room, we always see GCS. We train our EMTs, especially EMTs, emergency medical technicians, about this GCS. We all learn in our MBBS days or in emergency room, we learn how to assess this GCS. One of the important factor about GCS is, one is you are able to understand the GCS of the patient. Next one is when you are handing over to next person, your colleague or next PG, you can tell this is the GCS of this patient when he is coming. His GCS is only 8. Now it has improved to 12. One of the important clinical condition in emergency room is hypoglycemia. You all learned that in GCS less than 7, you may have to intubate. That we learned traditionally from our textbooks. But hypoglycemia is one condition. When the patient comes, his GCS will be very, very low. But once you correct that, the GCS will be completely normal. In a busy emergency room, documentation is very, very important. Because suppose the patient comes, when he comes, his GCS is very low, and after your treatment, whatever may be, whether it is sodium infusion or normal saline or a correction of hypoxemia, whatever it is, if the GCS is improving, we have to document that. So GCS, learning the GCS scale is very important, and documenting that is also very important. But if you are lazy, then AVPU score is another important scoring for you for that. But we don't recommend in our emergency room about AVPU score, because if we teach our residents about this AVPU score, next day onwards they'll only document AVPU score. So we don't recommend this type of scoring in our emergency room, but it is there in the textbooks. So that can be correlated with your proper GCS score. We train our EMTs, nurses, all taking GCS properly, because that we know that most of the time EMTs or nurses are with the patient. They have to assess them continuously. We will be seeing the patient 1 or 2 times in a day. So they have to be trained properly in GCS scoring. Now I'll tell the common causes in emergency room which can produce altered behavior. If you may be seeing a lot of patients in your emergency room, but in our emergency room, one of the most common cause for altered behavior is hyponatremia. So you may be seeing in your emergency room, causes may be different. Some hospital it may be trauma, some hospital it may be COPD, some hospital it may be alcohol-induced problem. But you can see this chart, there are a lot of causes. If you see that first slide, first paragraph, urinary tract infection, that is one of the most important cause for altered behavior in emergency room. You know why that urinary tract infection produces altered behavior? Normal urinary tract infection will never produce altered behavior, because the toxicity, you know that it is mostly because of E. coli, sepsis. The toxic encephalopathy is producing altered behavior. Another important cause which is not mentioned in standard textbooks is during urinary tract infection, urinary tract infection, patient is going to lose large amount of sodium from their body. This is not mentioned in any textbook, but you can see the patient is losing urinary salt through the injured urinary tract. So that is a second important cause for altered behavior in urinary tract infection. But if you see the standard textbooks in neurology, that is given, this problem is given in that like brains, textbook of brain, it is given. But in your practice also, you can just follow up how many patients are developing urinary tract infection and hyponatremia. And another important cause is hypoglycemia. For any emergency room physician, when you are seeing an hypoglycemia without any reason, take serum insulin level. That is very, very important, because hypoglycemia can be produced by various causes. It can be due to your drug, it can be due to insulin, it can be due to malaria. So many causes can produce hypoglycemia. But one condition which you are going to miss is spontaneous hypoglycemia, that is insulinoma. Since we have a lot of patients with insulinoma, we are taking always, whenever patient come with hypoglycemia, we take insulin level. But it is not possible to take insulin level in a routine practice, and you may not think also. But since it is a clinical presentation, I am telling every reason. And alcohol ingestion in our state, it is very, very common. Alcohol-induced problem. Withdrawal of alcohol is also very important. Then hepatic encephalopathy, same like that. You know that there are 4 grades of hepatic encephalopathy. Grade 1 is you can have altered behavior with altered sleep rhythm. Second grade onwards, you can get flapping tremor. Last grade, patient can have coma. So if you know all this grading system, it will be very useful. And neurological stroke, sir has already discussed about stroke. I am not going to the details. But stroke is one of the important reasons for altered behavior in emergency room. Seizure, that is another important problem. But most of the time, we get seizure after the acute episode. How do you diagnose seizure? After that, you can take history from the bystander, that's okay. But if you have a ABG value with ABG mission with lactate levels, immediately you can make out whether this altered behavior is due to seizure or something else. Because most of the seizures, you can get high lactate. If the patient is not having hypovolemia, shock, and if the lactate is elevated, patient is having altered behavior, you can think about seizure episode. Then other things are like hypoxemia is another important cause. We have a lot of patients who is having COPD, cardiac failure. Hypoxemia is another important cause. Drug-related problem, nowadays we are getting a lot of patients, again students are taking a lot of sedatives. They come with a lot of sedatives and other drugs. Alcohol is also another important cause. Now, I have stressed about hyponatremia because that is one of the most important cause of altered behavior in emergency room. Now, hyponatremia, there are three important types of hyponatremia. One is normal fluid, another one is more fluid, last one is less fluid. If your patient is having severe diarrhea, vomiting, and he can have hyponatremia with less fluid. If the patient is having some lung malignancy or some other malignancy with hyponatremia, he can have mostly SIADH. If the patient is having a volume overloaded condition like cardiac failure, liver failure, kidney failure, hyponatremia, then it is due to dilutional hyponatremia. But remember, as an emergency physician, what I have observed is whenever there is hyponatremia, there is a tendency to start 3% saline. That is not correct. When you see this chart, you know that only reason for giving 3% saline from this chart may be a severe SIADH or severe hyponatremia due to sodium depletion. Otherwise, we should never give 3% saline. If you see the middle part, hyponatremia with increased ECF, cardiac failure, patient can have more volume. Because of more volume, there is a reduction in the sodium level in your lab investigation. Actual sodium in the body is normal. Suppose you give more, like 3% saline to that patient, what would happen? Because again, if the 3% saline can retain more water and produce more failure, more water retention, so that will be dangerous. And again, if you are seeing hyponatremia in emergency room, remember to take three important tests. One is serum osmolality, urine osmolality. Third one is urinary sodium. Most of the time, we miss that. If you are taking urinary sodium and if the sodium levels are very high, you can know that the patient is losing sodium through urine. So in that condition, the drug tolvaptan will be effective. So all these things, when we are treating patient properly, when we are diagnosing patient properly in emergency room, it will be very useful for an intensivist or physician on the floor. So we have to remember that also. We just, if we just start 3% saline to any patient who is having hyponatremia, that will change the clinical picture completely. Then it will be difficult for the physician to make a diagnosis. Now, another important cause for altered behavior in emergency room is, I am not going to the details of how patient can develop status epilepticus. I have just explained you in the previous slide. You take ABG, if you have an ABG level with lactate levels, that will be very useful. Otherwise, detailed history should be taken not from the patient. We have to take history from the bystander. Suppose you take the history from the patient and he is telling, I have developed seizure. What will be your diagnosis? It is malingering. So if the patient is telling, I had developed seizure, I had rolling of eyeball to that side, I did like that, then that history is completely wrong. That is malingering. So you can take the history from the patient bystander, and if you have a doubt, you can see the lactate levels. It is a very useful blood investigation in emergency room, but we know that lactate can be elevated in so many other conditions also. Now, as an emergency doctor, PG, you should know about toxidromes. We have 4 or 5 toxidromes. I'll just show the slides. I will not go to the details of each toxidrome, but one toxidrome which is very useful, I can tell, that is anticholinergic. So you can have tachycardia, fever, hyperthermia, mydriasis. All these things are common in atropine, but there is a poison, that is datura poison, that is very common in some states of India, not very common in our state. But that, if you are from that state, you should know, because it will become a medical legal case. Another one is cholinergic muscarinic toxidrome. You all remember it as sludge or dumbbells. I am not going to the details. That is organophosphate. So we know that most of our states, Indian states, the farmer population is very high. So we are going to get a lot of cases like this. But standard textbook says that they have a peculiar smell for the organophosphate. But what is the smell of organophosphate in your clinical practice? Any PGs can tell? Don't tell the textbook definition. It is kerosene smell. So it is kerosene smell. Actually, books say some other smell, I don't remember it. Okay, whatever it is. Then cholinergic nicotinic toxidrome, again that is common in organophosphate. Black widow spider bites are not common in our country. And other opioids, all these things I am not going. Okay. Now this slide will be very useful for postgraduates. This is alcohol-induced toxic encephalopathy. So there are different types of alcohol-induced toxic encephalopathy. One is routine alcohol, that is ethanol. You get metabolic acidosis, altered behavior. But any patient who has consumed alcohol, metabolic acidosis, alcohol, history of alcohol, he is having blindness. Then what is the diagnosis? It is methanol. So recently in COVID time, we had alcohol ban in our states. Most of the states had ban. During that time, we had a lot of methanol intoxication and visual loss. There are some newer treatment modalities advised. Actually, that papers are from Iran. I am not discussing that here. Erythropoietin was given in many patients with some good result, but it is not promising, but some good results was there. Now, as a postgraduate, you should know this sign. This is Kernig sign. Whenever a patient is having altered behavior, fever, we always think meningoencephalitis. There is a difference between meningitis and encephalitis. Meningitis means patient can have headache, fever. Altered behavior is there means it is encephalitis. But this test, this is a very important clinical test everyone should know. Like previously we were discussing about the MRI, CT. Some centers we know that still in India, some centers we don't have MRI, we don't have CT scan. So this type of clinical findings may be very useful for you. This is Kernig sign. You try to flex the hip joint, try to extend the knee joint. You will not be able to do that. Patient will have severe pain. That is a sign of meningitis. Any other clinical condition you can get this? Any PGs can tell? This sign? Any other condition other than meningitis? Subarachnoid hemorrhage. Okay, good. So subarachnoid hemorrhage is one condition that can have similar finding of meningitis because blood is an irritant in brain. Okay. So this is herpes simplex encephalitis. You can have, there is a lesion on the temporal lobe. What is the treatment? It is acyclovir. So when you are giving acyclovir, how do you give acyclovir? You have any idea you can tell? PGs, it is for the benefit of PGs. It should be diluted in 500 ml of NS and should be given because you need to give more fluid. Otherwise, acyclovir can precipitate renal failure. That's why. Okay. So acyclovir 10 milligram per kg 3 times. Any other encephalitis can have temporal lobe involvement? Autoimmune encephalitis. So that is a very important finding because nowadays many patients who come with altered behavior, when we do LP, it resembles viral encephalitis. They don't get benefit with acyclovir. So that will become slowly repeated LP. We can send immune antibodies and it will become, the diagnosis will turn towards immune mediated encephalitis. Now this is tubercular meningitis. Which all anti-tubercular drugs can penetrate inflamed meninges? You have any idea? It's not core emergency medicine, but since many of our emergency PGs are even working in ICU, I am asking this question. Pyrazinamide and streptomycin are two important drugs which can cross the blood-brain barrier in an inflamed meninges. Okay. Why do we give steroids in TB treatment, TB meningitis? You have any idea? Because that produces obstructive hydrocephalus. Okay. Now, whenever we have meningitis in emergency room, we always try to do LP on that spot itself because otherwise we will miss the diagnosis. Once you shift the patient to floor, it will take a lot of time to make a diagnosis. Bacterial meningitis, you can see here, there are a lot of polymorphs. Then glucose is always low in bacterial meningitis, and gram stain is one important test which can be available very fast, so that will be positive. Now, empirical therapy for meningitis. Can you tell me why we give dexamethasone in meningitis? Because that should be initiated from emergency room itself. We had a lot of debates who will start treatment first, whether emergency physician will start or neurologist will start the treatment. But in our hospital, we only start the treatment. Why we start dexamethasone in meningitis? Because gram-positive cocci, once you start antibiotic, this cocci can be destroyed in your CSF. That capsule can produce further inflammation in the brain. So we have to give dexamethasone before the initiation of antibiotic. So before itself, we start dexamethasone and send for the patient for MRI. We do LP and we go for triple drug therapy that I'm not going to the details now. Okay. Now you can also make a clinical diagnosis whether it is hemorrhagic, thrombotic, embolic stroke by clinical experience. But previously we were discussing it is not that enough. We need to have a CT scan. Only CT scan is enough according to current guidelines, and most of our centers have only CT scan. MRI is a luxury for many hospitals in India. So we follow only the guidelines, and we also think that CT is enough to make a diagnosis of bleed in the brain. If there is no bleed, we can go ahead for thrombolysis. So these findings say you that there is first is CT, acute middle cerebral artery thrombosis. What do you do for this patient? If the patient comes in less than 4.5 hours, we can give TPA. Okay. But now time is extending, slowly it is extending. It may become 9 hours or 1 day, I don't know. But current guidelines say it is 4.5 hours. Now there are two important signs, hyperdense MCA signs and loss of insular ribbon signs. All PGs may be knowing. For the completion sake, I have added this. And another important condition which can have altered behavior in emergency medicine is sugar-related altered behavior. It can be hypoglycemia, it can be hyperglycemia. Both can have altered behavior. Here we require an ABG or VBG. What is the difference between ABG and VBG? Any PG can tell. In DKA management, should we take ABG only or VBG is enough? VBG is enough. Okay, thank you. Okay, another important condition is cerebral malaria. In our state, the number of cerebral malaria cases are less, but we know that almost all states in India have malaria, and number of falciparum malaria is very high. Do you know what is the reason for falciparum malaria which can produce altered behavior in a patient who is infected? Vivax malaria, you don't develop altered behavior. That is because this rosette formation. Rosette formation means infected RBCs club together and go and block some arteries in the brain. So that produces altered behavior. So altered behavior is a feature of falciparum malaria. So what is the treatment for falciparum malaria? Artesunate. Okay, we should know all these things, because in emergency room, you know that many of our hospitals, nighttime only emergency physicians will be there. So you cannot call a physician, you cannot call a neurologist, you cannot call orthopedician. So sometimes we'll have to manage everything. Okay. Now another important condition we admit in our ICU is most of the time it is because of neuroleptic malignant syndrome. Patient can have rigidity, altered behavior, elevated CPK. This is the classical condition you get in emergency room because of these hypnotic drugs. What will be the difference between tetanus and this? Any PG can tell. They can have rigidity, they can have elevated muscle enzymes. What is the main difference? It is the consciousness level. In tetanus, patient will be conscious. Here it will be altered behavior. Serotonin syndrome is a differential diagnosis for that. There are some differences. Main thing is pupil. Pupil will be dilated in serotonin syndrome. It will be normal in NMS. Okay. Now brain death I am not going because it's a big topic. I will not be able to cover that. But we need to have 3 different doctors to make a diagnosis of brain death. According to standard protocols, we need to have 3 doctors, and we should have persistent coma, absence of brainstem reflex, lack of ability to breathe independently. These are the 3 diagnostic criteria. Now, once you make a diagnosis of altered behavior, like you can do simple tests like you can take a blood glucose level, you can take an ABG. Most of the diagnosis will be ready because our ABG machine has got electrolytes in that, creatinine in that, everything is there. And blood sugar and ABG will tell you that the diagnosis, and like any other case, we have to take care of patient's airway, breathing, circulation. And last slide is how to treat seizure. Okay, you all may be knowing seizure we can manage with lorazepam. If the patient is not getting controlled, you can start phenytoin 20 milligram per kg body weight diluted in normal saline. And if the patient recurs seizures, again you can give it or go for another drug. Nowadays we use sodium valproate. What is the advantage of sodium valproate over other drugs? Huh? It is not like broad spectrum. In emergency room, what is the advantage? Because many patients who is having liver disease, levetiracetam is a very useful drug. Nowadays, we get a lot of patients who is having chronic liver disease, alcoholism, come with seizures. We are unable to use phenytoin. So we use levetiracetam. If the patient's seizure increases with phenobarbital or phenytoin, what is your diagnosis? That will be a homework for you. If patient's seizure increases with phenytoin, phenobarbital, and his urine color is red, porphyria, acute intermittent porphyria, that is the diagnosis. Thank you.
Sir, so no, we are not altered. Rather, we have got more algorithms in our mind now how to go ahead and take care of, at least diagnose what is the etiology and accordingly manage, isn't it? So thank you, sir. Thank you for the talk. And the homework needs to be done because principals don't forget the giving homeworks. He has already told.
Yeah.
So, yeah. So thank you so much. Thank you. We invite our next speaker, Professor R.K. Singh from SGPGI Lucknow. He is the professor and head of the Department of Emergency Medicine. And he's one of the person who has been developing telemedicine in emergency department for the government of India. So who better than him to talk on the same subject? Welcome, Dr. R.K.
I'd like to stand. Thank you, Ashima. Thank you, AIM-23 for the invite. All of you on the age of Dr. David may say this is too modern for me. Somebody of the age younger sitting behind may say this is so tech savvy, I need to be there. So it will be a mix for both of you. It's futuristic, it's in time, and it's needed. I happen to be the nodal officer for COVID at SGPGI and also the nodal for the telemedicine, tele-ICU service at SGPGI. So I take a lot of it from what I am doing currently to what I believe most of you in the coming times will go there. Harsh lessons learned during COVID. I think all of us have gone through each of these small segments, struggled, panicked. If COVID comes now, we will go through all of this again because we have not learned the lessons. We will struggle the same way as we did at our place at SGPGI in the second wave. And I believe all the experiences from the country are almost the same. The harsh reality is that I think we have not learned the lessons. Telemedicine during COVID did help us. We had both pros and cons of using this in the COVID times. And the pros, obviously, this comes from the Indian pediatric journals. So it was time-saving, easily accessible, social distancing, triaging, first aid, refill prescriptions, cost-effective, reduced overcrowding. This will hit you. Why? Because you don't want your EDs to be overcrowded. So how do you avoid it? COVID pushed you doing that, but this is non-COVID now. How are you going to help prevent overcrowding in your EDs? telemedicine is probably going to be there for long, long times. The cons for this are that there are technical issues, one-time cost investment. I don't have the money. The government hospitals don't have the money to invest into technological advancements at their place. There will be a lot of medical legal issues. There will be loss of face, lot of interaction between a doctor and a patient. You bring in telemedicine, that's gone. So it's a virtual reality. So how do you deal with that? There'll be confidentiality, legality, ethical, privacy issues. All of that will come when you deal with telemedicine issues in coming times. This is what we were doing. I'm sure most of you were also doing. A patient not in COVID or not having COVID, but having to deal with a lot of information using that, either by up-to-date or by online or by health science or by psychological. The patient struggling through screening and latent services and consultation, and the hospitals themselves, the medical staff training. During COVID, using telemedicine from SGPGI, we were able to train 70,000 healthcare workers. This is a huge number, 70,000 healthcare workers in the state of Uttar Pradesh were trained because of telemedicine. So this is a huge number. Training of consultants, consultation, quality improvement, psychological consultations, broadcasting, as well as panel discussion. So that is where the world is going in terms of technological advancements. Let's see a little more of it. Let's take the US example. I don't have the Indian example to share. 2019, you see the dashed line, the emergency services were going down. Simultaneously, you see the telehealth services were going up. And the percentage escalation was nearly to a tune of 100% during this time. So, COVID, at the back of the National Health Digital Mission, is where it lies now. So you have a personalized health ID. This is something that the government of India is doing, and this is where things are going to be. Hospitals, clinics, ambulances, patients, patient homes, everything connected in a virtual world. Everything connected by personalized health IDs, by telemedicine facilities, by DigiDoctor services, health facility registry, personalized health records, and e-pharmacy. So what Dr. Einstein was telling in Seattle may become a reality in a country like us, which is low resource, in the coming times. With the government of India pushing so emphatically towards this, I think times are about to change very drastically for the countrymen in need. So what it is? So there are two elements, I would say. When you deal with care elements of tele-segments, it's called telemedicine. Cure, I'm dealing with telepharmacy, I'm dealing with teleradiology, tele-EDs, telepsychiatry, teleradiology, teleneurology, stroke units, tele-stroke units. So this is all curative aspects of a patient, so this is telemedicine. When I go beyond that and promote health into wellness segments, promotional activities, that becomes the telehealth. And when I go even beyond that, that comes the National Health Mission, that is digitized health. I walk into a hospital, I have an ID, the hospital clicks me and picks me up, and my whole scale is everything is available on a dashboard. I don't need to pin my details. It is all connected. The mobile becomes live. So you are in a hotel, what do? You connect to a Wi-Fi, you are reaching a hospital, you connect to that setting, and you are live on that screen for the tele-ED doctors, for the cardiologist, for everybody. So their health records are coming straight away on the dashboards for you. So this is the imagination of the National Health Mission. I believe we can go there with the positive intent and the attitude. So what it is? So just look at the cascade. So you have wearables. Today in the current times, you connect to a hospital automatically. The wearables themselves send out an SOS signal to the hospital, which is nearest, and the ambulance is at the doorstep of your patient. You pick it up, you get the patient to the hospital, and then you connect everything. The patient, the EHR, the electronic health records, the data management services, the device and tools in terms of video cameras, mics and sensors and communication either through Bluetooth, Wi-Fi, or data. And then it is transmitted onto desktop computers, laptops, smartphones, PDAs, or tablets. And then you have care managing. So this is all that is going to happen. In times today, some of the better staffed hospitals like Kokilaben may be opting for these things. For poor centers like ours, we may be still struggling, but we all have smartphones with us. So they are going to change. So that is where the mobile health segment comes. So when I use a mobile or a smart health device like a smartphone, that is mobile health for me. So it is permeating almost all segments of healthcare. So it will become app-based. I need to access a ED service. So an app-based ED program is available. I interact and integrate with the hospital, which is closest to my house. And that is how I get the access of all those services. This is all possible. I'll skip this slide because it goes more into detailing. So there are three modalities that are available to us. One is the telemedicine interactive, which is audio-visual, bi-way communication, which are synchronous modalities. Then you have store and forward, as you do. I have an angiogram. I send it, I record it, and send it to somebody, a cardiologist, so store and forward. That is an asynchronous modality, which I use. And then there is remote monitoring. Now, all of this is there in big time in US. It's about to hit big time in India in the coming days to come. So change, adapt, change is inevitable, so learn it. So this is the market that is going for RPMs, remote patient monitoring services in US, almost 1.7 billion market by 2027. And if you take for 2024, the predictions are $30 million US market in RPM. So this is what is going to change. It is already changing. It's changing in India as well. RPMs, we know. We have glucometers. We have pulse ox. We have sphygmanometers. All these devices that are at my house. For my patient, for myself, can I connect them to an app-based system which gets signal to the hospital itself? So that is where things are going in terms of RPM monitoring. And there are even peak expiratory flow meters, which get automatically connected onto the app-based systems and sends a call into my pulmonologist that what's happening to me at my house. So this is all possible. This is all a reality that is about to hit us. And then we have this is a Swiss watch which sends out an SOS signal to the cardiologist if my rhythm disorder is happening. It sends out an SOS call to if my saturations may drop, my heart rate is beating or not okay, I may have a cardiac arrest on my way to the airport. So how do I send an SOS call to the nearest hospital? So this is all possible. This is all being done. Okay? So benefits extends the reach and expands the healthcare service. So it is just exploding. It's expanding your service beyond what you could have ever imagined pre-COVID. So COVID was the right stimulus given to this telehealth segment. Take this opportunity, go into a bigger world that is available. And while Dr. David goes to Run of Kutch, he can give his experience to an ED physician, junior physician sitting somewhere in Calicut about what needs to be done. He could have a digital stethoscope. He could have a digital camera, right? The resident could have a camera on either on the forehead. Dr. David, while shooting in the Run of Kutch, can give his impression to the resident on the floor. So while I take all his capabilities and utilize him, I extend his career as well. So that's the advantage. Why should he retire? Why should such a smart brain be doing only photography? Yes, okay, you deserve photography. But the kids who are there need to take from his experience. What he could tell in 1 second, that kid will take maybe 10 minutes, do extra investigations. So why can't I take these telehealth opportunities to bring his experience on the floor of a young ED department, which is unskilled, unmanned, with very less resource in terms of that. One-time cost investment will help me change the way things are going to be. So a lot of things are there in terms of benefits. What comes to the ED? Teletriage. Your triage is studied with camera. It has a resident with a digital stethoscope. It has a camera either on the forehead while I see a patient. It helps me get the experience of my senior colleague who's gone home tired out. So I can take this experience. So teletriage is something which is really there it will help you reduce the amount of load. Tele-EMS, again, the ambulance which Dr. Einstein was talking, it already has the screen, all the ECGs and the monitors. Even before I drop into Kokila by Ben Hospital, the information is with him. The unit itself has a CT scanner in that. So the image is transmitted. Even my paramedics can give the thrombolytic on the ambulance, within the ambulance itself. So this is all possible. This is what we are doing at my place. Costly, I would say. This is for 200-bed intensive care tele-ED ICU, which we are trying to give it to 6 pilot medical colleges in the state. And then we want to amplify it to 75 medical colleges in the state. We are planning to invest more money into it. We are already into 35 crore investment into this project. And it is going to get live in the coming few months at my place. So what is it? It is just like a cockpit. The cockpit is at SGPGI, and then you have all the aeroplanes, which are the ICUs of different places. They are being telemonitored, teleconnected, supervised, not in a brotherly fashion, big brother manner, but a collaborative care model, where we try and give our experience of intensive care to those younger ICUs which do not have enough people. They do not understand the changing dynamics of the patient at the time. So we have our nurses, our telecare intensivist, sitting 24/7 giving this service around the clock to all the medical colleges who are coming up in the state of UP. So this is one such model. I will not detail on this because it goes into integration of monitors, the core EMR, the PAC systems, and all those things, audiovisual. This is high end. It cost us 35 crore to build something like this. So it is one-time cost, but it will give you a lot of mileage in the coming years. So this is the smart hospital that I'm talking. Just look at the last lines, a smarter OPD. Why is my OPD consultant just sitting, waiting for a patient to walk in? Is the service going to be, with competition coming from corporate into the government, corporate is picking up the patient right from the homes. What is the government hospital doing? Waiting for the patients to come to them. Era is gone. You have to go right into his home. Pick him up from the house. There'll be competition soon, so better learn to change. So a smarter IPD, a smarter pharmacy, smart diagnostics, smart ambulances, smart blood banks, smart. This is all in the National Health Digital Mission of the country. So this looks really alien to, say, Dr. David may think, wow, when is this going to come? Am I able to see this? I think this will become a reality in the coming times with so much of money being pushed into this. And we are vying for a $10 trillion economy. UP itself is vying for a $1 trillion economy. This is a huge segment that is there, just waiting to be tapped in. So what is the evidence? Why am I talking so much? Sab khwab hai. So evidence, I'll just take one systematic review. Telemedicine in the EG departments, an overview of systematic reviews. This comes from Iran, somebody who's done this, published in 21. He looked into, there are 18 articles into this, right from 2015 to 2020, so includes the COVID period as well, so all these publications. And he's finally, based on the Robios protocols or trials, the assessment tools, he has worked into these 18 publications. So what is the most feasible technology in telemedicine? As of now, it is real-time video conferencing. This is the major bulk of all the studies which are commenting. Then there is real-time audio conferencing, then telemonitoring and forward and store. This is what says. Benefits, which I've just told you, they're all of them evidence-based medicine from the field of emergency. I'm not talking of cardiology. I'm not talking from neurology. This is emergency medicine. Okay, right from cost reduction, quality, decreased patient transfer, mortality, patient treatment times, time. So everything is green means green flag. Good, let's move ahead. But there are challenges. How do I implement it? Cost, interface, loss of face, one-time investment. Who will give me the money to invest into something like this in my hospital? So these are all the challenges that are there. For paucity of time, I'll just pick up. Then I need to see the feasibility and the effectiveness. This whole article looks into how feasible. The green ones are the low risk of bias in the studies. So for feasible, only one study was there which said that there is low risk of bias in the study and therefore it is feasible. Not feasible, again, there is only one study which says low risk of bias, and there is high potential but more evidence is needed. Most of the studies which looked into this were of low, 5 of them at least looked into it as a low bias component. So there is a high potential which is said. So the authors concluded that there is strong evidence, challenges are there, need for better quality of evidence in order to confirm their feasibility in the ED. How to set it up, just a few words. Don't go blindly, look into what your hospital has. You don't have to emulate what Dr. Is doing at Kokilaben, because my hospital may not have even an MRI, so I may do a CT scan for my stroke patients. And all recommendations are for CT scan as to rule out a bleeding. So why go for an MRI? It's a huge cost investment. And students there will work in places where they may not be even having a CT scan. So they will go on to clinical and a lot of things there. So look into your infrastructure, look into integrating devices. Today, all devices have got RS-232 ports, RJ45 ports with them. They integrate. They can integrate with your laptops, they can integrate with your dashboards, they can integrate even with your mobiles. So look into, when you're procuring these equipments, look into these things, are they tele-compatible for the future? Look into these things, whether they have or not. Then there are regulatory oversights, just skip through, and insurance and other things. These are 3 models, there are 3 or 4, like decentralized care, centralized, hub and spoke. We are applying the C1, the hub and spoke, but you can have Dandelion as well as holistic. I'll skip this. So there is still more future. What happens when in a zone of, say, 1,000-kilometer radius, there are almost 100 hospitals which have telemedicine? How does a patient choose where he has to go? Who will decide this? How will it be decided? So there comes AI. This is all futuristic. So the AI engine itself decides where this hospital or this patient actually goes to which hospital. It is helping you decide based on the quality of the service, the infrastructure capabilities, everything is connected. So while I go out from my home to a hospital, trying to hunt as people do now, yeah, I will go to Kokilaben or I'll go to CMC Vellore. Where should I go? So the signals come onto my mobile automatically. Okay, these services are available here, this is available here, this is the closest distance you go, these services are in. So there is an AI engine which is working and which will integrate and pick up patients to which hospital you go. You will no longer, in times to come, have the choice that I will call this patient home. It is automatically decided by this AI-powered engine, which looks within the network of all the teleconnected hospitals and helps you pull that patient to your hospital for the best of care. I'll just end this. To summarize, I would say it's here to stay. Change is inevitable, though painful. Adapt, adopt. Study your infrastructure before embarking on telemedicine and environments, you are understanding what is, for understanding the fall risk of these patients. So you are trying to go there right down. Use it to your advantage for better patient ED experience, hospital-based emergency care, transmitting or transferring itself to a virtual ED care. Bottlenecks must be abolished before widespread adoption happens. Thank you for a patient hearing. I know it is too much sometimes. But
No, it is not. It is the fact that, as you said, change is inevitable and, and it is, though painful. Painful in the sense that difficult to change at times. The regular thing, like when, for me, what the change is that now we have to enter each our case sheet in, on the computer, in the computer as well. So we feel so, they gave us those voice, like Google, yeah, so I'm speaking, the patient is, it is, probably my English is not British or what.
so there are dashboards now. When you speak, you speak Chinese, they will convert it into Indian.
Yeah, so I don't know. And
They will automatically bring it on. So work is going even to that level. So you don't have to write or scribble or type.
Yes,
You just
that's
speak
what
in
we are
front of
doing.
that. It will give out the treatment. So you say you want to write Zosyn 4.5 milligram TDS. So just say it. It will cross-check the dose. It will cross-check the indications, whether the creatinine is high, you need to optimize it. There is technology there going there, okay?
Yes,
So
yes, but I felt, oh my God, I'm taking more time to correct what is wrong. And I just thought, no. And then there is a letter from the administration that the usage is least in the emergency department where it was supposed to be the highest because the footfall is more. But then I was, okay, no, we'll start training ourselves. So we'll start giving us half an hour more. So that's it. So thank you so much, Dr. RK, for this. And especially when you have a flight, which you will miss if you don't really run. Thank you so much. So for coming all the way from Lucknow, Sai Sanjay Gandhi Postgraduate Institute, thank you. So we are now starting with our cardiology sessions, which would be the EM cardiology, which is sometimes, you know, these are the cases which are always there. So we are starting with them. And our first speaker is Dr. Naya Jamshed. Oh, yes, we are having coffee, but many of them I saw already had coffee outside. So, yeah, yes. Sir, I'm getting you a cup of coffee here. Sir, we can carry our coffee in the room. I'm so sorry. So we can carry our coffee in the room. That's not a problem. So please, sir is the additional professor of emergency medicine at All India Institute of Medical Sciences, New Delhi. Welcome, Dr. Jamshed, for your talk.
Thank you very much. Good morning to all of you, and I'm really thankful that you gave me this opportunity to deliver one lecture. So it's not about recent advances in cardiology. I hope that I am audible. Okay, so it's about your day-to-day case management in the emergency department, which should be based on evidence, the best evidence that is available at that point in time. So first case, a 30-year-old male came to the emergency department with breathlessness and chest discomfort. He had a unilateral leg swelling 3 days back, and you can see the vitals of the patient. Patient's breathing is 38 per minute with a saturation of 88%. Blood pressure is maintained at this point in time. So there is high index of suspicion for which disease? Pulmonary embolism. So we investigated the patient, and it's a copybook actually presentation, or all the investigation fall into the diagnosis of pulmonary embolism. So this is no-brainer. So the question is whether you thrombolize this patient or you will go with heparin. Anyone who, please raise your hand for thrombolytic therapy. You will thrombolize this patient? Okay. Anyone who go with heparin therapy only? Okay. Let's see the evidence. What are the evidence which is available? So this is nothing but submassive PE. And the first trial came in year 2002, published in NEJM, New England Journal of Medicine. And they gave, it was around 256 patients who were recruited in this trial. So in one arm, they gave altiplase with heparin, and in the second arm, they gave only heparin. And let us see the result. There's hardly any mortality benefit. 3.4%. Actually, mortality was much more in thrombolytic group. But patient who needed escalation of therapy was significantly higher, in which the patient received only heparin therapy. It's 10.4% versus 24.6%, and it was statistically very significant. Now, the question is, what do you mean by escalation of therapy? So was it increase in the vasopressors or putting the patient on mechanical ventilation or any rescue thrombolytic therapy which was required? So in this study, 32% of the patient required rescue thrombolytic therapy. Now coming to the second, so conclusion, heparin with alteplase improved the clinical outcome of the patient in the long run. Second trial was PITO trial, which was again published in NEJM in 2014, and it was about more than 1,000 patients. And they tried to see what is the mortality if you give tenecteplase with heparin or heparin alone. Look at the result. Mortality at 7 days was in favor of tenecteplase. There was absolute risk reduction of 3%, which was statistically very significant. What happened at 30 days? It reduces from 3% to 0.8%. What was the reason? Because most of the patients develop severe intracranial hemorrhage or any hemorrhage which is WHO grade 3. So it's basically hemorrhage which actually brought down the result of this trial. So what is the conclusion? Conclusion is fibrinolytic therapy prevented hemodynamic decompensation in this group of patients, but it increases the risk of hemorrhage and stroke. Now, another trial came in 2014. This is a top-cohort trial, recruited almost 83 patients. This trial was actually terminated early, citing the reason that the evidence is so much in favor of tenecteplase that we cannot continue it further. We have to give the advantage to the patients. So the major issue is that if we give thrombolytic therapy, there is increased risk of hemorrhages. So what is the ideal dose of these thrombolytic therapy? Is there any trial? So they tried to see which dose of alteplase or tenecteplase is safe, which actually provides some benefit without increasing the risk of hemorrhage. So MOPET trial came in 2013 in 121 patients, and they reduced the dose of alteplase to half. And what was the result? Half dose of TPA, meaning that by 50 milligram of TPA is as effective, and there was no case detected in which there was a significant hemorrhage. So, what is the guideline says? According to ACCHA 2020 guideline, which says that systemic thrombolytic therapy may be considered in a high-risk submassive PE. So it is maybe, this is a problematic thing here. You should come up with a very clear-cut guideline. ये तो मैं भी कह सकता हूँ. So for all the postgraduate resident, you have to thrombolize these group of patients, provided that you have to reduce the dose of thrombolytics therapy to half. Okay? So submassive PE, in my opinion, should be thrombolized with a half dose of recommended dose. So what do we mean by submassive or the high-risk submassive PE? If you do an echocardiography, if your right ventricles are very dilated, RV-LV ratio is more than 0.9. If there is evidence of pulmonary arterial hypertension, your troponins are raised, your anti-proBNP are raised, and the CTPA, if you do CTPA, there is a high clot burden, there is a high thrombus burden, if it is occluding more than 70% of at least one major artery or two intermediate group of arteries. In that condition, you have to thrombolize the patient. And if your ECG, we are using ECG very frequently, if it is suggestive of RV strain pattern like RBB is there, right ventricular hypertrophy is there, and there is T-wave inertia from V1 to V4, these group of patients must be thrombolized. Now, case 2. A 27-year-old nursing officer, it was about an emergency nursing officer who came to the emergency department with chest pain, nausea, and syncope. Airway, breathing, circulation, primary survey was absolutely fine, but we did an ECG. Any abnormality you can find here? Maybe some STT changes in lead AVL, and here in lead 3 and AVF, you can have a type 1 valence T wave, maybe. So we did troponins at 0 hours and 3 hours as per our protocol. and it was 0.2 and 1 microgram per liters. It was on higher side, so patient was sent for coronary angiography, and to our surprise, coronaries was completely normal. So are we dealing with something else? Yes, what it is? So we are just dealing with MINOCA. Have you heard about this term? It is, yes, I know that you know this. MINOCA is myocardial infarction in non-occlusive coronary arteries. It's a new term. Actually, it is not a new term. It is there for the last 80 years in the literature, but we are coming up with more and more information about this entity. So it actually fulfills the universal definition of AMI. Any postgraduate student who can say about the AMI definition, universal fourth universal AMI definition. If your patient is symptomatic, number one, if troponins are raised, if ECG changes or the ultrasonography changes are there, your patient is suffering. At least two should be positive. So presence of universal AMI definition is there. There is no obstructive CAD, meaning thereby that if you do angiography, occlusion is less than 50%. And at that point in time, there is hardly any reason for this clinical presentation. Studies suggest that it is more common, MINOCA is much more common in females, and non-STEMI is more common in this group than STEMI. So what are the etiologies? So coronary vasospasm can be there, microvascular dysfunctions can be there, and a spontaneous coronary artery dissection is very common, particularly in female, pregnant female, someone who is suffering from connective tissue disorders. So you always think about coronary artery dissection in a female who is less than 50 years, pregnant female. It can be associated with myocarditis, Takashimbo, coronary artery occlusion and thrombus, which can sometimes be missed on angiography. So do you think that MINOCA is something which is very benign? Not at all. MINOCA is not at all benign. Mortality, according to Sweetheart study or Sweetheart registry, and one of the meta-analysis is there, which suggests that mortality is somewhere between 2.4 to 4.7%. And 25%, only 1/4 of your patient actually will have persistent clinical features, maybe complaining about dyspnea, chest pain. So this will last for more than a year. Major adverse cardiac event at 1 year was comparable to single vessel disease or two vessels disease. So it is not at all benign. How will you investigate? If you do MRI, cardiac MRI, or you do intravascular ultrasonography or optical coherence tomography, you will be able to detect at least 85% of the cases. You can do TE, Doppler. Provocative tests should not be done in acute cases. For provocative tests, you can use acetylcholine. You can give acetylcholine and you can see the flow reserves of the patient, cardiac flow reserves. This is the image. If you do coronary angiography, you can see that there is hardly any occlusion in the epicardial blood vessels. But if you do optical coherence tomography, you can see what you can see here. This is dissection. And sometimes you can also say that there is plaque erosion with superimposed thrombus formation. And if you do some provocative tests, like if you give acetylcholine to this group of patients, you can see that there is microvascular resistance or there is a spasm here. How will you treat MINOCA? According to Sweetheart's registry, there is hardly any randomized controlled trial. So based on Sweetheart study, you can give statins, ACE inhibitors or ARB, and the beta blockers. But evidence is not very high. Maybe we are doing some MINOCA BAT trial. We are recruiting patients, and the results will be available by 2025. We will say that actually it is level 1 evidence or at least level 2A evidence. Important thing is that you have to know that there is no benefit of any dual antiplatelet therapy in this group of patients. Obviously, you will not send your patient for angioplasty, and there is no need for doing CABG. And you have to call the cardiologist because every time there is some problem, you have to need the inputs from the parent department. Case 3. A 45-year-old female was brought to the emergency department in cardiac arrest. After CPR, ROSC was achieved. Post-ROSC, patient's MAP is 67 millimeter of mercury Glasgow Coma scale is 8/15, patient is on ventilator, and this is the ECG of the patient. Can you find any abnormality? Maybe ST depression and T-wave inversion, but one thing is very clear that there is no ST elevation in this group. If you do troponin is on the higher side. Now, there is a big fight here, where this patient should go. Is it ICU or cath lab? Cardiologist will come and say that I will not do anything. There is no indication to do cath in this. ICU will say that, how can you say troponins are higher side? Actually, the problem is these type of patient will remain in the emergency department, and you have to manage it. So what is the evidence that angiography is actually not needed in this group of patients? It's based on some randomized control trial, and the number one trial was COACT trial, which was published in NEJM 2019. It was a multicentric randomized control trial having more than 550 patients with out-of-hospital cardiac arrest without STEMI. Important to remember that, please remember this, they recruited the patient who were hemodynamically stable with a shockable rhythm. Remember, every time cardiologist will say something else to actually pacify you. An immediate time to actually send the patient for catheterization was 2.3 hours in immediate group and delayed in up to 122 hours in delayed group. And they try to see what is the mortality benefit, what is the survival at 90 days, and how many of them survive with a good neurological outcome. Can you predict the results? This is the result. At 90 days, there is hardly any benefit in terms of mortality, in terms of recovery with a good CPCA score. So what they concluded that immediate angiography has almost no role in improving either the survival of the patient or discharge with a good CPCA score. So maybe it was done by some cardiologist who doesn't want to come at the middle of the night to intervene. So again, another trial came in year 2021. It was Tomahawk trial. It was a multicentric RCT done in more than 530 patients. So in one group, patient went immediately for angiography and PCI if it is needed, while in another group, it was delayed for 46.9 hours. And again, what it is different from COACT trial, that apart from hemodynamically stable patient, they included both main shockable and non-shockable rhythm, and they tried to see the mortality and the CPCA score at 30 days rather than 90 days. This was the only difference. They included patients who are having non-shockable rhythm as well. So can you imagine what is the result? Actually, it was worse in those group of patients who went to immediate angiography, and absolute benefit was less in those groups. So 8% difference was there. Mortality increased by 8% in immediate angiography group, and the composite of death and neurological deficit was worse up to 8% in that group of the patient without any proper advantage. So they concluded that post-ROS in out-of-hospital cardiac arrest patient without ST segment elevation, immediate angiography provided no benefit. So what is the guideline? Do we have any guideline? So guidelines according to ELCO 2020 and European Resuscitation Society, European Resuscitation Council 2021, they say that patient with a STEMI out of hospital cardiac arrest, you have to shift the patient to cath lab and do angioplasty if it is needed. There's no controversy in that. What about non-STEMI patient who is having out of hospital cardiac arrest, achieve ROSC? So it is needed only those subgroup of patients who are hemodynamically unstable, electrically unstable, or having ongoing ischemia. Otherwise, it is not needed to send the patient for angiography or possible interventions. So maybe this indication by ILCOR or ERC also change in the coming years once we have 2 more trials which is looking to the same thing, arrest trial results and the DISCO trial. They have already recruited more than 1,000 patients, and the results will be available in a year or 2. So thank you very much for your kind attention. So it's I think it will be a more interactive session because I have
Yes, we look out for questions because there are so. Oh,
Good morning, sir.
Good morning.
So actually, whenever I am talking about the Aeme-Con, so suppose a patient has come, a young female, and she is having a chest pain and trop test is positive in that situation. So initially, before going for the coronary angiogram, so always we think about that it should be an NSTEMI. So we will give the loading dose. So what should we do that in that situation?
There is no harm in actually loading the patients. You cannot continue the dual antiplatelet therapy for 9 months at least, which is recommended. So in that condition, if you load the patient with dual antiplatelet, there is no harm. Maybe your patient is suffering from coronary artery dissection, but you will be able to know after some time when you do coronary angiography and then optical coherence tomography. So in my opinion, you can go with the standard protocol management for any ACS patients. And later on, if it is already clear that your patient is not suffering from occlusive coronary artery disease, in that condition, you may change. You can avoid dual antiplatelet therapy.
Sir,
but you have to load.
Sir, in that situation also, suppose initially we thought that it is a case of NSTEMI and we go for the cath lab, and after getting the angio report, it turns to normal, of course.
In non-STEMI, why it is... you are talking about Aeme-Con.
Aeme-Con, exactly.
Okay.
So suppose it turns to be normal, then we generally do that, we stamp it as a unstable angina or like that. So
in unstable angina, there will be no raised troponins. So
okay.
This is the difference.
Okay.
So is there someone else who has a question to Dr. Jamshed? Yeah? No? Okay. Yes. Thank you, Dr. Jamshed.
Thank you,
It was a pleasure having you here, and I'm sure with a big round of applause, coming all the way from AIIMS New Delhi to share his experience with us. Thank you, Dr. Jamshed.
Thank you very much. Thank you.
Yeah. We will take a little more twist because of the flight timings of one of our faculty working in emergency department, and then come back to the cardiology session. So I welcome Dr. Arjun James for his talk on acute kidney injury. Yes.
Good afternoon, all. Thank you very much, Ashima Madam and team AEME for giving me this opportunity. And I feel really blessed and privileged again to present before my teacher, my professor, Dr. Suresh David, sir. I am his training product only. Okay, we'll go to acute kidney injury. Before, I have a happy news for you. I have some chocolates with me. So this is for the postgraduate registrars. If you answer, I'll answer some questions. So if you answer, you will get the chocolate. Okay, so oliguria, anuria. What do you mean by oliguria? Less than 400 ml of urine in 24 hours. In case of children, it is around 0.5 ml per kg per hour. Anuria means urine output less than 200 ml per 24 hours. So this is the definition, recent definition of AK. Can someone tell me which guidelines is this definition from? Very good. So full form of KIDGO? Kidney injury? Kidney injury? Oh, these are all my students.
All the chocolate comes to me then.
So this is KDIGO. If you go by the recent, actually it is very interesting to read about the literature of definition. There is one, so basically if you look at, you have KDIGO definition, then you have AKI network definition, so many definitions, around 35 definitions in the literature. So I want to make it a little bit clear. Acute kidney injury means there is a renal insult where there is a reduction in GFR, which occurs from hours to days, which results in decreased excretion of nitrogenous waste products, which leads to systemic side effects. That is AKI. For an EP, that should be so. So it is rapidly progressing. There is reduction in GFR. So how will you calculate the GFR? What is the gold standard for calculation of GFR? Gold standard. It is, I will only eat this. It is inulin clearance. What we commonly use is creatinine clearance. There is a formula for calculating the GFR. What is the formula? Very good, Corcroft got formula. Fine. Okay, you know the definition of AK. Whenever you have a definition of AK, you should stage it. Stage 1, Stage 2, Stage 3. Bit difficult to remember, 1.5 to 1.9, 2 to 2.9. Keep it as 1.5 to 2, 2 to 3, more than 3 times from the baseline. Easy? So, terminology, AKI, you know. There is one more terminology, acute on CKD. Sometimes you see in the patient has a previous renal kidney disease. In spite of that, he is getting an acute insult. Always, when you write an acute on CKD, there should be some, what is the acute factor which is causing? Most probably, it may be an infection, sepsis, or ischemia. And what is the chronic factor? Most probably, it is a diabetic kidney disease. You have different phases. Why it is important for us? Okay, because you have an initial phase of oliguria where the patient usually comes with fluid overload features. You need to tackle the electrolyte abnormality and your acidosis. Then you have a diuretic phase. We will see that the patient has AK and he comes, we see that, okay, the urine output is good. No, it doesn't mean anything. He may be in the diuretic phase. We are more profuse towards managing of hypovolemia and hypotension. Pathophysiology, always. What is a pathophysiology? We know that it is a reduction in GFR. So what is the prominent force for the GFR is a pressure gradient which occurs between the Bowman capsule and the glomerulus. So that depends upon your cardiac output. That depends upon your renal blood flow. So anything which alters the pressure gradient of GFR, reduction of GFR, AKI will occur. So anybody who know the definition of AKI and we look at the laboratory parameters, creatinine is elevated, we can diagnose AKI. But God has created emergency physicians to tackle it at the early point. So you need to anticipate AKI. When to anticipate AKI? Think, stop. Whenever you have a sepsis patient with hypoperfusion, hemorrhage, hypovolemia, renovascular insult, toxicity, patient taking NSAIDs, ACE inhibitors, ARBs, aminoglycosides, obstruction, patient coming with prostatomegaly, carcinomas, any parenchymal kidney diseases, anticipate AKI and manage it at early. So classification, you need to know there is pre-renal, renal and post-renal. So pre-renal, what's the most common cause of pre-renal? It's hypovolemia. Usually we see hypovolemia, hypotension and decreased blood flow through the disease. And second most common thing, what is the most common cause of post-renal AKI? Yes, it's BPH. I was thinking it was an nephrolithiasis. But when I asked the nephrologist, he told me that, Arjun, there is a thing. For a nephrolithiasis to cause an obstruction, it should be at least bilateral. If you get a unilateral obstruction also, most of the cases, he won't even get a AK. Usually when you get, most common causes, prostatomegaly, carcinomas, bladder carcinomas. So clinical approach to AK. First thing is evaluation of his volume status. So how will you assess his volume status? You can look at the hypertension, tachycardia, but very insensitive markers. It can be normal up to grade 3. Tachycardia, mostly elderly or the patients on rate controlling drugs, it may not be a good value. You can look at the JVP, lung auscultation, edema, IVC measurement. Then you need to rule out obstruction, send renal blood test, probable cause for renal function, urine microscopy and urine indexes. So coming to pre-renal, how will you know? By history, there are some features suggestive of any volume loss. Examination, you see features suggestive of dehydration. When a patient comes with dehydration, AKI and hypotension, usually it will be pre-renal. If it is an AKI with fluid overload and hypertension, most commonly it may not be a pre-renal cause. Renal cause, you need to review the medications and look for any signs of rhabdomyolysis. Post-renal, always you comes with ureteric obstruction, prostatic disease and this thing. This is a laboratory investigation which we see every time whenever you are studying about AK. The traditional urine osmolarity to serum osmolarity. That means if a pre-renal patient, your kidney is functioning mostly to conserve your salt and water so that your urine will be concentrated so that your urine osmolarity will be very high. Renal diseases, the osmolarity, the renal function is lost, so salt and water will be released, so your osmolarity will be less. And if you are coming to the excretion of sodium, if in pre-renal, kidney will be preserving the sodium, so your urinary sodium will be less. But when you look in the guidelines, it is, the recent evidences show that your fractional excretion of sodium poorly correlates with your pre-renal and your renal indices. Microscopic examination, definitely we sent. Imaging, what imaging you use? We'll just use a POCUS. When you see a hydronephrosis, we will just go for a plain CT-KUB, renal Doppler, and radiography. Biomarkers, yes, these are certain biomarkers which we use for early identification of AK. No biomarker is telling you that, okay, this patient is having, but can give you some clues regarding an acute kidney injury. So what is your treatment? As emergency physician, 5 things. First thing, rule out immediate life-threatening. Just look whether there is hyperkalemia, severe acidosis, correct it. Assess for adequate perfusion, yeah. Then, if the patient is having edema, you need to treat that, AK workup, and consider imaging if it is a post-renal AK. 5 things. So fluids, what you can use isotonic crystalloids in the absence of hemorrhagic shock rather than your colloids. What fluid of choice? The KDIGO, they recommend ringer lactate as the fluid of choice, has relatively neutral effect on the acid-base status and may reduce the risk of further AK compared to the normal saline. Coming to vasopressors, will you use vasopressors? Yes. If appropriate use of vasoactive agents can improve the kidney perfusion in volume resuscitated patient, even if the patient is having a vasomotor shock. Gone were the days, low dose dopamine that will increases natriuresis, increases renal blood flow, good effect. No, KDI, not using dopamine to prevent or treat AKI. Diuretic, $1 million question. Will you use diuretic to increase? No. The current recommendation to increase urine output in a oliguric AKI patient, diuretics does not improve the kidney function, improve the requirement for a dialysis, or improve the mortality. Rather, it may delay the initiation of dialysis. Initial initiation time may be delayed. But can we use it? Yes, you can use it for a volume overloaded patient. If it is in the management of volume overloaded condition, you can use the diuretics. So many patients comes to take erythropoietin, CKD patients in our ED to put infusion. So I just looked whether this erythropoietin helps in AKI. So I just saw a animal study which has a potential clinical benefit of erythropoietin in AKI. But there was one RCT in prevention of human AKI, but further tests should be done. I recently come across one terminology, RIAK. Anybody? Anybody know the full form of this RIAK? It's not radiation. Actually, it's rhabdomyolysis induced AKI. It's okay. How will you tackle rhabdomyolysis? Excellent. Aggressive fluid resuscitation. And not only just fluid resuscitation, you need to treat the cause. If it is a compartment syndrome which is causing this thing, what you should do? Urgent fasciotomy. Post-renal, yes, you need to relieve the urinary tract obstruction by your catheterization or stenting. Every time in the Viva, they ask you these questions of what are the dialysis indications for dialysis in this patient. You have a mnemonic, you can remember AEIOU, and dialysable drugs also as a mnemonic. Every time it's a favorite question. And can you tell me some trials of early versus delayed initiation of renal replacement therapy in AKI? Some trials? I think I have to eat all these chocolates. Yeah. Okay, sir. These are few trials. Align, AK, Akiki trial, Ideal ICU trial, and Akiki 2. Akiki 2 is the recent trial. Align trial is a single center study where they told that early initiation of RRT favors in AK, but rather all others one, there is no significant mortality difference between all other things. These are my references, and thank you, team AEME, for giving me this opportunity. Thank you very much.
Thank you, Dr. James, and it is always, I'm so thankful to Sir also to allow us, because it was his session, and thank you, and all the chocolates are going to me only because the session was preponed. I need chocolates. I'm hypoglycemic. Thank you, Dr. Arjun. It's always a pleasure whenever I interact with you.
Before you go, I have to have the last chance at pulling your leg. I'm going to do that by telling you a story. Okay? This is when I was in my first year of MBBS. And I had gone to the anatomy class. And my professor and head of the department, Dr. Mary Jacob, she actually was trained in Oxford in England. So we had to have these dissection classes, and so we were discussing the male genitalia. So she asked me this question, so tell me the structures on the coronal section of the penis. So I said, ma'am, on the coronal section of the penis, you have the dorsal vein of the penis. And she said, stop. I do not have the dorsal vein of the penis. Okay? The point I'm trying to make is for all of you. You see, when we teach, we have the habit of saying, you have, you have. Okay? It's a way of usage of English, but sometimes it's inappropriate. When I was sitting and listening to when he was telling me, when your renal perfusion goes down and you develop your oliguria, and then after that you will go for the AKI, I said, when did I last pass urine?
Thanks.
Okay. So you said that in patient of AKI or in CKD, where patient is actually in the volume overload, you can give diuretic therapy. There is a subset of patient where actually in acute AKI, acute kidney injury or chronic kidney disease, the patient is really fluid deficient, still the patient is having pulmonary edema, like escape, severely sympathetically crashing acute pulmonary edema. So have you experienced at your center so many patients coming with fluid overload pulmonary edema, and if you look for the IVC, actually it is collapsing?
Yes, sir. Actually, the intravascular status is less. Usually when we see in hepatorenal syndromes and sometimes in case of CCF also, when you see there are features suggestive of fluid overload, but when you look at the IVC, intravascular status is collapsed. So yes, definitely.
We invite the head of department of cardiology from Coimbatore Medical College to share his experience in EM cardiology. Professor Nambirajan, sir.
Yeah. Thank you, ma'am. Very good afternoon, all. At the outset, I'd like to thank Einstein and ma'am for having given this opportunity to be in this scientific forum. So, my talk would be, as you all know, the coronary artery disease is classified into stable ischemic heart disease, acute coronary syndrome, STEMI and NSTEMI. So we all know the STEMI has a complete occlusion of the coronaries. In NSTEMI, we have a partial occlusion or the plaque, rather than the plaque rupture, we have other mechanisms such as plaque erosion and your spasm, and we do have, as Jamshid has said, menopause were also being documented in NSTEMI. So why do we need risk stratification? Because we need to place them whether to treat them as an outpatient or to keep them in a step-down unit or a intensive coronary care unit, and for the selection of therapy as well as for urgent revascularization. So the TIMI trials which has been conducted, and it has the cumulative evidence, the cardiovascular death being the leading cause when it was followed for 12 months. So in any NSTEMI patients, the CV death has been the leading cause of death. It could be due to your late recognition and not offer the PCI and multiple plaques responsible for the left ventricle failure. So these could be the causes which were accountable for the cardiovascular leading death. So when we want to risk stratify, we should focus on the history, physical findings, ECG, and the biomarkers of cardiac injury. And we do have some time-tested scorings systems which have been used. So this is the one Braunwald's classification which uses the only the anginal pain and the underlying cause of death. So with this, we have class A, B, C, and the class 1, 2, 3 with the severity. So when you see the death or mortality in 1 year, you can see very well the post-infarction angina has the highest mortality, followed by the secondary angina. followed by the primary angina. So this increasing class has a risk of recurrent ischemia and followed by a high mortality rate. So with the ECG, we can risk stratify. What to see? We can see the ST depressions more than 0.05 millivolts and the T wave inversions and the new onset of LBBB. So this is regarding when to take the ECG. ECG has to be taken within 10 minutes. And if there are inconclusive, we need to repeat the ECG with 15 to 30 minutes interval during the first hour. We need any extra evidence if the ECG is not conclusive, but we have a clinically, if we have a consistent pain with the angina, we need to have extra leads looking for the posterior leads and your lateral leads. So this cardiac biomarkers, these are the most important one which differentiates from unstable angina to the end STEMI. So what to choose? Can it quantify the ischemia, timing and accuracy? So the HS troponin has been the time-tested assay apart from your other assays. So the early rise of HS troponin and its sensitivity and the NPV is very much high. So this is the assay which has been recommended by all the leading ACC and other EAC guidelines. So when to do? So at presentation, and there are two protocols being followed. Initially, they were looking after at 0, 3, 6 hours. And now the latest guidelines, as per the EAC guidelines, it recommends 0 and 1 hour protocol. If it is not advocated, you can follow 0 and 3 hours. So the 0 and 1 hour protocol is very much validated because of the high sensitivity of this HS troponin T. So this is a algorithm. When you have a HS troponin more than the upper limit, and if the patient is a highly abnormal troponin with the clinical presentation, you can straight away go for the invasive management. And if there are no changes after 3 hours, then you need to consider other differential diagnosis. And if there is consistent pain more than 6 hours, you can go for the scoring systems such as gray score and the other differentials to be excluded, and the patient can be discharged or subjected to stress testing if there are any intermediate or low risk. And when the ECG is combined with echocardiography, it gives valid information and you can high risk the patient. But you should know, even if the troponin is negative, echo showing a regional wall motion is a high risk indicator for an early intervention. So these are all some of the scores which have been used in risk stratification of the NSTEMI. The TIMI risk score tells us the 14-day mortality rate. When you have a higher risk for 6 or 7, the 14-day mortality is very high. You can see 40.9. This has been tested from the TIMI 11B and the ESSENCE trials. And not surprisingly, the higher TIMI risk scores have been correlated with the higher angiographically severe disease. So when you have a high score, this was proven in PRISM Plus trial. When you had a high risk score of 5 to 7, there were multiple lesions, left main disease, and with higher thrombus burden. So this is one of the important score which has been there for many years and been tested with various trials. So the more the gray score, the more the mortality. You can see the in-hospital death with the gray score more than 140. Its in-hospital death rate is high. And post-discharge 6-month mortality is also very high with the higher gray risk score. This is another score which can be predictive of the 30-day mortality. This is also an important score which can predict the 30-day mortality. So this is another risk classification which takes into the in-hospital adverse cardiac events. So which one to follow? There are a lot of scores. So, but the gray score has been tested in various intervention studies, and it has been found to be better outcome for predicting the mortality. So gray score more than 140 is a better one which predicts mortality. So this is for the low risk patients. You need to do some stress test, and intermediate risk also stress test can be done within 2 to 3 days with the submaximal protocol. So when taking out the ECG, you need to consider the LV hypertrophy, bun branch block, and other pre-excitation digoxin, and other. If it is associated, you need to subject them for a pharmacological stress echo and a myocardial perfusion imaging for later risk stratification. So in very high risk patients who are especially have a higher troponins and unstable patients, you need to go for intervention immediately. So in patients with a cardiogenic shock or a refractory angina or a hemodynamic instability, you need to do an immediate invasive strategy. And patients who have high Grace score more than 140, early invasive therapy within 24 hours, and initially stabilized patient, you can later on plan for a coronary intervention. So as I said, in hemodynamically unstable patients with cardiogenic shock, recurrent refractory chest pain, life-threatening arrhythmias, mechanical complications, acute heart failure, ST depression more than 1 millimeter. In these situations with the ST elevation AVR, immediately invasive therapy less than 2 hours is being recommended. And it has been found in various follow-up literatures that immediate invasive therapy in these sort of patients reduces the mortality. So early invasive should be considered in the dynamic STD changes and resuscitated cardiac arrest. Jamshed sir quoted a study. In that also the mortality was with the resuscitated outside cardiac arrest patients. It was found to have a better outcome with the early intervention. So the take-home message is don't underestimate end-STEMI. Because the STEMI mortality, as you all know, it is around 10 to 11%. The end-STEMI mortality is 4.5 to 6%. But the recent study from a follow-up of 3 years after the end-STEMI, the mortality is little more high when you don't intervene timely. So we need to intervene timely with the early risk stratification, and it will reduce the chances of your left ventricle failure and further sequelae and the increasing mortality. So in STEMI, we need to be aware the multiple vessels are involved, unlike your STEMI. So the chances of left ventricle failure, if not intervened within time, and the chance of not going for an intervention will lead to a higher mortality and left ventricle failure and other sequelae. Thank you so much for patient listening.
Thank you so much, sir. So risk stratification is very important a topic for us because there are times we have to answer. I look out for Dr. Einstein to probably put in some, how do they do on the other side?
No, yeah, calculating the Grace score is very important, number one. Mostly it's the patient. If the patient is having ongoing chest pain, diaphoretic, and and he's having, even though there is no ST segment elevation, you have to call the cardiologist because some of them will die if you don't. You can do clinical trials and you take thousands of patients, it will be diluted, If the patient is diaphoretic and having severe chest pain, you need to call the cardiologist and he has to go to the cath lab. That's very important. That's, I think...
it's an unstable plaque and white plaque. It's a different pathology. It will not be amenable for your any anti-platelets or GBT3BA inhibitors. The chance of embolism to the other arteries, it's very tough, multi-vessel disease. In fact, we are scared much about whether you want a STEMI or an STEMI. I would prefer a STEMI rather than an STEMI.
Yeah, but there will be STEMI. Patient had chest pain. Now he doesn't have chest pain. and the troponin is elevated, but now he doesn't have chest pain, he is chest pain free, that's fine. The cardiologist can come the next day and they can do elective cath and things like that. But it's all, I think, most important thing is you look at the patient and see, and that's very important.
And sometimes even in Prince metals, you may not have a situation which can be diagnosed easily, isn't it?
Yes,
so there's a vasospasm.
Yeah, there's vasospasm, there is the ST elevation.
But sometimes you may not necessarily have.
It will be transient.
Exactly.
Transient. It will be transient.
So you may miss that window period when it was happening.
So, sir, what we are doing in our emergency department, when any patient who is coming with chest pain, we are actually using the accelerated diagnostic protocol, and what we are using in our emergency, it's ART pathway, that you actually do an ECG and then troponin at 0 hours, and we are using at 0 hours and 3 hours. So ECG, repeated ECG done at 20 to 30 minutes is within normal limits, and at 0 hours and 3 hours, if your patient's troponins are not raised, then you can safely discharge, citing the reason that the major adverse cardiac event is less than 1%. So even if you do angiography in those group of patients, if you see that even after doing angiography, you are discharging the patient, major adverse cardiac event is around 1%. So how can you send every patient for coronary angiography? So this is the issue, sir.
This is the NSTEM he is talking about. So he's... Yeah, he was talking about NSTEMI.
We do something called a rescue PCI in NSTEMI. There is something called rescue PCI. STEMI, we know there's no doubt about it. Rescue PCI in NSTEMI, there has to be few indications. One is hemodynamic instability, ongoing chest pain. So ongoing chest pain and hemodynamic and ongoing chest pains and arrhythmias. Yes, so in those patients, you have to, even it's an NSTEMI, you have to take them for a rescue PCI. Yes, so this will be a criteria for angiography for an NSTEMI patient.
What you're saying is patient with chest pain, troponin negative, 0 or 3 hours. We are talking about
We are in a little tight so we have some people leaving by flight, and then and their flights are at 2 p.m., 3 p.m., and then we have our own beloved Dr. Suresh David sir for his oration lecture. So let us hear him first. And sir, I would appreciate you to please come on the stage, and all those students who are outside, and I've already shared the Zoom link in various groups. So please give a round of applause for sir giving the first oration lecture for AEME.
Can you give me a hand mic?
Yes, sir.
I find it difficult to be immobilized to the podium. Ladies and gentlemen, thank you very much for being here today to listen to this sharing of my experience. And I'm very thankful to Dr. Arunachalam and to Dr. Hashima for having invited me. And after I received the Lifetime Achievement Award yesterday, when I went back home, back to the hotel room, I was thinking, oh, so now what they're trying to say is they're going to say that my life is over, at least my professional life is over, and my achievements have come to a stop. So therefore, you're defining me and putting me into the museum. Thank you very much for that. I'm just pulling your leg. Thank you so much for inviting us to be here. I'm very happy to share with you what I think is the journey of my life through emergency medicine so far and the path ahead. So I'm going to spend a little bit of time on both. talk a little bit about the past, spend a little bit of time on the present, which you are aware of, and then also spell out what I think we can do or you can do in the future. So I'll talk about my early days. I cannot boast of a very sophisticated schooling. I studied in a very ordinary government high school, and this was in a small place called Darapuram, and it's not very far from here. In fact, this is actually the map of Coimbatore, and you can see Coimbatore is there, close towards the northern side, and this small place here, which is Darapuram, is here. In fact, if you look at a big map, you will not find it. It's not on the map. It's in the middle of nowhere. For me, the nearest railway station was 40 kilometers away. Even today, it's 40 kilometers away. And Coimbatore was around 70 kilometers, and everything was 60, 70 kilometers away. So I grew up in this very small place, studying in the government high school, and these are my classmates. We all got together in 2015. That's my classroom. So I studied in a very modest school. So I had these beginnings in this very rural setup. So therefore, although I have traveled everywhere and I can mix with everybody, I'm very comfortable on either spectrum of the population. After finishing my schooling, I went on to do my pre-university course at the St. Joseph's College in Trichy, subsequent to which I did my medicine at CMC Vellore. I did my MS General Surgery in Madras Medical College, as it was called those days, which is in Chennai now. It was really nice because my first love at that time was general surgery. I lived and breathed surgery. I really enjoyed my training in general surgery, and my passion at that time was to become a urologist. But I did spend some time in the casualty those days, and I found that the care that was being given to trauma patients was very, very inadequate. The worst experience I had when I saw that there was a patient who was being wheeled. See, in my casualty over there in MMC, you are the MO. You are posted there, you're sitting there, and the first person to meet the trauma patient is actually the barber. So the barber actually shaves the head if the patient has got an altered sensorium. He'll try talking to him. If he doesn't talk, he shaves his head, and then he sends him straight to the neurology ward, the neurosurgery ward. And there's a huge big hall. It's double the size of this, and there are 60 beds there. So all the patients are put into onto the beds, and in the morning they will come for rounds. So in the morning, if anybody is alive, they are taken for surgery, and if they are dead, they are taken to the mortuary. So I'm talking about reality, which we had in 1985 when I was doing my general surgery. So I thought, there's something we should do. I think this can be a little better. And one day, I saw this chap going past. I said, stop. Let me come and have a look at him. So I went and had a look. That was the neurosurgery registrar, whose head was shaved, and he was going to the neurosurgery ward because he had an accident on a motorbike. So that's when I realized that the truth hits you when you know that it is something which can happen to you, not just for anyone else. So therefore, when I joined work in Vellore back as an assistant professor of surgery, I was actually in the Department of Surgical Gastroenterology. And the only thing that I did throughout the week was look after patients who had GI problems, only from the throat down to the first part of the duodenum. Second part belonged to someone else. So therefore, only till the first part of the duodenum. So therefore, every patient of mine only had either an esophageal problem or a gastric problem. And I got fed up with that. It's very easy. I have a very limited attention span. So I get bored very quickly. And I realized, boredom was the thing which was setting in because I was looking after only these two things. And that's when I rekindled my passion of trauma management. And I conducted a study, I'll talk about that. But while I was studying in MS General Surgery, we had a very long study leave, which they gave us because most of us used to fail. In my batch, 49 candidates went for MS General Surgery final exams. Only 9 of us passed. So all the others failed. So therefore, we had a very long study holiday, and during which I went to work on the oil rig on the Arabian Sea. I was the medic, and I used to fly on choppers. go up and down, as well as transfer patients. So it looks like I had a dabble with emergency medicine and pre-hospital care even before I formally went into it, unknowingly. All these things I did without even a knowledge. And I used to fly with Pavan Hans. These are the kind of choppers which we used to fly in. While I was in Bellore, I did a trauma audit. I wanted to see what exactly happened, because my passion still was this trauma patients who were not being looked after well. And I realized over a 3-month period, when this trauma audit which I did, there were 18 patients who had died due to preventable causes. That was really a life-changing experience for me and an enlightening for me. So that's when I decided I have to do something about the caring of patients in the early phases of trauma so that death can be prevented. So my plan was to go to the US and become a trauma surgeon. Then I realized going to the US was not that easy. The other option was to go to Germany to do trauma surgery, and that was 9 years of training. And I had to study German. Not too happy about that. So that's when people talked about this particular program, which was in Australia. And it was to join as a trainee registrar in this specialty called as emergency medicine, which actually dealt with patients who were in the early phases of trauma and their care. I said, that's precisely what I was interested in. So therefore, I went and joined as a trainee registrar with the Australasian College of Emergency Medicine in 1991. Now, the college actually had started in 1989. So it is just a couple of years prior to my arrival there that the college had started. So it turned out that I was the first non-Australian to join the College of Emergency Medicine. And because I was already a general surgeon, they said, okay, then you can go straight away for 3 years of advanced training. You don't have to do basic training, go straight away for 3 years of advanced training. So I did have a great time over there, wonderful time. Really, really good. It was very, very enlightening. And yes, I enjoyed the beauty of Australia. And you can see that young lady who is there standing next to me. She looks still as pretty as she is at that time. She still is as beautiful as then. And that baby over there actually sits today in this auditorium as your faculty. And that's Sandeep. So that's his photograph about 32 years ago. But when I returned back to India, it was a different perspective altogether. Everything looked very dark. And that's because I was the one and only emergency physician in the whole country. There was nobody that I could speak to. There was nobody that I could call, ventilate with, ask questions, seek advice. There was nobody. And it was very dark for me for 3 years. And I felt that I was sitting all by myself, all alone, and with nobody else to talk to. So there were 2 ways by which I could have handled this. One is to look at it as a cup which is half empty, or I could look at it as a cup which is half full. So I decided to be optimistic. And I said, okay, if there's nobody else, and if nothing has been done, and if you know so much which you have gathered as a trainee registrar, why don't you try and do something for our own country? That's why you came back. Because I could have stayed down in Australia. My chief said, no problems, you stay back here, you be our consultant. My wife had a job. She could have stayed back. We could have stayed back without a problem. But I said, no, I will go back to India because the purpose I came with is to learn, to take back, and go back and teach, to share. So therefore, I said, okay, let me see what I can do. So everything that I did, everything we did as a group together was for the very first time. We established the first formal academic emergency medicine in India. Everybody thought of it only as a casualty. We said, no, no, no. Casualty is old time. Now it's emergency medicine. So we formed the first department. We did the first manual because I wanted standardized care because every person was teaching things differently. There were no set standards. So I said, no, 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 we will draw protocols for every single case, and we made this manual of emergency medicine. That got printed eventually, and today I think it's the 9th edition which is still going on, Handbook of Emergency Medicine, which some of you have seen. So it started in the department, printed by the local person for whom I gave the money, So that's how we started this manual of emergency care. In 1996, I decided I'm going to send my charge nurse to Australia, to the same center where I trained, because I tried telling her things which was totally new to her. She said, no, but we never studied and trained all these things. I said, yeah, you trained to be a nurse, a registered nurse, but today you're going to become an emergency nurse, which is different. Because I knew at that time that unless we have the nursing team going along with us, we will not be able to improve our standards of care. They need to be side by side when we are progressing in this field. So she went to Australia, trained as an emergency nurse. I put her into the module. There's an emergency nursing module. And it was no surprise, Indians, we do very, very well. She was the top in the group. She passed out as the best outgoing student in that particular group of training. And in 1997, I put together the concept of trauma team. Now, this is something which I want to talk about because although I established it in Vellore in 1997, it still is not prevalent all over the country. This is a synchronous approach where when you have a patient with polytrauma, you got people, designated people from the various specialties who come down together, see the patient together, make a decision together, investigate together if required, and then take the patient to theater on work on the patient together. That I don't think is prevalent in most parts of the country. And it's very interesting that I wanted to show you Dr. Ashima. You see this young man sitting there? Standing and trying to put a cannula? That's the Bashish. Okay, that's Dr. Debashish Adhikari. Most of you would know. He's now one of the doyens in pediatric emergency medicine in the country. So, yes, and yesterday or was the day before when somebody spoke about ultrasound which was done in the US in the 1990s, we were well into ultrasound because CMC Vellore received the first ultrasound of the country. It was a refurbished machine which came to us from Japan. It was a Toshiba machine, not a brand new one. We got a second-hand machine from Japan and we sent the radiologists to learn how to do ultrasonography to Japan. That's how we started sonography in India. But I incorporated it soon after that, and we were doing ultrasonography in the emergency department as POCUS right in 1997. We started the fellowship in emergency medicine. It was the first of its kind in 1997. 97 was fantastic because this particular program was to facilitate the learning, and I sent my trainees and told them, don't stay here, go away. Go to the various parts of the country so that you will be able to teach and make sure that people understand what exactly emergency medicine is all about. It is also very special to me because that is when I wrote the first proposal to the MCI to recognize emergency medicine as a separate specialty because it did not exist. So although I wrote the first draft in 1997, it took me 3 revisions and many trips to the MCI building before in 2009, MCI recognized emergency medicine as a separate specialty and then said, okay, I think we should be able to start MD emergency medicine. It was very easy because I had given them the full curriculum as to what needs to be done. So that's how things have gone on. And in 1998, we put together a program which is called EMTC, Early Management Trauma Course. And this is something which I had learned by the Royal College of Surgeons in Australia. And some of my contemporaries had done ATLS in the US. So together we got together and did this EMTC. And it was a program which had a moulage, everything it had. It had workshops, and we used to do on cadavers. In the anatomy department, we did life-saving procedures on cadavers, which is totally different, which is totally more realistic. And there was an exam, and the pass mark was 85%. The reason is I did not believe in this provider course and a training instructor's course. I said there is one course, and I train you not to be a trauma clinician. I'm training you to be a trauma team leader. One and only course, but you will go through it and you will secure 85%, and only then I feel that you're fit to go out into the country and be part of the learning process which needs to take place all over the country. So therefore, that's something that we also said. Somebody said the government hospital expects patients to come to you. No, I think the emergency department needs to go out to the community. So way back in 2004, we had this injury prevention programs. So we used to go out to the high-risk groups, which were students in colleges, in schools, in the later years of schools, to housewives, to people who worked in factories, and we talked to them about first aid. We taught them CPR. This is way before the Indian Resuscitation Council came into existence. So we were doing all these things those days when we went out. You can see the people are sitting. These are all factory workers who are sitting there in the uniform. Children. What we did was we did puppet shows. So children would sit and listen to what we are trying to tell them. So you sow the seed early, then you find that people understand what you're trying to talk about. So there was a story when somebody came back and told me that there was this 16-year-old girl who had listened to the injury prevention program 2 years earlier when she was in school, and she had left school, and she gave CPR to her father in the house, and then brought him back to the emergency department, and he was alive. So it was very gratifying. Those early years were good fun. And it was in the year 2004 that the tsunami struck India. So people at that time did not know the spelling for tsunami. But I had learnt about it as part of my learning in emergency medicine. So we were able to take a team and go out and work among the tsunami survivors in Tarangambadi area, which is close to Kadalur and Pondicherry, that area. So we were the first ones to go. And the collector was in touch and said, "Sir, can you please help us?" I said, "Yeah, sure, definitely we'll help you." So with the government, we were working together. We spent about 2 weeks over there, and we have a log, and we saw that we had worked on 5,000 patients who are survivors. So we provided the early emergency response to this group due to this natural disaster. So therefore, in many ways, we were the top. Yes, we were the largest emergency department. We had 40 beds those days, and we were recognized by the WHO to be the South Asian Training Center for Emergency Nursing. Yes, we could have been riding high. No, not really. Because I was speaking from an isolated ivory tower once again. Because the rest of the country was struggling. This is the emergency department of a medical college hospital. It is built outside the hospital campus, behind a hospital campus, and this, Dr. Ashima, is a photograph in Hyderabad. Okay? I'm just telling you that this is how the situation was. So I asked the person, the medical superintendent, "Can you tell me why is the emergency department outside the hospital and at the back?" He said, "Sir, it's very easy, because when the patient comes in and when we finish the documentation and everything, if the patient dies, it's easy to shift him to the mortuary." I said, "Okay, all right, I get the idea now." So therefore, this is the accidents and emergencies department, okay? So there was this small little place in Vellore which was struggling to be the beacon for the rest of the country. It was tough. The early years was very tough. I was flying alone for a very long time. But not too long, because soon I had 3 people who were flying with me. One was St. John's Medical College, the other one was Apollo, and the third one was SRMC. All these 3 institutions came forward, and they started flying along with me. Then one by one, more and more people started flying with us, and soon we were having a big flock. And the flock is getting bigger by the day. I have not come for one of these conferences for emergency medicine for about 3-4 years, and I see that the numbers have just exploded. I am so happy. I am so happy and relieved that what we started has now really mushroomed, and it is doing so very well. What were the challenges that I had in the past? I will not call it as obstacles, I call them as challenges. Because I was at the stage when I never considered anything to be an obstacle. I only considered it to be a challenge. I need to get over it one way or the other. First and foremost was the acceptance of the specialty. That was my major problem. First thing they would do is to stare at me. Yes, this is a photograph I took in Kenya, by the way. So it was very uncanny, because we tried to outstare each other, but I failed and the leopard won. But the question that I was always asked is, what's wrong with the old casualty system? We have done that for the last 100 years. What can you tell me? I'm a professor of surgery, I'm the professor of orthopedics, I'm 30 years older than you. What can you tell me new? Why do I need to have another specialty to teach me how to manage trauma? Sir, we are not trying to teach you trauma. We are going to take care of the early phases of trauma. We will resuscitate. Resuscitation? My boys can do that. They can start the IV. My biggest contenders were my own colleagues who were 10, 20, 30 years older than me. So I was literally fighting with them. What you see of me today is just a fraction of what I was. I was tough. You will not believe. But they were the biggest. And the second possibility, the second obstacle or challenge, was the acceptance of competence. They were asking me, neurosurgeons would ask me, what do you know of GCS? You're talking GCS? That's not your territory. Procedural sedation, RSI. Anesthetist came down to the emergency and said, excuse me, are you doing RSI here? Who gave you permission to have muscle relaxants? It's our domain. You can't be doing that. Then I had another group who said that they were afraid of losing clientele. The gynecologists, the radiologists, ultrasonography, you're doing in your department, who licensed you? How can you do this? And radiologist said, if you start doing ultrasonography, how will I get my patients? My trainees are there. I said, see, look, we are not taking any of your patients. We are only doing this as a routine and we are not doing anything spectacular. I'm going to put the probe and see if there is any fluid in the abdomen. That's about all. So the worst challenge was our own professionals. And you don't have any of these problems today. And you think you have problems? Ha! You don't. Trust me when I say that. Okay? So I used to think, is India struggling due to EM? Lack of it? Or is EM struggling due to Indian ignorance? Which of this is the truth? And why am I like the monkey in the middle? What am I trying to do? So when I looked at it, yes, first question, is India struggling due to lack of emergency medicine? It is, because those days, when the cosmopolitan cities started having, it was restricted only to the metropolis and to the private institutions, nowhere else, not even in all of the medical colleges. The second problem was that the district hospitals were the worst affected. So by this time, we had grown along, and my classmate and my roommate was the health secretary of Andhra Pradesh. Then it was only one state. So he called me over to do a full survey, tell us what can we do for capacity building for district level hospitals. So that's when we started putting together a program for hand-holding and capacity building for district level hospitals by having the hub and spoke kind of a concept. But as usual, what happens is when everything has been drawn, our budget was 800 crores, sanctioned, organized. That's when the government changed. And P.V. Ramesh Babu, who was my classmate, who was instrumental for this, was transferred from here to Delhi. Fizzled out. That's the end of it. So even today, this is something which still has not been sorted out. And we did not have any uniformity in healthcare delivery. We heard about it even today. We talked about it. See what happens in Kokila Ben. Something which, we can all be envious of. But the ground reality in some of the hospitals where many of you work in rural areas, it's totally different. Even today, after 30 years, there is no uniformity. You take, for example, the US, or take Australia or New Zealand. Any place you go, you have the same kind of standards. We do not have that in our country. Is India struggling due to lack of emergency medicine? Well, this is the problem. We are unable to populate the government medical colleges with EM-trained faculty. What India has done now is that they have made sure that they have mandated that every medical college will have an emergency medicine department. But because we do not have EM-trained faculty, we are only asking people, we are telling people, go and work there. But some of our doctors, by choice, have moved because they have decided that where they are, they can work better in another place, which is the emergency department, which is an area of need. But by and large, most people have been put in there without their permission or without their full consent. That's our problem. What did I wrote something there. Yes, I wrote something small to remind me. I'm talking about the MCI saga. In fact, Arjun just left. I wish he was around, because we were going in for inspection, for MBBS inspection. Okay, this was in the year 2012. At that time, I was the medical director of Pushpagiri Medical College Hospital, which is the first private medical college in Kerala. And we were going in for MD in emergency medicine. And I had these inspectors who came. I'm pulling your leg. Who came and said, so Arjun was a postgraduate student at that time, so I said, Arjun, and you know he's got the gift of the gab. So I said, Arjun, you go ahead and you take these MCI people and show them around. So Arjun was, busybody that he is, he was trying to show, and he said, sir, this is our emergency medicine department. Emergency medicine department? Yes, sir, this is our emergency medicine department. Very good. Where is the emergency surgery? Actually, my jaw dropped, and I looked, and Arjun also, as usual, he did that. So we had to close our jaws. So this man was actually the MCI inspector. So I said, sir, only in Sweden we have emergency surgery and emergency medicine. In India, we do not have that. Where is your casualty? Sir, casualty has now transformed into emergency medicine. So where will casualty patients go? Sir, they don't go anywhere, sir. They come here. Oh. So, these are the people with whom I have dealt. You don't deal with these people. Today's NMC will come to you and say, show me whether your vascular probe is working well. Show me where exactly is your ultrasound. Show me how exactly you're using it. Days have changed. Those days it was very, very difficult. Now, what actually is the core problem? So I try to analyze where are we going wrong, or what did we go wrong in, or what is the current problem? First problem is that the Medical Council of India, not the NMC, which I hope will be different, I'm talking about the Medical Council of India, considered everybody equal. So when I tried to tell them, see, look here, all other departments are 8-hour departments. They work during business hours. After that, they're on call. So therefore, when you allot the number of seats, that is suitable for an 8-hour department. Emergency department is a 24-hour department without any break, 365 into 7. So therefore, you need to allot 3 times the number of trainees. If you're allotting one candidate for a professor, you need to allot 3 candidates for a professor, because we have 3 shifts and they have to go on rotational postings. Please, all departments are equal. We cannot have any variation. Okay, so what is the consequence of that? We have inadequate seats. We do not have the numbers necessary to populate. So therefore, I'm sorry, I know you can't probably see that slide. It reads lack of training emergency departments in the medical colleges. We have emergency departments, but they're not training departments because none of the people, the faculty, are trained. So if you are not trained, how are you going to train somebody else? So therefore, all our emergency departments in most of the government hospitals, in my opinion, in my knowledge, there's only one person in India who has done a postgraduate training in emergency medicine, who is now working as faculty in the emergency department. I know she has undergone a full 3-year training in emergency medicine. Other than her, I don't know if there's anybody else who works. So therefore, because of this, what happens is there is no undergraduate EM exposure. When there is no undergraduate emergency medicine exposure, there is a problem. The problem is there is inadequate PG training and inadequate people who are really motivated to come for training for emergency medicine. And the government hospitals, I'm not talking about medical colleges, I'm talking about the government hospitals now, the non-teaching hospitals, there is no emergency medicine. And you find that the NMC inspectors are not EM familiar. They do not have a concept. When we were trainees, right, Dr. Arunachalam, we did not have emergency medicine. You and I got exposed to it when we went overseas. Most of these people who are working as senior faculty in government colleges, who are inspectors for emergency medicine, do not have a concept about it. That's why we had that the difficult situation with emergency surgery. So therefore, once again, it comes back to it. The MCI says, look, you're all the same. So this goes on. So we got to break the cycle somewhere, and somebody, somewhere, if you can do something, something will happen in our country. Because you find that the present status still, this is a picture of a hospital which emergency department, and you will find accident and emergency, and below that it says casualty emergency. There are 3 names on 2 notice boards. Okay? Because everybody is confused. So the few departments which are there are like oases in the desert. Okay? Literally that's what they are. And casualty continues to linger. Trust me, in CMC law, I'm saying it openly, people still refer to it as casualty. That's the problem. It didn't once upon a time, but now it does. So there is a significant variation. That's what somebody was also saying. There's a variation in training, especially in the corporate hospitals, in the government hospitals. There's a lot of training and variation, and thereby in the competence of the people who are coming out. These are all the challenges which we have. And there's poor networking. At least 5 people during the last couple of days, I've heard them say in their talks, our sample size for research has been very small. There's nobody, the sample size, more collaborative research is required. Multi-centric studies are required. Why don't we do it? Why do we just talk about it and whinge about it? That's what is required. Well, as they both have declared, I have reached the evening years of my life, my professional life, which is true, which is true. This is a picture I took of a sunset in Ran of Kutch, which Rathinder was describing. Last week I was in Ran of Kutch. So it's beautiful over there. So therefore, what do I need to do? I need to pack my bags and I need to go home. I need to, because my time is over. It's your time, guys. You need to take over from here and you need to do the job. But before I go, I want to refer to a verse in the Holy Bible. It's in the book of Luke, chapter 10, verse 2. It says, the harvest is ready, but the laborers are few. This was written such a long time ago, and it is true. The field is so big, but the laborers are so few. What exactly is the reason? Why exactly is this happening? There are postgraduate possibilities. One can do diploma of the National Board of Examinations. You can do your MD Emergency Medicine. You can do MRChem. You can do your MEM. You can do your FACE, so on and so forth. But when you analyze and you see that there are wheels within wheels, there are a lot of complexities, and there are a lot of multiple problems in these things. I don't want to go into this because that's yet another talk by itself. But I was trying to see whether we can get all these things together, and I think some people are working towards looking at a unification of standardization so that these courses can all be considered to be something which is really worth it. When we look at the national board, when we look at the MCI, this is the NMC, the website, and I had a look, and you can't see it. It says that there are 415 medical colleges in India at the moment. Somebody was saying 600, but no, the 630 I think takes into consideration homeopathy, Ayurveda, and all those things. I'm not really sure, but the NMC, the website, which I saw 2 weeks ago, said 415 colleges. That was the total college count. And I also saw that the number of colleges which were doing MD emergency medicine was 33, and the total number of seats was 129. Same thing with diploma. The diplomate of the National Board of Examinations also has got a similar situation, and I put them here so that you can see it better, because I don't like this copy and paste from the web, because you can't read anything. So NMC has got 130 seats. Please correct me if I'm wrong, Dr. Asima, because this is what is given in the website. The National Board over hospitals has got 100 seats, and the total number of seats are 230. Okay, these are the people who are eligible to populate our medical colleges or teaching institutions where there is DNB or MD emergency medicine, and the number of faculty required total, very simple, 1,700. And it's going to take us 8 years to populate all the medical colleges now. And every day they are recognizing more and more colleges. So therefore, you see, the problem is we have this. I call it the leaky bucket syndrome. You keep pouring on one side, but there are multiple holes. Multiple holes because people who are doing MD emergency medicine are going away to do subspecialization into other things. The first batch of MD, there's nobody who's in India. The first batch, which did MD emergency medicine, nobody is here in India doing emergency medicine. They're either gone abroad or they're subspecialized into other things. So on and so forth. Then we have another problem, and the other problem is this. That's called as a human capital flight. Human capital flight is nothing but also known as brain drain. And that is the departure of professionals from one country for another, usually for better pay or living conditions, causing loss of skill and intellect to the place where they belong. This is reality. This is what is happening in a very big way. So how are we going to hold? What I thought is 8 years is actually not 8 years. That's a theoretical extrapolation. It probably will take 18 years or 28 years. I don't know. Because every day hundreds of people are going away from here. So therefore, when are we going to have enough people to populate our own country? So please remember this picture, the leaky bucket. Okay, this is reality in India as far as our personnel are concerned. So how do we light, how do we ignite the fire of desire for our people to make sure that they become emergency physicians? And I believe the answer for that is to make sure that you talk to the medical students who are in the early formative years of their minds. If you ignite the fire of desire in them, you will have emergency physicians. And today, in this auditorium, I want to say I'm very proud to see that I had done this. Dr. Ram, will you please stand up for me? Thank you. Please sit down. Ram came to me soon after he finished his MBBS. In my early years as an emergency physician, I came back to India in 94, and I think he came in 95 or something like that. He spent 6 months with me. He had a life-changing experience. He went to the UK, worked for 20 years, gathering all that he required to come back to India and to serve. We salute you. Similarly, we have people who have had this life-changing experience because I had the opportunity to interact with them. So I believe that the answer for this is to make sure that we have EM as part of our undergraduate curriculum. And this is what, Dr. Ashima, if you can use your what you can.
We already wrote a letter to NMC, and it is in the curriculum. 2 weeks of emergency medicine undergraduate is mandatory.
Excellent. I'm so glad. I'm so happy about this. Because we have already started doing it, not now, in 2004. Okay. I only introduced one person. There's another person also who is over here. He also did an elective posting during his MBBS days. and then subsequently he worked in the emergency department as a requirement, and he then decided to do emergency medicine after doing MD anesthesia. Sandeep David. Okay? So, like this, I come across a lot of people in various meetings who have done this. And the fact is, you need to strike them when they are young, when they are moldable, and this is what I'm telling all of you. All of those of you who are working in medical colleges, or going to work in medical colleges, make sure that you become people who will inspire young people to take up the career of emergency medicine. And that is my plea to all of you, okay? So my two eyes, I call them, because with these two eyes, I can look into the future. And what are these two eyes of mine? First and foremost is pre-hospital care. It's very much part of me, okay? And the second one is emergency nursing. Emergency nursing. Pre-hospital care, I was part of the Royal Flying Doctor Service, not now, in the year 2000. So it's 23 years ago that I was part, as a consultant in Australia, I was part of the Royal Flying Doctor Service. I used to fly on fixed-wing aircraft. We used to transport patients from Alice Springs down to Adelaide. I was a consultant working in Alice Springs, and I used to take patients down. This is a chap who had a spinal injury, because we had to transfer spinal injury patients to Adelaide, which was 1,500 kilometers away. So we used to take this fixed-wing aircraft and go. So therefore, I know the value of pre-hospital care. I used to work with ambulance officers. I was a registrar. I was about your age, in my early 30s. And I used to enjoy going with them. Not only were they doing a lot of very challenging work, they also lived their lives well. I really enjoyed going out with them and doing the things that they did. You know how the ambos are.
Yeah. Actually, in US, we have 1 month rotation with EMS, and we go in ambulance, and it's very difficult.
Yes.
Like they don't have a light, and they have to intubate,
on the street.
They don't have suction. It's raining. The accident side.
It's fantastic.
It's fantastic.
But it's really challenging, It brings you back and makes you realize, hey, don't complain about your emergency department. You don't know what the guys are doing out there. So I really had a great time working with them. And when I was invited to the US to come and speak to the American College of Physicians, of emergency physicians, I was talking about trauma systems in India, and this was way back in 1998 or something like that in Chicago, when the ASAP meeting was held. And after that, I went to Minneapolis because I wanted to redesign the ambulances in India. So, because I was very impressed by the fact that this particular design, where you have a chassis and you have an aluminum body which is fitted on top of it. So when the chassis becomes old and needs to be replaced, you just pull out the chassis and put the aluminum box onto another chassis. So when I talked about this to Mahindra those days, they said, why don't you come to Pune? So I went to Pune, and from there I was driven somewhere to one of those factories. I don't remember where they manufacture these. And I showed these pictures and I said, look, I spent a whole day. I have a whole lot of photographs and everything else and designs. They looked at all of it and said, sir, this is fantastic. But I want to tell you one thing. If we do this, how will we sell our ambulances? Because you are only going to change the chassis. Once I make an aluminum box for you, you're going to keep that for the next 100 years. So therefore, I'm sorry, we're not going to do this. So therefore, there are a lot of problems. This is what I mean. There are wheels within wheels. There are people with vested interests who do not allow certain things to happen. And this was 25, 30 years ago. Okay? So, EMS in India to me is very, very important. Yes, it is happening. I mean, the BSc EMT program was started by the MJR University in 2002, I think, and we had the first emergency nursing and EMS conference together in the 5th National Conference of the Society of Emergency Medicine, which I conducted in Vellore in 2005. We had a total of 650 nurses and paramedics together, and we had a program for them. So since 2005, EMS has been part and parcel of emergency medicine. They've been conducting conferences and everything. But when I see this particular article, which was written in 2014, it says that currently India does not have a centralized body which produces Guidelines for training and operation of emergency medical services. I don't think much has changed in 2014. We do not have a centralized body. Yes, we do have training courses, we do have conferences. Oh, we just had a conference also, right here with us. And we had people coming and saying, you know, in my department, I do this. In my institution, I do this. Yes, we are so proud of you, what you're doing. But my question is, where is your regulatory body? Who regulates you and tells you what you're doing is correct, what you're doing is right? Who certifies that you're doing a good job, except yourself, patting yourself on your backs? My other concern is, where is the communication? 25, 30 years ago, people used to talk to us when I was a registrar in emergency medicine. They used to talk to me on the radio and say, I'm bringing this patient, doc. This is the problem, this is what is happening. ETA, 3 minutes. So in 3 minutes, I had the department ready to receive and I was at the door. Today, it doesn't happen. Why is it in these days and ages when we heard Ritendra talk about apps and everything else, why don't we have a very simple radio, a two-way radio, one in the ambulance and one in the station in the hospital, where they can call us and tell us? We get into activity only when the doors open and a patient comes in. I think this is something we need to look at. And the other very important thing I'm concerned about, what is the legal protection for my EMS people? If there is no regulatory body, there's nobody to write a constitution for them. There's nobody to apply to the parliament. Where is the protection for them? What are they allowed to do? What are they not allowed to do? Nobody knows. Where is indigenous research? That's another problem. We are only using and transplanting information and data from overseas. Our needs, our requirements are totally different. We need to have indigenous research, and that can happen only when postgraduate studies come into the picture and when we have a regulatory body. This is the logo of the National Association of Emergency Medical Technicians. This was established in the year 1975 in the US. 50 years, nearly 50 years, have gone by. Where are we? Nowhere. Do we have a national logo for the country, for EMS? No. This is the situation, people. People talk very big. They say, oh, it has grown so much, it's grown so well. It has grown as isolated islands of excellence, not as a nationwide development. It hasn't happened. So we need to see, when are we going to change the scenario? When are we going to have the paradigm shift? I mean, we have people like Venugopal sitting over here. He's been doing ambulances for so many years. I want people like him. I want people like Prasad Hans or Shubhrata Das. All these people, they have been working for decades. When are you going to join hands? Yeah. You have been working isolated. When are you going to hold hands, go together, draft something, put it to the government and say, look, 50 years have gone since this was done in the US. When are we going to wake up? Where's the protection for us? And that's what I would implore that you people do. Okay? Diploma in emergency nursing, the WHO granted me the certificate. So my first nurses who did the diploma was actually, they were endorsed by the World Health Organization. And I did this in 2002. But today, after all these years, do I have an MSc in emergency nursing? No. PhD? What? No. When we do not have academicians, when we only have at the technician level, where is the possibility of research? Where is the possibility of formalized education? We are training people to be only workers. We are not training people, our co-workers, that's the EMS and the emergency nurses, to be leaders, to be teachers, to be researchers, so that we, the thousands of patients that we look after, we should be able to collate the data and teach the world, not receive from outside. Think about this, people. All you young people who are sitting there, think about what I'm saying. People talked about COVID and all the things that we did learn and didn't learn. As far as I'm concerned, I am very thankful to COVID. Trust me. In spite of all the trouble, that everybody went through. I'm thankful to COVID. For you know what? First and foremost, it gave the concept of infection control and personal protection equipment to whom? Not to my workers, to my administration. Said, oh, so we need to provide the emergency department with all these things. Okay, okay. So I'm very glad, because when it has come, now it has come to stay. Because now I see the emergency department, everybody is in scrubs now. Everybody, this did not exist before COVID. COVID brought in scrubs, COVID brought in PPE, COVID brought in infection control, COVID also brought in biomedical waste control. Fantastic. Thank you, COVID, because you have helped my staff to be protected. I'm very happy. Are the tasks over? No, we still have lots of things to do. That's what I'm going to leave with you, because as I said, they have declared that my time is over. Okay, now I'm going to pursue my passion. By now you'd have realized what it is. It's photography, bird photography. That's what I'm going to do. So my unfinished task, I'm going to leave with you. Okay, first and foremost, make sure that you establish an EM policy for district level hospitals. I don't know whom you're going to talk to about this. You are doing it for medical colleges. Corporate hospitals have done it. Who's going to take care of the majority of the Indian population? The majority of the country, as you know, ladies and gentlemen, lives in the villages. And that's where I come from. To go to my taluk office, the taluk headquarters, I had to go to Tirupur, which is 40 kilometers away. Trust me, those days, when I was a young doctor like you, I had finished medicine. I was working in the hospital, in the small little rural hospital in Darapuram, where one of my nurses yawned and she dislocated her jaw. That was the first time I'm seeing a person who has got an open mouth and she's trying to say something. I said, what are you trying to say? And she's drooling in her mouth. Is this rabies? Why is she drooling? Stand far from me. What are you trying to tell me? And she's trying to tell me, So I said, God, why are you not speaking to me? I don't know what's going on. I didn't have anybody to talk to. So the first thing I did was I put her in the ambulance, took her to the district hospital, straight away. District hospital was only 82 kilometers away. My district was Erode. So I traveled for 3 hours, took her to the government hospital in Erode, government hospital, district government hospital. Took her there, and I'm saying, doctor, this is the problem. This lady has got, I don't know what, suddenly I think she yawned, and then after that she's not able to close her mouth. She said, oh my God. And he was just staring at her, she was staring at him. And I said, what specialty are you? I'm a psychiatrist. You're a psychiatrist? Why are you in the emergency at 2 o'clock? I don't know, I've been posted here. Okay. Now, whom can I talk to? Is there anybody? There's a surgeon, sir. I said, very good. I will speak to him. So now it's 7 o'clock. Because, mind you, this happened at 2 o'clock. Then we started driving from there. By the time we reached, now it's 7 o'clock. By the time we finished with the psychiatrist. And he says, you can't talk to him now. He will come to work at 9 o'clock. Okay, we will wait. So 9 o'clock he came. He doesn't know what to do. Mind you, it's just a dislocation of the jaw, okay? And he started giving her injections in the TM joint. And I'm sitting and watching, oh my God, what's he doing? You know, in the face, he's, wait. And then he tried, nothing happened. Finally, they took her to the theater. Sure enough, after induction, she relocated herself. And they brought her back. These are all things, you know, it sounds, yes, mind you, I'm an old man. I've gone through all these things and they sound so funny to you today. But this was the reality in my days, okay? And you need to enlighten the NMC, please, that the EM is a 24-hour specialty. And what you've done for 8 hours, you need to do 8 into 3 is equal to 3 times the number of registrars or residents you need to provide so that we will have enough people to man the department. And also, you people need to facilitate ED networking for multicentric studies. All your studies are basically registrar level studies. Okay, you do it to fulfill your requirement to do your DNB or your MD. What you need now is consultant-led research, prospective studies, multicentric studies, by a sample size, is really significant, and everybody will know that this is a concerted effort which has been done prospectively with a proper and a robust research study design. So that's what you need. You need to join hands. You can't be working in isolation. You need to get together and do things together. You need to have helplines, sexual offense management. Every day we hear about rapes. If a rape victim comes to your hospital, are you ready now? Do your registrars know what to be done? We had a conference today. Did we talk about this? No, we didn't. Oh, great. I'm so happy. Toxicology, we need helplines. Somebody should be able to ring and say, I'm finding it difficult to breathe. I think I've been bitten by a snake. Oh, okay. Where are you? We need to talk to them. Okay? Mental health, that's also very, very important. We heard Nijila talk about it yesterday, how people can ring. We don't have it here. In-service training of faculty. What do we do as teachers of emergency medicine? What we do, which is you and I together, okay? We teach you to look after others. We never teach you to look after yourselves. It's very, very important. Capacity building. How do we help? How do we facilitate our team workers? How do we help them to grow professionally, academically? Do we have a plan as heads of departments? Many of you are heads of departments. Many of you are senior consultants. Do you have a plan? Do you also make sure that all your registrars learn about managing conflicts, breaking bad news, team building, and also consultant-led research? This is what I was talking about. How much are we doing? We are doing it only for promotion. We are not doing it for dissemination of knowledge. So therefore, this is something that we need to do. And answer this question for me. Who's the most important person in the department? Very good. All of you are wrong. You are the most important person in the department. You are the most important. If you are well, you will take care of thousands of patients. If you are unwell, so many of those patients are going to suffer. Never neglect yourself. Make sure that you take care of your health, your well-being. Make sure that you, as heads of departments, as leaders of emergency medicine, ensure the well-being of your colleagues, of your subordinates, of your trainees. Make sure that they are mentally, physically, socially, professionally, they are doing well. Make sure that they exercise enough. Make sure that they are able to handle their diurnal rhythm management. It's very, very important. We need to teach them. We need to make sure the shifts help them to manage their diurnal rhythms well. We also need to help them with their academic growth. Don't tell them at the last minute, do a study so that you can go and present it in the conference and then you get your fellowship. No. You need to make sure that you facilitate their growth. Okay? This is a black-tailed godwit. That's the name of this bird. I'm trying to learn more about ornithology than emergency medicine now. I took this photograph last week. What I wanted to tell you is, all of you are now flying. You are flying at various levels. But in your flight, what exactly is your aim? Where is your goal? What exactly you are doing? Is something that I wanted to keep in mind. And I want to leave this question with you. Because I was sitting down for lunch the other day with a group of young people, and one of them asked me, "Sir, I've just joined as a senior resident in emergency department. What is my future? What should I do?" These are the questions which are in the minds of young people. Okay? We need to be there to answer them. And they say, "Sir, emergency medicine, sir, but nobody really knows about it. So it's very tough." So I leave with them this particular quote by this gentleman by the name of W.C. Fields. Many years ago he wrote this. And you know what he said? He said, "Dead fish flow downstream. Only the live ones swim upstream." Okay? Everybody chooses the well-trodden path. General medicine, orthopedics, pediatrics. If you are challenged, if you really feel that there is need for me to do something to make a change, make a difference, and I want to do something, then you are the live fish, because that's the rule of the animal kingdom. But we prefer to go along with everybody else, go for the joyride. So those of you who are doing emergency medicine, you are the live fish because you have decided to swim up current against the stream and stay alive. So I want you to continue doing that, and I want to introduce this person to you. That's a funny word, introduce. Well known to all of us. I idolize him a lot. And I equate him with another saying, which says, all men are equal, but some men are more equal than others. That's what this man is, okay? And I want to end my exposition to you with a saying by him. He said, have the courage to think differently, to travel the unexplored path, to discover the impossible, and to succeed. So God bless you all, and Jai Hind.
Thank you so much, sir. Thank you, thank you, thank you, thank you so much. So now I feel what I wanted to achieve from this Aeme-Con is done. Yes, thank you. There's a young girl, paramedic, she wants to say something.
Sir, first of all, since I'm leaving, I'm so sorry everyone for taking your time. I may be very young to tell this, I'm just 23. I'm doing my MSc in paramedicine, that is the pre-hospital care. I'm in my final year. So, since sir has addressed about EMS, I'm really happy that he has voiced out this. I would like to highlight that I have been in emergency since 2017. I did my 4-year UG course. I worked as a paramedic at global hospitals, and right now I am at SRMC under Dr. T.V. Ramakrishnan sir. Out of one batch, if it has if you consider it as 100%, only 30% of the students stay in the emergency medicine field itself. The rest 70% get into IT fields. They get into business, they get into medical coding, which is no way related to emergency medicine. So this has disturbed me a lot. And thank you, Dr. Ashima ma'am and Einstein sir. In this Aeme-Con, the paramedic students who came to workshop, they approached me and they were interested to do MSc. I think this has provided a good platform for the students for knowing the importance of EMS. And really, sir, definitely I would carry what you told, and definitely I'm going to stay in emergency medicine till my death. So teaching is my passion. I would carry it. Thank you so much for that, sir.
Thank you very much, sir. Lot of emergency physicians, especially young emergency physicians, they don't know what is their future. They are very much worried. They all come and ask me what to do, and there is so many MEM is there, that is there, corporate hospital, whether they will take, what to do. They are really confused. And, you gave them optimism. I know. The last statement was very correct, because I had a chance of doing cardiology, which is what everybody was doing. The program director called me and said, do you want to do cardiology? I will select you. And that was more glamorous when but, I chose emergency medicine because I was trained in general surgery, trained in internal medicine, and then I thought that emergency medicine is my calling, and I also wanted to do urology when I was doing MS general surgery. So then I also wanted to like how to, I know there it is advanced, how to bring everything here, So my mind is all in India, how to, improve and all those things. And we wrote a letter to MCI, Dr. Lokesh Adra and other people, the American Association of Physicians of Indian Origin, and we wrote a letter to MCI to make emergency department compulsory in all medical colleges. And we gave the letter, and the union minister had come to New York, and we submitted the letter, and he put pressure on the MCI. And then they made it mandatory by 2022. So then, yeah. And same thing they were asking, everybody was asking, even the MCI officials, casualty is there. Why do you want emergency medicine? Why do you want foreign system to be here? We have to think locally like that, But they didn't understand how it can save lives. And then we are also working on getting post-graduation, increasing the post-graduation seats, because there are 2,700 postgraduate seats in the US for emergency medicine. And the US has 1/4 the population of India. So India has 1.4 billion. So we need more than 10,000, 11,000. We need 11,000 postgraduates. But as you said, there are under 200, So that's why, that is one of the reasons I came in 2020, met Dr. Sudha Seshayan, MGR University, and asked for 5 postgraduate seats in each medical college in Tamil Nadu. And, she did a phenomenal job of granting that. And, Tamil Nadu has the highest number of MD postgraduate seats in the country. So we know. Thank you, sir. Thank you.
And I know how much efforts Einstein sir has put for this. So there is no doubt that meeting with the right people at the right time, talking the right thing works. Yeah. So now we have, now I have to triage. Now I have to think like emergency physician. I am not sure how to do it. I'm just seeing this. I'm thinking how to triage. I need help from all of you. First of all, I apologize that there is a quite amount of delay. There is no doubt. But then we have been talking. We have been talking good. We have been talking the right things in the front of the right audience. You cut short, you run fast, you sometimes miss the important things, isn't it? So let us have a half an hour of lunch, okay? Try to be fast, come back over here, and then we carry on with our rest of the talks for the day, okay? So thank you so much. We break for lunch now. clap for Dr. Sandeep and David, who had won the Future of EM competition. He was the winner. He spoke on how would he manage acute liver failure in ED. That was not the single one. Dr. Keyur has just left, but from Pramukh Swami Medical College, he spoke on the newer concepts in trauma resuscitation, and it was a wonderful talk. So we have two of the winners in that category. There was a category of paper presentations where Sabha, Himanshi, Harismita, Binu, and Dr. Shrikar had competed. And the winner was Dr. Himanshi Bed from AIMS Rishikesh. She had left yesterday, and I had the fortune of giving her medal to her. She had spoken on POCUS applications in ED, her thesis paper during her post-graduation. There was a young faculty talk where Dr. Kasturi, Himanshi, Anjala, Dr. Aditya, and Dr. Divya and Dr. Prashant had competed. And the winner here is standing one among us, Dr. Aditya. Dr. Aditya, huge round of applause. Please come over the stage. Dr. Aditya, your topic you have to just tell, though I remember it is vertical vertigo. Okay, I'll only speak. I remember his topic. It's center, please. Congratulations, Dr. Aditya. We had an e-poster competition where Dr. Akhileshwari, Dr. Riya, Dr. Yashaswini, Dr. Jami, Dr. Shruti, and Dr. Kaushik were there. And the winner was Dr. Yashaswini. She also left yesterday, and she collected her medal. Okay, thank you. And next was the e-poster competition where Dr. Tom, Dr. Anup, Dr. Mani, Dr. Rudra Rupesh, Dr. Binu, and Dr. Ankit were there. I do not know. I don't see him again. Dr. Rudra Rupesh Reddy? No, I think so. He had gone for nerve blocks. Has he not come back? Okay, so no, he's not there. We had another e-poster where Dr. Dhayashri, Dr. Divya, Dr. Tilak, Dr. Chinnadurai, Dr. Sivakumar, Manaswita, Dr. Rajavel, Naveen, and Dr. Manish had competed. And the winner is Dr. Tilak. Congratulations, Dr. Tilak. Please come over. I really want to know your topic, please. I'm sorry, I'm forgetting. Methemoglobinemia. Thank you so much, Dr. Tilak. There was another e-poster competition where Dr. Mahesh, Dr. Suman, Dr. Anjali, Dr. Janvi Kabala, Dr. Abhishek, and Dr. Binu had competed. And the winner is Dr. Anjali. Dr. Anjali was here. She told me she's somewhere here already. Okay. No problems. We move forward. We had a young faculty talk. I don't see the winner out here. Dr. Somya, Dr. Satish, Dr. Mario, Dr. Jishmi, and Dr. Sabira had competed. And this was a wonderful talk given by Dr. Mario Anthony, who spoke on transfusion disasters. No, he is not there. There were paper presentations by Dr. Vivek, Dr. Avichal, Dr. Mani, Dr. Shruti, Dr. Amoga Varsha, Dr. Sangeeta, and Dr. Abhishek. The winner is Dr. Abhishek, and he has left back to PGI Chandigarh, and therefore we had given his medal yesterday itself. There was a paper presentations again, another one, Dr. Izaz, Dr. Shamna, Dr. Sabrina, Dr. Aishwarya, Dr. Akshata, Dr. Silpa, and Dr. Salva Amina had competed, and the winner is Dr. Akshata. Oh, and this is how you enter. No? Come, Dr. Akshata, please. Room key? No box left there, sir. No lock box. Oh, I'm so sorry. I'm probably pulling it out the wrong way. You can just... Sir. You have to... Dr. Akshata, what was your topic on? Alport syndrome. I'm forgetting it. This is the third time I'm asking her. Oh my God, my memory is... Okay, then there were virtual session on paper presentations. Dr. Vishaka, Dr. Shraddha, Dr. Malika, Dr. Pranjul, and Dr. Bhumi had competed there. And Dr. Bhumi has won this. She has already sent her address to me, and I'll be sending a courier of her medal to her place. There was other paper presentations where Dr. Arunjit, Dr. Parth, Dr. Somyajit, Dr. Harit, Dr. Abdur, Dr. Rahul, and Dr. Gopichand were competed, and the winner is Dr. Abdur Rahman. Do we not have him? He was there in the morning. I saw him, must be down there. So then there was another e-poster competition. So number is more. So there are 2 winners in this. Dr. Deepthi, Dr. Vinay, Dr. Athira, Dr. Anagha, Dr. Johnny, Dr. Krishna Kumar, Dr. Sharan, Dr. Rajat, Dr. Sindhu, Dr. Jyoti, Dr. Harit, Dr. Vignesh, and Dr. Badhur. And the first winner is Dr. Krishna Kumar BS. And the second winner is Dr. Johnny Saxena. Do we have them? No? Okay, no problems. Now this is something which is more near to my heart, very important. Dr. Harsha from Gujarat and Dr. Talha from Bangalore. They have conducted an OSCE competition with the students. And it's so nice that most of the students did very good, but the one who did the best is Dr. Vinayak SR. Where is Dr. Vinayak? And he did it with getting 89 marks out of 100. Superb, I would say. When we go to check DNB papers, that is what I think so would be the best thing. He is also not there. If all your friends, please inform. I have thanked all the students for participating. We have done so many conferences in anesthesia as well in emergency medicine. I know you all will vouch for me. This number of presentations, not possible. Yeah. Yes. So now I invite Dr. Abhilash, sir, whose train is, I'm sure he'll run in this traffic for catching his train. Thank you, sir. And thank you, Dr. Jamshed. Yeah.
Okay, thanks Ashima and Arnachalam for inviting me. So since it's a post-lunch session, I'll try to keep my talk very quick. The topic given is worrisome zoonosis. It's a very broad topic, zoonosis. So what's the definition of zoonosis? These are diseases and infections which are naturally transmitted between vertebrate animals and man. So could be viral, bacterial, rickettsial, protozoal, helminth, or fungal. Can you name a few? Let's say viral. All my students are here. You can name a few viral zoonotic infections. Okay, some more. That's it? Only one? Bacterial, let's say bacterial zoonosis. Name a few. What, you can't even think of one? Rickettsial zoonosis. Nope. Okay, so I mean, there's a whole spectrum of zoonotic infections. In fact, if you look at all the pathogens, almost half or more than half are actually zoonotic infections. Could be viral or rabies, yellow fever, Kyasanur forest disease, especially in Karnataka, anthrax, brucellosis, plague, leptospirosis, rickettsial ones that we see quite often, scrub typhus, then toxoplasmosis, trypanosomiasis, not so much, not India, but still. So these are the spectrum of zoonotic infections. Now, how does it spread? These are prevalent, these pathogens, they get transmitted in the wildlife, monkeys, camels, bats, rats, a lot of animals. From there, it may get into the humans in different ways. Could be vector-borne diseases, airborne method, or direct contact with animals, or foodborne. So different ways of transmission from animals into humans. What was the first reported zoonotic disease? Anybody with this? What am I trying to show? Who's that guy there? Is there a pointer? Is there a pointer I can use? Who's that guy there? This is the plague. That's Justinian plague in one of the Roman emperors. So plague was one of the first reported zoonosis. We're very familiar with these terms. Now, how is it classified? Zoonotic infections as could be endemic, could be re-emerging, or could be emerging diseases with epidemic potential. So many of the, if you look at, think of the list that I put up earlier, many are endemic in some parts. Let's say Kyasanur forest disease is endemic in one part of India. Trypanosomiasis is endemic in one part of the world. So the different infections in different parts of the world, and some are emerging infections. So if you were to look at India, this is what I would think of as the very common diseases with public health concern. Now, some zoonotic infections have zoonotic origins, but nowadays they're not really considered to be zoonotic. Let's say HIV. How did HIV come into the world? It started only in the 1970s. How did HIV come to be as a human infection? Yes? From chimpanzees, from monkeys. Direct contact with monkeys into humans. And now it's no longer a zoonotic infection. It is spread among humans directly. Even coronavirus disease started off from bats is the speculation. And after that, it's no longer a zoonotic disease. It just spreads among humans. So, but there are some zoonotic infections which keep coming out as recurrent outbreaks, like Ebola in Africa. It starts from the monkeys mainly in the sub-Saharan Africa, Congo region. Humans exposed to monkeys in close proximity. Once they get the virus, it spreads among humans after that. But the initial origin would be from animal. So this is a systematic review of a few zoonotic infections in India. If you look at it, brucellosis, Nipah virus keeps coming regularly. Japanese encephalitis outbreaks keep happening quite often. Leishmaniasis, leptospirosis outbreaks keep happening with floods. Whenever there's a flood, these small epidemics come up. And what is very concerning for us is this scrub typhus, something that we see quite often in Tamil Nadu, not so much in North India, but it's a very prevalent zoonosis. Now, which ones am I worried about? Can you think of what I would be really concerned about in the Indian scenario now? Which ones? Take your pick. Yes? So I would put these as the main ones: rabies, anthrax, scrub typhus, and a lot of emerging zoonosis that I already mentioned COVID, so there could be a lot more coming like that. Now, scrub typhus is something that is very typical seen a lot in Tamil Nadu. I remember during my 15 years back when we were in college, nobody heard of scrub typhus. Everybody used to come with fever, short duration. The only possibilities that we would think of were malaria or leptospirosis, but scrub was not even in the list of differentials. And then we started looking for eschars, we found eschars, and then we started reporting scrub typhus a lot. Now it's so prevalent that in CMC at least, that is the #1 cause of acute febrile illness. So almost 40% of our patients in the fever season, that is September to January, the rainy season, have scrub typhus. So this is categorized as a re-emerging infection. It wasn't there in the 1900s. From 2000, early 2000, it started. Now it's spread across the country and the world. I'll come to that. So this is, the vector is a thrombocular Shiga mite that may get onto your body if you're exposed to vegetation. If you walk on grass or go trekking in the hills, you could get exposed to this Shiga mite and can bury inside your body and then leads to a systemic infection. So these are the areas, the kind of areas that called scrub vegetation, could be farms, could be forests, wherever if you trek barefoot or you get exposed to this environment, you could get scrub typhus. Now, classically, scrub was reported from a triangle called Tsutsu-Gamushi Triangle, from Japan to Australia to Afghanistan. In that region, that includes the majority of Southeast Asian countries and India. That is where classically scrub typhus has been reported for a long time. But now, recently, with the spread of scrub typhus, now it is spread beyond this Tsutsu-Gamushi Triangle, well into Australia, into a few Nigeria, Cameroon, from European countries, and especially in Chile, it's even reached South America. So something that was very endemic, very locally prevalent in this Tsutsu-Gamushi Triangle has become a worldwide infection now. It is spreading rapidly. So very soon, I'm sure that this would spread to the rest of South America, go to the North American continent and across Europe. So it's going to happen. So something that was very localized is spreading a lot. Just like how COVID has spread in very fast, this is spreading slowly, but it's going to happen. Even in India, if you look at the Indian map, Tamil Nadu is the state with the highest prevalence. In fact, I would say that every single state has scrub typhus, but it's not really so much, and people don't look for the eschar, they don't really diagnose it. The antibiotics used, doxycycline, azithromycin, for many other infections do cover, but it is spreading across the country. Before 20 years back, it wasn't reported in any of these places, but now if you look at it, it's so common. And in the other states, it will certainly spread and start getting reported very soon, in the next maybe 10 years or so. And what I said, this is the eschar that is typical of scrub typhus. That's something that everybody, every patient should be searched and thoroughly examined. The prevalence is reported from many studies. We have reported quite a few patients with the prevalence of from 30 to 65%. That's the rate of eschar pickup. But in fact, if you look at, if you really carefully search for patients, it should be 90 to 100% almost, but just that we don't search so much. Once we find rapid IgM positive, we tend to start the antibiotics and may not describe the eschar at all. But in general, pickup rate is around that much, 60%. And this is where eschars are found in the axilla, groin, the back, in the hidden areas of the body, where the Shiga mite, it goes up and buries in areas of moisture like groin, axilla, inframammary region. That is where eschars are classically found. So if you do search patients thoroughly in the fever season, that is July to Jan in South India, you would find a lot of scrub typhus and eschars. Now, rabies is another infection that is very endemic in the country. We are quite lucky that we have multiple options for vaccination and immunoglobulins. But I'll tell you my experience in a few places. I've been to Malawi recently in Africa, where I realized that rabies is very common, or the most common cause of meningitis in Africa is rabies. And when I went there, I realized that in the entire country, there is no option of immunoglobulin at all. For us, the moment a patient has a category 3 bite, we administer immunoglobulin and the vaccination. But in some parts of the world, there is no immunoglobulin available in that country. So if somebody has been bit by a dog here, they have to go to some other country, either South Africa or Kenya, just to get the vaccination, just to get the immunoglobulin. That's how bad the health situation is in some countries. Another experience, I've been to this place, Manipur, Imphal, last year. I went to the hospital. There are a lot of rabies cases, almost 70 to 80 per month, the government hospital was saying. And then I went to the neighboring state of Nagaland, and really there's no rabies there. Why is that? Huh? And there are hardly any rabies in Nagaland, but there's so much in Manipur. They eat the dogs. Simple. Supposed to be tasty. I never tried, but then they eat the dogs. So I mean, just a joke, but yeah. So rabies is quite prevalent in most parts of the country. And this is what is really concerning now, zoonosis with pandemic potential. If you look at all those pandemics, Spanish flu, all the SARS epidemic, then MERS epidemic in the Middle East, now the current COVID pandemic that started in 2019, they all started as zoonosis, and they all have epidemic potential, and COVID is still going on. The last major pandemic was Spanish flu, and currently COVID, if you look at the difference, the way we responded to the disaster, how Spanish flu response was in 1918, and how we responded to COVID-19. A lot of progress being made, but still we have to be prepared for further pandemics like this. Do you know why it's called Spanish flu? Anybody? Which country was most affected by Spanish flu? Why is it called Spanish flu? I mean, we don't call this Chinese flu, but they named it after a country, Spanish flu. But you know that, yeah, exactly. Spain was not affected by the flu at all. Spanish flu started in the United States and spread during the World War I in UK, France, Germany, and all the other countries, but not in Spain. But we call it Spanish flu because Spain was reporting this, because Spain was neutral in the World War I. They did not take part. The press was very active. They started reporting a lot of cases from across the neighboring countries. And the world started calling it Spanish flu, and the name stuck, Spanish flu, even though Spain was never affected by Spanish flu. Okay, so antimicrobial resistance is something that is one concern now, the use of antibiotics in veterinary science and animals, where the strains can mutate, and then once it gets passed on, and antibiotic resistance could be a major factor in the future. Now, how do we prevent zoonosis? Again, it all boils down to good hygiene, which COVID has taught us a lot. It has improved our general hygiene, clean drinking water, waste disposal, and general hand washing is all that is needed. Now, special attention needed is to collaborate between veterinary science and humans and the regular medicine in preventing further episodes. Now, can we prevent further zoonotic episodes? It's not going to happen. It's not possible. So all that we can do is to early diagnosis, treatment, and prevention control, like how we did for COVID. The moment COVID hit, we went at such a rapid pace in terms of diagnostics. Even vaccination happened in less than a year of the start of the pandemic. So that is essential. There is no way of stopping zoonosis. More than half the infections are zoonotic in origin. But if they become pandemic, if they have pandemic potential, we just have to be prepared and diagnose early and handle that. So that is going to happen, and we must be ready. And there's no point worrying about it. We can't prevent these infections, but we learned a lot of lessons during COVID in terms of diagnosis and treatment, and we need to continue doing that to tackle zoonotic infections. And my talk here, any queries, I'd be happy to answer. All right. Thank you, Ashima. It's okay. I know you are having a tough time. Yes.
We could manage the conference, but I couldn't manage time.
It's okay. You did a great job.
Thank you. Thank you so much for friends like and colleagues like Dr. Abhilash and everyone. So there are two students who are leaving and who have won medals. I want Einstein sir once, please. Dr. Mario Anthony, please come. So he did as I told, he's done a young faculty talk, and his talk was brilliant. Then we had Dr. Vinayak he has won the first prize in the OSCE. We have Dr. Krishna Kumar, who has won the first prize in e-poster presentation. And there was a girl, Anjali. There's Anjali. She also has won the first prize. Oh, Anjali, you are here only. I was in e-poster presentations. I hope I'm not missing out on any other name who is already here, because there were so many who were not here when we were just talking of results. No? Okay, we are good to go for our next talk, and we have triaged, and two of my young friends have helped me to triage the talks, and we have Dr. Talha speaking up next.
Good afternoon, everyone. Post-prandial, I know, it's a bit tough. I'm really happy that I'm sharing the dais with such dignitaries. I mean, the talk since morning has been just exemplary. And we are just like chickens, just hatched out of eggs in front of you people. But I take an honor and pride to share the stage with such people. I also extend my warmest thanks and regards to Dr. Ashima for giving me this opportunity, and Dr. Einstein as well for organizing this so beautifully. Most of the people, my juniors, residents, people who I've met across in conferences, the only thing they ask me is, how was it in the UK since I'm back? So I thought I would take this topic as a matter of passion rather than just going into the core subjects to just discuss my experiences with life as a doctor in the NHS. I'm going to stick to exactly my time, hopefully, and that is one thing I've learned again from the UK. So the contents includes the pros and cons of working there, and then a few take-home points from my experience, and then it's for you to decide what you want to do next. That's me, and that's the Royal Albert Edward Infirmary where I worked for the last 4.5 years, and it's quite historically a very old institute that was inaugurated by then the Duchess of Wales in around 1853. That is what it was on the right side to what it is today. And NHS has also evolved in terms of structure and in terms of what it is currently and what it is going through. But like Dr. Suresh said, there were a lot of obstacles, but we have to take it as challenges to overcome these. What makes UK a popular destination among us, among Indians? So one thing is we do have a lot of cultural and historical reasons for this. Most of the knowledge you have gained here with the medical textbooks and the way the Indian medical teaching goes is quite transferable. Just a few things, of course, I think more importantly from the basics which we kind of ignore in our medical setting is what we need to refine to get adjusted in the UK. They're quite welcoming and liberal. I've been there for 4.5 years, so I can say even though it's not quite an extensive time, but still they are quite welcoming, especially to the Indian doctors compared to any other nationality. And it is a multicultural environment like it is in the US, so it's always nice to work in a welcoming country. And anything you put on the CV, of course, whether be it your degrees, your experience, your clinical attachments, which you do in the UK, has always been recognized across the world, so it is always very nice to kind of refine your CV. What preparations do you need as a junior doctor if in case you're thinking to go to the UK? And of course, there are a lot of procedures you need to go through. It is cumbersome, but it is all quite systematic, and if you have the documents, it's going to be very easy. So the first and the foremost thing is you need to get adjusted to the colder temperatures. Most of the Northwest and England hospitals where you guys would be posted if you're going as an IMG, that is the International Medical Graduates, this is where you would be populated rather than the southeast and the warmer and the better aspects of London and other areas, because their local trainees are the ones who are normally posted there. So you have to get adjusted to the temperatures, and also so like we have different languages here. They have one universal language, but they have different accents. So you need to get to, especially, if just going from Manchester to Liverpool, which is not even about, say, I would say 30, 35 kilometers, the accent changes quite drastically. So if somebody comes and gives you a history, it is English, but it is a different accent, so you have to kind of get used to that. basic paperwork and exams for IELTS, which you need, or it would be IELTS for the doctors, which will be a UKVI IELTS, which you will have to give. It is mandatory for the visa process. And also obtaining PLAB exams, but if you have been qualified with any of the Royal College exams, then you don't need to have a PLAB. Again, the visas and the UK postgraduate qualifications, it's very much systematic and in place. If you're going to get affiliated and you've got a job offer, I think the visas are quite well sponsored, and that shouldn't really be a hassle. Challenge in itself is obtaining a GMC. Sometimes I feel like writing that I've got a GMC registration as like my degrees, because it's tough to get. And the second thing is I'm still paying 40,000 to keep it, so it is quite a challenge. But once you have all your documents, it's easy, and obtaining a GMC is in itself, something you should be proud of, because there is so much of documentation they ask for, so much of evidence they ask for. And also they do a lot of background research on your current medical registration. So it is quite interesting, but I'm sure you will enjoy the process. And then there'll be local administrative procedures to the hospital you belong to. And then once you go there, the procedures still don't end, because you'll have to get your disclosure and barring services. I think we can relate this to the US system. Your occupational health clearances, which just basically shows that how systematic the whole thing is, and how we can learn and incorporate a lot of things when we have our international graduates. There's a quote I'd like to share by Simona Bortello. She is the head of Medics Healthcare UK, one of the largest recruiting IMG's companies, who said the Indian medical professionals especially are still held in quite high esteem in the UK, and so there is always a healthy demand for the doctors who are trained and coming from the UK. And this is also my personal experience. I had been working in a mixed doctors from the Middle East, from Pakistan mostly, and of course the British. But you will always see that the local consultants, they kind of prefer still the Indian nationalities and the doctors coming from India. The first question I'm asked, and everybody is asked, what is the salary? So that's why I have a link right at the bottom, www.healthcarecareers.nhs.uk. It is going to give you the most updated salary figures, which you will be having for your particular grade and what you are employed for. So I think it's pretty straightforward. There's no confusions about it, and you don't have to run around different people asking, giving you different figures. But if you start off, I think your basic salary is between, this is as of current scenario, 28,243 per annum pounds to 32, which is taxable. So salary is still something better off. If you're looking at the pros to work there, you can also have some savings. So is that already my time? Okay. Annual leaves, you get quite a lot of annual leaves, and then this is what I've displayed. So if you have started your job, you nearly have about 27 days of an annual leave plus 8 bank holidays, so which is quite a good thing. And sometimes if you're in a training course, you can kind of double your training course by doing a part-time training. So there is an option for that as well for the Royal College trainees and for the other people. You get special study leaves, which is basically for you, which can go up to 30 days a year. And associated with the study leave, you get a study budget. So if you start as a registrar, I think you have a study budget of about £1,200. So you can do a lot of courses, your ATLS and ALSs and various other conferences, which they will fund you. And that is basically your right. If you stay there long enough and you wish to pay your NHS pensions, which you will be getting it after 62 years in terms of money, and then, I mean, that is also an option, but you have options to opt out as well. Something which I enjoyed really is the NHS discounts. If you're working in an NHS setup, not in a private setup, you do have so many apps. You can really enjoy these discounts in most of the shopping and your transport and university and student apps if you're really affiliated. The quality of training, it's more systematic. You do have a lot of opportunities, especially in research, compared to what we have in India. You have experienced consultants who are coming from different parts of the world, and there is an excellent training environment at every step. There is also nursing staff which are quite specialized, like we have the advanced nurse practitioners who are equivalent to a registrar, and they are so well trained. We are talking about training EMSs, and like Dr. Suresh sir said that, training and having courses for the emergency medicine nurses. We already have an advanced nurse practitioner program there where they train for 3 years and they are ready to diagnose, treat, and discharge patients like any other doctors do. This is always prone to going to a new country, new people, learning the new culture. I mean, even though the food is quite bland, but you can try to enjoy and be a part of the environment. What are the cons, especially coming to now? I mean, with all that you have learned in the news and everything, I think, according to my personal experiences, I was just moving back before the Queen died, and then after that, there were a lot of things that actually went downhill for NHS, and they're still struggling. It is quite taxing, the environment. We have a 4-hour target in every hospital. You don't have the OPD system. It's the GPs who see them in the community, and anybody who walks through a hospital would be via NER. So you see all sorts of patients. You have long waiting hours. Patients are waiting for about 6 to 8 hours also to be seen by a doctor, but that is how the whole system is. So there are a few cons to it. But what you learn there is how to triage and the core principles of triage and the challenges you feel in triage. I think that is what I have learned while I was working in the NHS. This is one of the pictures I had taken. So Dr. Suresh, I do also have a passion for photography, so we can have a competition. Yes. It's a bit fast-paced. You have to keep up with your portfolios. You have to keep up with your other contemporaries, your colleagues, your junior doctors, because everybody comes to you asking you questions, sharing of knowledge. So it is a fast-paced environment. You wouldn't know how your years have flown by, especially if you're in a training program. You do feel it's underpaid and overworked. Having said that, you also have rest periods, and the rota is quite well planned. You have rota managers, and we are always short-staffed, especially from the nursing aspect, and that exists even now. So that's why you're overworking. You sign up for a job, even if you're a consultant, you have to sign up for night and weekend shifts. So it's not like some of us have the luxury of not doing night shifts or probably taking just on-calls on the weekends, but that's a no-no in the NHS. Often people feel, so we had a survey done. This was also done even while I was working there. I'm talking about in 2019, just after the first wave had just gone off. And then we had a huge survey across the NHS, northwest of England. And the survey was, how did they feel? Basically, the well-being, again, what we talked about, of the staff working in the NHS, and they felt they were undervalued and underpaid, and that still exists. This is the most recent updated survey. And of course, there's a lot of competition, but is that a con? I don't think so. It is definitely a pro, because with the competition is when you also kind of buckle up and think, yes, you have to match up to all your other colleagues. Very, very important. This is a question as being an outsider, you're an IMJ, how do you think you're going to adjust? But it is totally dependent on you. Otherwise, most of them are welcoming. There are a few challenges even I faced in the first 6 to 8 months. It is difficult to adjust. You have to prove your meat even to the nurses, only then they start believing in you, because they are quite educated, they are quite well versed, unlike how it is in India. So they're going to ask you a lot of questions: why, what, when, how. But it is, at the end of it, all patient-centric, and we're all working for the patient. So I think, and we all miss home. It's not as easy to just fly from Dubai or anything like that. It does take a lot of planning, and especially during COVID, when I was away from the family, it was quite challenging. But again, this is a part of any place you go abroad. My favorite author, I read a lot of books from him. He said, if you're brave enough to say goodbye, the life will reward you with a new hello. So if you are going for challenges, you have to leave back something, and that is when the new doors will open to you for opportunities. Another picture of mine, I'm just showing off. What I learned, this was going to be my last slide, I promise. What I've learned from the cultural differences is communication skills. Saying please, saying sorry, may I, thank you. These are the 4 important basic things which we have forgotten, unfortunately, in our country. This is with the patient, with your colleagues, with your staff, senior, juniors, whoever it is. Showing empathy, again, not just to patients, but to your staff. Asking how you are, saying you have done a good job, appreciation, positive feedback. having patience. Yes, we have had patients with recreational drugs, you see all sorts of things there, cocaine and heroin and everything going on, and then they're just pouring on you, and then there's police, about 7, 8 people asking you questions, and why are you not sedating this patient? How long have we to pin down? And then you hear all sorts of new good words, which you might have never heard. So, yes, having patience. In fact, they have a mask because patients spit, so they have a spit mask, which is used to being spat on. So, a lot of resources. Each trust which you will be with, they're going to share a lot of resources with you. You have free access to a lot of journals, free access to a lot e-portals, which your trust would be aligned with. So make sure you utilize it. Every trust there comes with a 24/7 library access, and it's worth a lot of pounds. I'm sorry. So please make utilization of all these things. Training programs, immense training programs. Luckily enough, I've done about some 15 to 20 training programs, and I very proudly presented on my CV, and there's everything you can do, right from ultrasounds to all these workshops, what we have done here, and they are quite important, and that would be a part of your career. CPD points, again in India, we take quite lightly our CPD points. We just wake up and think about it when you're probably going to renew your license, but that happens annually there with your annual appraisals are quite strict. So I think bringing that system again into ours and incorporating those, especially to the EM leads and the departmental heads, is something we should really think of, and that's very, very important. Portfolio logbooks, again, it's all gone online. It's e-portals and annual appraisals. And of course, teamwork and mutual respect. Everyone is equal there. We have a flat hierarchy system, and the respect which we have is quite mutual, and that is what I have learned and I want to take from the UK. The reason for me to come back might be varied, but I have always taken the good points and also have taken the learning points, and that is what I am here for. But each one has their own choice. People might have stayed for 20 years and come back to serve us again. I've done that for 5 years. You might do it and stay there. So whatever it is, whatever path you're taking, it is you who decide. You have to have a clear frame of mind as to what you want in the future and what you're going to incorporate in your lives, and that is what it is. So the references, a lot of them, I can share these slides. So any doubts, anything, please go through this. There are a lot of text information given by most of the students who are working as IMGs. You can read articles and the real experiences, real stories. This is my story. I hope I've helped you enough. That is my graduation picture when I did my MCH from the Edge Hill University. This is how it looks during winters and summers. So I've seen all seasons, and I'm happy that I've got some knowledge back home. Thank you.
So all the students, they aspire, students, young consultants to go abroad and do MRChem, work there. So what are your questions? I see one boy was yesterday asking me, he's just joined somewhere, and he said, I want to go abroad. And I thought it is emergency medicine where there is a good need. So I took it, but now I'm confused. I don't see him here, but thank you. So otherwise, we'll share our, yes, we have.
Scottish is pretty easy. Yes, Welsh, I would agree. And also Liverpool. It's a bit, yeah. They're different breeds. Scouse, yes, Scouse.
Yeah. It's not really a question, just for them. I was in UK for about 7 years, so did my MRChem, FRChem, whole lot of exams there. There's one exam which I really struggled, and I cleared in my 4th attempt. Does anyone want to guess which exam that was? Not the IELTS, no. It was the practical driving test to get my driving license. And that was just for the 4-wheeler. I decided I'm not going to go for a 2-wheeler license.
That's nice. So thank you so much. And we now invite our next speaker, Dr. Mohan from PGI, Chandigarh, and he would be taking us into the ethical and legal issues in emergency department.
Thank you, ma'am. I would thank the Aeme-Con Forum for inviting me to give a lecture on this boring topic. This is the topic which has been given to me is a wide one, and it's very difficult for me to sum up in 10 minutes. So first I thought that how would I go ahead with this? Then I would address few of these questions in these slides. There is a lot of difference between what is moral, what is ethical, and what is law. I would like to simplify it to you, and we'll answer each of those questions in the further slides. First coming, what is moral? It is basically the behavior in accordance to the customs and tradition of your family or of your society from where you come. And whereas ethics, it is a branch where it tells you what is right and what is wrong. It is something about the moral values where it is based on some body of knowledge. Whereas the law, that this is something next advanced to the ethics where they have a coded rules, and if these rules are not followed in the community, there is an enforcing authority. When the rules are broken, the authority will come into the existence. If you are not able to understand, I will make you simple. Morals is something which is between the private and personal interactions. Ethics is what we have the professional bodies where it would keep your standards for ethics. Law is for the whole society, where it would be interaction between two different persons. So with this, now we will just go, why should we know law? As the ED physicians, why should we know law? It would help us to perform the duties effectively. It will help us to give patients better care, and we can give them an opportunity to inform them about the procedures and take a detailed informed consent. And it will also help the doctors to know what are the legal authorities which is governing you. And if not followed, or if these standards are not met, what are the legal implications that can happen, and how are you liable for these things? I would go in detail about these words. This may be complicated right at the first time. And the last thing is, if you know something about the law, it would avoid the unnecessary emotional stress which you would face when there is a litigation against you. And recently, and more commonly, we practice the defensive medicine in the ED. What is defensive medicine is, whenever a patient comes to the ED 15, 20 years ago, you would have sent back the patient, aapko kuch nahi hai, chalo wapas jao. Nowadays, you prescribe them the unnecessary laboratory and radiographic investigations, although you are clinically sure that the patient doesn't have, but just to save a lawsuit, or he may come up with a different thing, the defensive medicine is being practiced more. Now we know why we should know law. I would tell you some of the legal principles which you are expected to know. Basically, source of law is what we have learnt in the high school civics classes. Everyone knows that the Constitution is the main source of law. In the legal language, it is called as the Grand Norm. And we have three branches in it. One is the legislative branch, where we elect the legislators. They go there. We have upper house, lower house. They pass various bills. Once the bills are passed, it becomes an act. Once the act is passed, then there are various professional bodies which would make these acts, and they would execute it into the society. Once there is a breach in either of the acts or the various norms by the executive branch, you can take up to the judicial branch, where the judge would decide or would address the loopholes of the acts and various professional guidelines, and the judge would give a decision. And these decisions will become as a common law or a case law. It's also called as the precedents. Now coming to what are the types of law which would be applied on the doctors. To categorize it is civil law and criminal law. Civil law is something called as the private law, where it is based on the relationships between the persons and the person's rights. Whereas criminal law, which is also called as the public law, which is based on the relationship between the individual and the society, or the individual and the government. So whenever there is a violation of a person's rights, then you will file a civil case, and whenever you feel that there is a breach or there is a threat to the society, then we would be filing a criminal case. How will a case be, which case would be raised on which incident over a doctor? On a single incident or on a single case, both the civil and the criminal case can be filed for a single incident. Now, what is negligence? This is most commonly seen. Before knowing what is negligence, we need to know there is something called as a standard of care. Various professional bodies have set some guidelines on what a patient can expect when he comes to a medical care. So whenever these standard of care is not met, it is called as the negligence. Here, there are 4 components. Whenever there is negligence, a patient can file a case against a doctor. But here, the patient needs to prove on these 4 aspects over the doctor, then only a negligence can be proved. What are these? One is, there should be a duty of care. There should be definitely a doctor-patient relationship. Like Dr. Mohan is coming to the emergency and he would see the case. What is a breach of duty? He came to the emergency, he just gone through the case, but he didn't advise anything. Then there should be a proximate cause. He came to the Sunday rounds, he saw the patient, he didn't advise, he went. Because he missed a thing on that day, after that, the proximity is there. He missed the thing on that day, after that, the patient deteriorated. The patient has to prove that all these things, and after proving all these 3 things, the patient should have a damage, which either can be economic loss or a life loss. If all the 4 things are met, then all the 4 things had to be proven by the patient against the doctor, then a professional negligence case can be taken. There's something called as res ipsa loquitur. The thing speaks for itself. That's a difficult definition. I will give you an example. You take a patient from the ED with a stab injury, and you are operating him, and the patient falls, and he has a shoulder injury, and he comes out. And he can file a case against you. But here, what happens is, the patient, the negligence is on the doctor because he had a shoulder injury within all the controlled environment. So here, the patient need not prove anything. Because the shoulder injury itself proves that was a negligent thing. Here, the doctor has to prove over. These are the various terms with which, if the case is filed, then the doctor has to defend that I haven't done any negligence in different. Even this has various parts on which the doctor has to prove. Something that is called as vicarious liability, and something similar to this is a respondeat superior, where when you are running a hospital or you are a head of a unit, someone who's under you, if they are making an error, even in the hospital, if you are employing certain healthcare professionals, 5 minutes? Is it for 5 minutes or 10 minutes? I can go ahead, right? Okay. The vicarious liability is where once you have a hospital, you have employed certain healthcare professionals, and then it becomes your responsibility while recruiting them to check their professional ability, to train them according to your hospital requirements, and you should to make sure that they give a definitive care to the patients. If your employee makes a mistake, then the employer would be responsible. This is called as the vicarious liability. So there are much more terms which would be difficult or an afternoon for you to understand. I have gone through this. Just we'll go through some few legal problems in the ED which you come across. First, can you name some, or can you enumerate which you would have thought that these are the problems which we see in the ED, which is, has some legal or ethical aspects? Anyone? Or everyone sleeping? I will go ahead with myself. First is the consent. Any procedure or anything which has to be done, you need to take a consent. There are 3 types of consent. one implied, verbal, and written. Implied consent is that a patient comes to a hospital, it implies that he has come to the hospital to take a treatment. Verbal consent is what you tell him and he consents, but what is currently required is the written consent. The written consent, there are various types, how we take in the emergency. Because of the limited time, we write 2-3 lines. So I would like to go in detail about the parts of the consent and when it is told as a valid consent. The validity of the consent is based on these terms. A person should be legally capable. There is something called as the capable capacity. I will tell you how to determine these things in my next slide. Then he must be informed about what to be informed. That I will tell you in detail. Then your consent should contain specific things. What the procedure is being undergone, that has to be written in detail. And it should be freely given. The patient or the patient attendant should not be under any pressure, and the entire detail should be covered in this part. I would like to go in detail that what is informed. You need to give the information to him, and you should ask him whether he has understood each and everything or not. The informed consent has to be clear, accurate, it has to be relevant regarding what procedure it has been done, and it should have the material, it should have the content of what the procedure need to be explained in detail. The treatment options has to be written, has to be given in detail, and you have to explain him what are the consequences of treatment, what are the complications that can happen, and if he is not taking the treatment, what would happen? Usually we forget explaining them consequences of no treatment. That also would be a component of your consent. There is something called as capacity and competence. When for the doctor, you have to determine the capacity, whether the patient has a capacity to give a consent or not. Whether when you go to the legal forum, the court would tell only for the competence. Even given such situation, a normal person can do his daily affairs or not. If he is able to do that, then he is a competent person according to the legal definition. For the capacity, how to determine the capacity in the EM? First, you need to ask this question, whether he does understand what the problem he is suffering from, and the treatment you are proposing to him, whether he is understanding that or not. And you have to ask him this question, specific question, what will happen if you don't have it? And you should be, if he is whether able to comprehend what you are telling, whether he is able to understand or not. If after all this, whether he is able to, on what basis he is arriving at the diagnosis, at his decision, that he should make clear, then only he is a capable person to give a consent. The capacity need to be determined by the doctor. But when this thing goes to the court would tell it based on the competence. There is something called the reportable events. Whenever you see these cases, you have to report to the higher authority or the medico-legal things. What are the usual cases you report to the higher, or what a separate register you maintain or you inform to the police? Anyone? Road traffic accidents? Anything else? Hanging, assault, poisoning, yeah. There's something, some of the things is after which I have been added, the common things I have left it. The child abuse, or if at all you see while examining a patient, or if there are any signs in a child, or if someone comes up with a history of sexual abuse, you are expected to report to the legal authority. Or else you can be sued, at least for the child abuse part, you can be sued if you have not reported by yourself. You have injuries of a gunshot or a stab, you can see, communicable diseases, you know, and animal bites and broad dead patients also, that you would be anyhow taking to the MLR. Some more thing about the medical record. Why do you need a medical record to be maintained? Anyone? It is just for the documentation purpose, so that you can have something to follow up while the patient is admitted, And later, for the future, if at all someone comes with a legal suit or someone comes for the follow-up in the emergency, in the OPD as well, they will have some document. So a medical record has to be detailed entered. Although the ED environment doesn't allow us to write all the components of a medical record, I would like to tell you what are the usual components you are supposed to mention in the medical record. A patient identification mark, as of now, the time would be printed, the means of travel which has been given, but we usually don't follow. Vital signs we document. The history and physical findings, whichever is the positive findings, this you need to be written. The emergency care, whatever you have given at the triage, that need to be documented first. There are many times it happens that the patient, for the treatment mentioned in the triage, the treatment given in the triage would be missing. Because the doctor would have done all the things, the documentation part would be missing. Then the later you wouldn't have known whether what was given or what was not given, or sometimes a double medication would also be given. And the diagnostic and therapeutic orders, whatever you are giving in the rounds register or the book, that also need to be documented in the medical record. Whatever the findings you pick up during your rounds, those need to be mentioned. The reports of the procedures, tests and results, these all are the components of a medical record. And whatever you have your differential diagnosis and the way which you have concluded to, after the examination results, these need to be mentioned in the medical record. The diagnostic impression, final disposition of the patient, how you are discharging him or in what state you are discharging him, and what is the discharge instructions and where he should follow up. These all the things make an ideal medical record in the emergency. This is ideal thing. There are some more things which I have removed it. Actually, after this, I would have 2 or 3 slides. What are the basic laws we should know? I was just searching through this. There is a huge list of laws. I would not go through any of this. There are various acts and bodies of nation and state which have been taking care of guiding the medical profession. But I would tell everyone to go through some of these things which would help us, according to which the common legal suits are filed against the doctors. I would share the slides. With this, I would like to conclude this. Legal issues are very complex in the ED, and always think that what a reasonable person at that situation can do, you do that, even if the consent is not possible. Always think in the best interest of the patient. So 95 to 99% you would be doing right. Even if the documentation purpose lapses, then you now know the features of a valid consent. You have told you how to assess the capacity of the patient before he can give a consent. And some parts of the medical record documentation I have explained. This is what I could do in the given 10 to 12 minutes for me. Rest, if you have some questions, you can come up.
Thank you, Dr. Mohan. You know, my personal experience when I go around doing NMC and NB assessments, most of the time those faculties who have been transferred to emergency department because of making for the new departments, especially at NMC, are worried because of this very reason. They are so worried, we want to go back, what if police catches me if something happens? And I think so this sort of lectures are very important, not only in one forum, but on all forums, so as to them to understand that there is a law which helps them, if you are right, documentation is right, and all other things which Dr. Mohan mentioned. There's no way we will be, implicated under the means. I think so we'll be very much safe. Though all of us would have our own small short stories, anecdotal incidents, but I'm sure we always have improved on our own, in our own places, based on our own available resources and help in our institutes or place of works. I just request Dr. Einstein. Dr. Mohan has been one of the faculties, not part, who has helped us a lot. Mohan, you have to go back to the stage, please. It's my request. No, this is required. You don't have to tell me. In this way, I'll go up from the flat hierarchy to the vertical hierarchy. Please go back. Please, sir, please, on the stage, please, sir. See, there is a reason why Aeme wants to honor Dr. Mohan, and the reason is, it's from 2 months. Whenever I felt confused how to do it, what to do it, I was just calling him. And sometimes at 10:30 in the night, and he would help me out. He would say, okay, I'll come back, ma'am. You send me, I'll do that. So thank you so much, Dr. Mohan. You may not be on the paper, but you are also co-organizing secretary with me. Thank you for all that. Thank you. Yeah.
You can't get away without us asking questions. I reiterate here, I think we've heard from Mohan so many acts, do this act, do this act. I think another act should be invoked, and that should be a what not to do act. Rather than understand 200 of these acts, it's better to have an act which tells you that this is the things you don't want to do. You don't want to do the non-documentation. You don't want to explain to the patient all these things. Because people learn better from what not to do rather than what to do. Right from the time when we are born, it's the time when the mothers start. They always say, beta ye nahi karna, don't do that, don't do this, don't go near the electric or you get current. My other question to you is, Mohan, what are your comments about artificial intelligence taking over some role as far as your talk is concerned? You know, artificial intelligence has passed the USMLE examinations now. They passed the Harvard examinations, which is one of the toughest examinations you can think about, MBA examination. You see a role for this particular AI, chat GPT, and OpenAI beta as far as our practice is concerned?
So definitely, if we provide or if we enter the data of the emergency of our setup, they would perform better than us for sure. There's no doubt in that. As we were discussing, I think even the management issues can be taken care of.
Yeah, but even documentation can be carried out because it is a highly evolved form of intelligence that has the world's resources at its disposal.
It's difficult. Thank you, sir.
So, this is another moment of honor for us to hear the director of AEME speaking about the top 10 papers in the emergency medicine. Professor Aeme-Con, please, sir. This is.
Can I have that mic? Thank you all. You are still here after 3 days of listening to various lectures. So it is difficult to pick the top 10 papers because I had to see a lot of papers, but I thought I picked which is more practical for emergency medicine, which we can put into use. So I chose such papers. Next slide, please. So on. Okay. The first paper we are, talking about endovascular therapy for acute stroke. We know that for a large vessel occlusion, the standard of care is endovascular therapy. But if there is a large ischemic region, usually if it is aspect score is more than 6, then endovascular therapy, that is what they use. But aspect score of 2 or 1 or 3, we don't know, because if there is a large ischemic region and you revascularize that area, there will be a large amount of hemorrhage. So we do not know what is going to happen. So there has no trial has been done before. So that is why this trial is important. So this is a open label, multi-center, randomized clinical trial in Japan. Compared endovascular therapy with medical therapy alone in patients with large vessel stroke and large ischemic area. So they took about 200 patients, and 100 patients underwent endovascular therapy and 100 patients underwent medical care. About 27% of these patients received TPA in each group. And this is the modified ranking score. Like the disability, the primary outcome they were looking for is modified ranking score of 0 to 3. This, like 3 is like moderate disability, but they are able to walk without assistance. So that is what the goal is. They are able to walk without assistance. So the 90-day modified ranking score of 0 to 3 was 31% with endovascular therapy and 12.7% with the medical care. The p-value is like 0.002, which is statistically significant. So then we have to see what is the harm. So any intracranial hemorrhage, that is even a small petechial hemorrhage in a CT, 58% with the endovascular therapy and 31% with the medical care. But that is not very important. We want symptomatic intracranial hemorrhage, where the patient is having a new weakness. It is 9% with the endovascular and 4.9% with the medical care. And death within 90 days, endovascular therapy is 18% and medical care is 23.9%. So conclusion, patients with large cerebral infarctions had better functional outcomes, but more intracranial hemorrhage with endovascular therapy than medical therapy alone. So what are the limitations? It was done in many centers in Japan. So we do not know what is the situation in other countries if it can be replicated. And only 27% of the patients got TPA. And standard dose of TPA, which was used in Japan, was 0.6 milligram per kilogram, whereas in India and other rest of the world, it is 0.9. So next paper is balanced multi-electrolyte solution versus saline in critically ill adults. We give large amount of saline infusion in ICU in hypotensive patients, 3-4 liters. And previous small trials have shown that infusing large amount of normal saline causes hyperchloremic acidosis, acute kidney injury, and there is also increased mortality. So that's so they thought that it's a balanced multi-electrolyte solution might decrease the mortality and decrease the risk of kidney injury. So that's why this trial was done. So design is a multi-center, double-blinded, so they don't know, the treating physician doesn't know whether they are giving plasmolite 48, which is a balanced multi-electrolyte solution, or whether they are giving saline. Parallel group, randomized, controlled trial. So plasmolite 148 was the balanced multi-electrolyte solution, and this was done in ICU. So plasmolite 48 has an ionic concentration of 140 milliequivalents of sodium, 5 milliequivalents of potassium, 3 milliequivalents of magnesium, 98 milliequivalents of chloride, 27 milliequivalents of acetate, and 23 milliequivalents of gluconate. So this is the Kaplan-Meier estimates of probability of survival, you can see both curves look the same, so there is no difference in the probability of survival. So they had randomized about 1,000 patients, and the mortality was 21.8% in the balanced multi-alkali solution group and 22% in the saline group. So there is no statistical significance. And all the secondary outcomes also was kidney, the maximum creatinine level was 1.76, 1.75 in the saline group. Maximum increase in creatinine are patients who underwent dialysis were all similar. There is no statistical significance between the two fluids. So this is the summary. It's a 5,000 patients, 2,500 had balanced multi-alkali solution, 2,500 had saline, 22% mortality in each. There is no difference in mortality or no difference in kidney injury. So next paper is acetazolamide in acute decompensated heart failure with volume overload. Normally, patients with acute congestive heart failure, we usually give Lasix, loop diuretic, routinely. So now we want to see whether acetazolamide, which acts in the proximal convoluted tubule, whether adding this is helping for rapid decongestion when compared with Lasix alone. So this is a multi-center parallel group double-blind randomized placebo-controlled trial. So it is acute decompensated heart failure. Patient comes with dyspnea, pulmonary edema with elevated BNP. So what they did is they gave IV acetazolamide 500 milligram IV versus placebo. And the physician doesn't know, the treating physician didn't know, or the patient didn't know whether he was getting the placebo or the acetazolamide. And they were getting the dose of Lasix was, if they are on Lasix 40 milligrams daily, they doubled the dose of Lasix, 80 milligram IV. So both groups got that. So what they found was successful decongestion in 72 hours. 42% of the patients with acetazolamide group achieved successful decongestion in 72 hours, whereas only 30% in the placebo group. So the p-value is less than 0.001, which is statistically significant. So death from any cause was similar. Adverse effects also was similar. So addition of acetazolamide to loop diuretic therapy in patients with acute decompensated heart failure resulted in a greater incidence of successful decongestion. So next paper is effect of fluid bolus administration on cardiovascular collapse among critically ill patients undergoing tracheal intubation. We all know, like, if the patient blood pressure is around 120, sometimes you are worried whether the patient will become hypotensive when we give propofol or inducing agent and giving. So there are three ways to avoid the hypotension. One is giving fluids. Next is to give push dose vasopressors. Third is to select the induction agent, whether instead of propofol you use ketamine, which increases the blood pressure. So this is the question. In critically ill adult patient undergoing tracheal intubation, does giving intravenous infusion of 500 ml of bolus before giving the induction decrease the incidence of severely low blood pressure, cardiac arrest, or death, which are referred to as cardiovascular collapse, during or shortly after the procedure? So 1,067 patients randomized, 538 patients were randomized to give IV fluids, 527 patients didn't receive IV fluids before. This is the PREPARE 2 trial. So 500 ml of IV fluid bolus or no fluid bolus. So we want to see whether giving IV fluid bolus prevents cardiovascular collapse. So main outcomes and measures. The primary outcome was cardiovascular collapse. How do they define cardiovascular collapse? Is like receipt of vasopressors. Like if the patient's blood pressure goes from 110 to 80 and you want to give, you start vasopressors, then that is one of the measure. And blood pressure, systolic blood pressure less than 65 between induction of anesthesia and 2 minutes after tracheal intubation. Because if you wait 30 minutes, it could be due to other factors, not due to the intubating drugs. Or cardiac arrest or death between the induction of anesthesia and within 1 hour of tracheal intubation. The secondary outcome was incidence of death, 28-day mortality. So what was the findings? 21% had cardiovascular collapse with the administration of IV fluid bolus and 18.2% without administration of fluid bolus. A difference that was not statistically significant. So giving IV fluid bolus in a patient before intubation does not prevent cardiovascular collapse. But, they had excluded patients, like if somebody is dehydrated already, those patients were not included. If the clinician clinically felt that the patient needed IV fluids, they were excluded. This is patients who is normovolemic and they are not hypotensive before their blood pressure was like 120 like that. They are not like 80 and it also 15% of the patient had crash intubation. So there is no time to randomize. So those patients were excluded. So next paper is outcome of patients discharged from the pediatric emergency department with abnormal vital signs. There are a lot of children, patient with bronchiolitis, they are breathing at 42, 45, but their oxygen saturation is 96. So you might discharge the patient, but that is an abnormal vital sign. So we do not know what's going to happen to these patients. How many people come back and within 48 hours and get readmitted. So that's what we want to know. What are the adverse outcomes? So it is a retrospective cohort study. So they took 2 emergency departments and they found out about 97,824 children evaluated in the emergency department. 18% were discharged with abnormal vital signs. Out of only 2.28% returned to the emergency department, out of which 95 were admitted for the same chief complaint within 48 hours. That is only 0.5% of the children discharged with abnormal vital signs returned and were admitted to the hospital. So 99.5% of them patients were not admitted. So there was no adverse event and there was no deaths because of this. So the 48-hour return rate for children discharged with normal vital signs was 2.45%. With abnormal vital signs, it was 2.28%. So the p-value was not significant. So, but in adults, it's different. Adults, if you discharge with abnormal vital signs, there's a high incidence of readmission and mortality and all those things. So conclusions, many children were discharged from the emergency department with abnormal vital signs, but few returned who required admissions. So we all see a lot of low back pain patients in the emergency department, and we treat them with non-steroidal anti-inflammatory drugs, and we also add muscle relaxants. Now what they want to assess is what is the efficacy of the skeletal muscle relaxants in addition to non-steroidal anti-inflammatory drugs. So they included 4 randomized trials in which patients were on naproxen or ibuprofen, and they were discharged on one of the muscle relaxants, 7 different muscle relaxants, and they wanted to find out which one is effective. So how they want to determine the efficacy is the disability rating scale for low back pain, Roland Morris disability questionnaire. This 1 point is given to each question, and the score is from 0 to 21, and they want to see 10-point reduction in the score in 1 week. So in 1 week outcome, placebo, it was 10.5% mean improvement of the RMDQ score, and all the other muscle relaxants are also around 10%. So they say that conclusion is, among the patients in the emergency department with acute low back pain treated with non-steroidal anti-inflammatory drugs, adding muscle relaxant do not improve more than placebo. So next, defibrillation strategies for refractory ventricular fibrillation. So there are different defibrillation strategies. One is the standard, we put one lead in the right infraclavicular region and left another lead in the So the second strategy is the double sequential external defibrillation. That is rapid sequential shocks from 2 defibrillators, and then vector change defibrillation. That is, change the pad from, like, you give like one shock when the pad is in the right infraclavicular apex, you take that pad and put it in the left chest and to the back. That is vector change defibrillation. So they want to know whether adding these strategies improve the survival after defibrillation. So this is the standard defibrillation, the top one, the vector change, and double sequential is like you're using 2 defibrillators. You defibrillate with one defibrillator and then defibrillate immediately with the other defibrillator. So it is a cluster randomized trial with crossover among 6 Canadian paramedic services. So what they did is this, it is in Toronto. There are like the 6 paramedic services. So 2 months they were using standard defibrillation, and then next 2 months they were using vector change, and then next 2 months they were using this double sequential defibrillation. So first, all the patients were, after 3 unsuccessful defibrillation for witnessed VFib arrest, then they randomized to one of these groups. The primary outcome was survival to hospital discharge, and secondary outcome was termination of VFib. So 405 patients, about roughly 1/3 were randomized to each group. So survival to hospital discharge with the standard defibrillation was 13%, vector change was 21.7%, and double sequential external defibrillation is 30%. So in conclusion, the patients with refractory ventricular defibrillation during out-of-hospital cardiac arrest, survival to hospital discharge occurred more frequently with double sequential external defibrillation or vector change defibrillation than with standard defibrillation. So this, the next paper was published 1 week ago, early extracorporeal CPR for refractory out-of-hospital cardiac arrest. So how they define refractory out-of-hospital cardiac arrest is after giving CPR and defibrillation for 15 minutes, if they are still have not caught the pulse back, one group, they did the extracorporeal CPR, and the other one, they continued their normal CPR. So it is a multi-center, pragmatic, randomized control trial in Netherlands. Assessed extracorporeal CPR compared with conventional CPR for refractory out-of-hospital cardiac arrest. 134 patients were included, out of which 70 were assigned to extracorporeal CPR and 64 were assigned to receive conventional CPR. So the survival with favorable neurological outcome was 20% in the extracorporeal CPR and 16% in the conventional CPR. It's not statistically significant. The 3-month and 6-month also was not statistically significant. So survival with a favorable neurological outcome at 30 days was 20% with the extracorporeal CPR and 16% with conventional CPR. At 6 months also, there was no difference. So conclusion, in patients with refractory out-of-hospital cardiac arrest, extracorporeal CPR and conventional CPR had similar effects on survival with favorable neurological outcome at 30 days. So next paper. This also was published last week. Early restrictive or liberal fluid management for sepsis-induced hypotension. So what happens is, when there is sepsis-induced hypotension, patient comes with sepsis, and you initially give 1 or 2 liters of fluid, and the patient still is hypotensive. Then they are randomized into 2 groups, whether to continue give IV fluids, and then later on, after giving another 2-3 liters, then later on start pressors, or start pressors immediately instead of IV fluids. So this is how they are randomized. So they called it as crystalloid liberal or vasopressors in early resuscitation in sepsis, Clover's trial. So it is an unblinded superiority trial conducted at 60 US centers. They randomized 1,563 patients. 782 patients with restrictive fluid strategy, prioritizing vasopressor and lower intravenous fluid volumes, or a liberal fluid strategy where 780 patients were given, continued to give IV fluids. Then if they still don't respond, then start using vasopressors. So this happened within 4 hours after the patient met the criteria for sepsis-induced hypotension refractory to initial treatment with 1 to 3 liters of IV fluids. So over the 6-hour period, the restrictive fluid group got 500 ml of fluids, whereas the liberal fluid group got 2.3 liters of fluid. So the liberal fluid got about 1800 ml of urine more, of fluids more. So the vasopressor administration rate was 460 in the restrictive fluid group, and it was 290 in the liberal fluid group. So what was the conclusion? Actually, there was no difference in any of these parameters, number of death or number of days free from organ support therapy, number of days free from ventilator use. Everything was, there's no statistical difference. So conclusion, among patients with sepsis-induced hypotension, the restrictive fluid strategy that was used in this trial did not result in significantly lower or higher mortality before discharge home by day 90 than the liberal fluid strategy. So next paper, 10th paper. Some monkeypox virus infection in humans across 16 countries, April to June of 2022. So in 2022, there was a big, there was a pandemic of monkeypox virus infection. And the method where it was an international collaborative group of clinicians. It was an international case series to describe the presentation, clinical course, and outcome of PCR-confirmed monkeypox virus infections. So what they found was there was a difference. The classic form, which is endemic in Central and West Africa, the affected population was children and young adults. But in the new pandemic form, it was 98% were homosexual men. And the transmission was, the animal reservoir was there, probably rodents, in the endemic form. The pandemic form is exclusively human-to-human transmission. And the lesions were in the endemic form were in the face and in the upper limbs and lower limbs. It's a centrifugal distribution. But in the pandemic form, the rash was mainly in the perianal region and in the penile rash, and also in the oral region. These viruses were clad 1 and clad 2 in the classic form, whereas it is clad 3 in the pandemic form. So these are some of the lesions. You see vesicular pustular lesions with central umbilication, mainly in the hands. But the main penile lesions, I had a patient in August. I saw a patient. It looked like a genital herpes. That's what I thought, because this guy was a homosexual man and he had a herpes outbreak. But I also thought of monkeypox, so I sent the herpes virus PCR and the monkeypox PCR, and the monkeypox PCR was positive. And then I went through the literature. 57% of them had a single penile lesion. So it is like you might be mistaken for syphilis or herpes or some other condition, So you have to have a high index of suspicion, especially with oral ulceration and things like that. History of homosexual is very important. So these are the oral lesions. So 528 infections were diagnosed between April and June 24 in 43 sites in 16 countries. 98% of the patients were gay or bisexual men, 75% were white, 41% had a HIV infection, 95% of the patients presented with a rash, 73% had anogenital lesions, 41% had mucosal and oral lesions, lymphadenopathy was common, and concomitant sexually transmitted diseases also were present in 29% of the patients. And monkeypox virus DNA was detected in 29 of the 32 patients in whom seminal fluid was analyzed. So they were asking whether it is could be sexually transmitted. That question is unknown, but so 13% of these patients were hospitalized. Why were they hospitalized? Mainly for pain management. They had severe anorectal pain, or they had severe ulceration, they could not swallow, so they were dehydrated, so they were admitted for IV fluids and pain control. And 2 patients for acute kidney injury, 1 for myocarditis. No deaths were reported. Thank you. Any questions? Not, even before the studies, we were doing it on selected, refractory,
and Dr. Sahana, who has been very helpful right from the start. Sahana, please, this is our thank you say to you. Thank you. So we carry on with the presentations, and we have Dr. a very aware, full of awareness, motivational. I'm not seeing there, here and there, and you are also not seeing there. Okay, yeah, please.
Thank you.
You want this? You want your mic?
Yes, please. Thank you. Good afternoon. Fairly sleepy, silent. This has to be interactive, because we were thrown a gauntlet by none other than Professor Suresh David in how to take emergency care to the next level in India. So this talk is about half of that journey. The other half you'll have to do from within the departments. I'll tell you how we can do together the half outside the departments. So I'm Dr. Ram Nair. Did my undergraduate training in India and then went across to UK and did the post-graduation in general surgery, a few diplomas in emergency ultrasound, pre-hospital medicine, disaster management, critical care, anesthesia, and then came back. And as Sir rightly said, he was not correct when he said I spent 6 months with him. I only got 2 months of his time. When I went and started in CMC Vellore, Sir was in Australia. So all I can tell you is if you get a chance, do at least 1 week with Professor Suresh David. His impact is beyond words. So today we are going to talk about skilling up primary care practitioners to optimize emergency care delivery. Why? Why am I after non-emergency physicians to improve emergency care in our country? If you don't talk, I'll come to you. I'm going for them. Why is it? Thank you, sir. Go on, you can sit down and talk. No issues. Here we are all equal. Any idea? It is. If you look, absolutely. Thank you, sir. So if you look at the national data, 88% of acute presentations to a hospital, which is an emergency condition, is going into a primary care, secondary care, suburban setup, not a tertiary care hospital where the few of you are working. As we know, we don't have emergency care physicians working in the other hospitals. So what are we going to do about that 88% of poor patients, unfortunate patients, they may not be always poor, who are presenting with an MI or a sepsis or an anaphylaxis, and how are we going to improve the mortality and morbidity of our citizens if we don't do something about it outside of the four walls of emergency departments? So quickly, Jeevaraksha was a project started by Rajiv Gandhi University of Health Sciences, which is in the middle, and an organization called Swami Vivekananda Youth Movement, which is not far from here. It is just across the border from where Veerappan used to run around, Satyamangalam Forest, just across the border in Karnataka. They have got a tribal hospital, and this organization started by 12 interns, so even more junior than most of you, who went from Mysore Medical College after they completed their medicine MBBS and went into the forest. It took them 2 days to get to the tribal hamlets where they set up shop in the 1980s. And over the last 39 years, they've been doing different types of projects in social empowerment and tribal education, all sorts of things. So that organization, why is it moving? Okay, that organization with Rajiv Gandhi University of Health Sciences and University of Utah from USA came together to come out with a program. And why they did it, I'll come to you later on. So let's all reflect on this one case. Where's the microphone? Have you given it away? You can pass it to your next door neighbor. Can you please read that for me?
8-year-old son of a surgeon presented with breathlessness and fever for 5 days, become unconscious, rushed to the ER at same medical college. Plastic surgeon on COVID shift not interested in resuscitation. It's not an operation.
This actually happened. Some of you are smiling. This actually happened in Bangalore in a really big medical college hospital. Surgeon was working in that hospital. He's a staff member. What do you think happened to his son? Absolutely. Didn't make it. Now, is it important for every doctor to recognize a critically unwell patient? If you don't answer, I'm running to you again, okay? And is it important for us to stabilize that patient before the patient goes somewhere else? And is it important to get the patient to the right place? It could be the ICU, it could be the theater, it could be a tertiary hospital. So this is where the current status is of emergency care in our country. I talked to you about the majority going into hospitals which are not tertiary care hospitals. Sir talked about the minute numbers of trainees like you coming out to look after the patients in our country. And you can see there's a huge gap, a massive gap between the supply of physicians who are trained and the demand on the other side. We are now the #1 country in the world when it comes to population. So what do? We need to get that triple R across to our colleagues outside of the emergency departments. We talked about emergency care nursing, we talked about emergency medical services, but there is a big elephant in the room. Our own medical colleagues who are looking after the majority of patients outside of these big hospitals. If you get a phone call telling you that the patient has had IV fluids, antibiotics, patient was hypotensive, looks like primary infection, becoming a septic shock, you will be getting the patient in 10 minutes. The outcomes are going to be with that patient better than an uninvited patient, uninformed patient? Yes or no? Yes. So what communication tools would we use? Do you get any phone calls? So there's something called ISBAR. How many of you can tell me what ISBAR is? You can. Come on, shout out. Where's the microphone? Pass it on. Please.
Situation, background, assessment and recommendation.
What is I? You did really well. What is I? ISBAR.
Sir, I thought it was ABCISBAR.
It's I is for introduction. Who are you? And who is taking the call is also important. Very well done. So that aspect of communication. Of I'm calling you, my name is so-and-so, who am I speaking to? And this is a situation, this is a background. My assessment and action on the patient was so much. I've done such things. Can you please review? You are the tertiary care center, you are the anesthetist, you are the intensivist. Can you please give me any more recommendation that I need to do before the patient goes from my care? If we practice that simple communication tool, so many more patients can be saved on a daily basis in our country. So in 2013, there was a survey done in Mysore. They surveyed Mysore and nearby districts' hospitals, small hospitals, because the number of incidents of violence against doctors and nurses had just gone through the roof. Over a month, sudden reports of spurt of violence. 2013. I don't know what most of the youngsters were doing at that time, but those seniors here, any idea what happened in 2013? Why did that happen then? There was no COVID. What was the reason? Any guesses? Sorry? Not Kaveri issue, no. And I don't even want to get into it when I'm standing in Tamil Nadu while working in Karnataka. Too dangerous. It's actually not. It was actually the 108 ambulance services were introduced in Karnataka in 2013. So what would have happened? People who would have died at workplace, home, roadside, who would have normally died, were suddenly picked up by these fast taxis and thrown into the nearby hospitals. The doctors or nurses didn't know what to do because they're not expecting this kind of it's just moving. Are you changing the slides? No. Okay. Sorry. So the doctors and nurses who were used to routine elective kind of care were getting these patients who were critically unwell. They were not trained. As we all know, 2 weeks of observership in emergency department would have started in undergraduates recently, thanks to Dr. Einstein and team. But in the curriculum of MBBS, emergency medicine is not covered at all. So there need to be a covering of the gap from where our primary care physicians are to what needs to happen onto the patient when they come to us. So if you look at what kind of courses do you know? Life support courses in India. What do we do? There's ITLS in Vellore. Anything else? ACLS, come on. NALS, PALS, ATLS, there are lots. Guess how much it cost a doctor in 2013 to go from rural India to one of the cities and pick up all these courses? 1.5 lakhs and 15 days minimum to stay and do all these programs. That means accommodation, transport, everything is adding up. They couldn't afford. So we needed to find an answer. So at that time, thankfully, University of Utah came on board, and a consultation was done, and a comprehensive emergency care course was sort of brought out, which covered all the common emergencies, the bigger killers in India, and how to manage them based on the evidence-based protocols. Incidentally, Professor Suresh David was writing a course material for something similar called National Emergency Life Support around the same time, I believe, which has not come through to the rest of the country in a big way yet. Central government tried something similar. So Jeeva Raksha Trust was formed in 2019 because the demand from outside of Karnataka also was happening. So this was formed by the Rajiv Gandhi University, which is a state health university, in trying to evolve emergency care skills education amongst the nurses, doctors, and outside emergency department practitioners. Okay, so the vision is, as the name stands, just to save lives, simple thing. And a tourniquet on a patient by the roadside after road traffic accident, any idea how much more people we can save in India, which is #1 in road traffic collision deaths, if you tie a tourniquet for a preventable extremity hemorrhage? Any idea how many more people die currently? 40%. That's the highways authorities data if you look at it. 40% people die because of a preventable hemorrhage. All it takes is lungi, dhoti, dupatta, whatever. Tie a little tourniquet, twist it in, stop the bleeding. So many more people can be saved. We don't know what to do, and we are not doing it. So the mission is to equip healthcare providers, institution and public with knowledge and skills of current standards so that we have timely, collaborative. Each word is important, collaborative. Not my organization, your organization, I am bigger than you, we do it this way, you do it that way. A collaborative national set of guidelines to prevent people from dying, and it has to be cost effective. We cannot have the American ambulance system where they do all the tests, do all the vitals, call up a radiologist in the middle of the night with red flashing signals. We are far, far, believe me, having worked in both systems, it is impractical in our country. It won't happen. It's too expensive, that's why. Emergency medicine in all nations across the world is one of the most money-sucking specialties because there's no profit or output to come from it. So we can't have it. What do we need to do? We need to take our specialty and the skills to outside the walls of our departments and train those people who are going to be the first responders in these conditions. So we also do research and development as well as relief and rehabilitation. Not long ago I tried, this was before COVID actually, 4 years ago, I tried to collect a set of hospitals in Bangalore to give me data on pre-hospital cardiac arrest, just to look at how many die in India from pre-hospital cardiac arrest. Quick question, what's the survival rate in Europe? If 10,000 people have pre-hospital cardiac arrest, any idea how many live? Get discharged, go home with no significant neurological sequelae. Out of a 10,000, 1,500 to 2,000 make it. US, 2,000 to 4,000 make it. Seattle, 6,800 people out of a 10,000 pre-hospital cardiac arrest make it out of hospitals with no significant neurological problems. Any idea why? Early. So all of you have done ACLS, I'm assuming, ACLS is so important. AHA is God, right? So the two interventions which save lives in cardiac arrest, early resuscitation is a general term. It is actually early effective compression. effective compression, not just doing this, super fast one we do in the wards. And then the second one is early defibrillation, not ventilation. You should be doing delayed ventilation. We teach 30:2 in AHA courses in India, where most people don't do mouth to mouth, or we don't have ambu bags out there. We just blindly follow the protocols from there without realizing how things can be implemented in our country, what are the challenges and what are the risks. So Seattle did it because one doctor, I forget his name, one Jewish doctor, he implemented AEDs in every 2 blocks in the city, trained all the public in how to do CPR. Just those 2 cost-effective interventions makes them the biggest leaders in cardiac arrest survival across the globe. Can we not do it? We don't need a lot of money for it. We can't. We should be able to, and that is the answer for better survival. So currently Jeevaraksha offers a bunch of programs. One is the comprehensive emergency care and life support that I talked about, which is a 4-day program covering cardiac, respiratory, trauma, neonatal, pediatric emergencies, toxicology, burns, all in a 4-day format. There is an emergency nursing program, which was actually having tried to do a program in the UK for nurses, because even in the West, believe me, the nursing education is not given as much importance as the medical education. If you look at ACLS, ATLS, whatever, they come as observer or as a light candidate. ACLS light, ATLS light, etc. So there are no good emergency life support courses targeting the nurses. So primary care, secondary care, tertiary care nurses, academic and administrative nurses, and Western nursing faculties were sort of got together as a curriculum committee. They wrote this program. And interestingly, they asked for few things which were more than what I just mentioned to you in the doctor's program. Any idea what they are? The girls and boys in nursing asked for it. I've got 2 instructors sitting here, I won't ask you. Communication, absolutely. They asked for modules on communication. Anything else? That's a clue, communication. What else are they facing? Medico-legal they asked for, because they're not trained. And the third thing they asked for is psychiatric emergencies. They're really scared of psychiatric. Because when it kicks off, nurse, can you please sort it out? I'll be with you in a minute. Yes? Sorry, ma'am. So they asked for these 3 specifically. So the 4-day emergency nursing and life support program has all those modules and teaches them like a crash course. I'll tell you more detail about how the courses are designed. Then there is a 1-day program. This happened because when I was working in a tribal hospital and dealing with cardiac arrest and other emergencies, I had AHA trained house surgeons coming from medical colleges nearby doing a posting in the hospital. And once I said, there's a cardiac arrest, can you please take over? I got a shock of my life because I'm a fan of AHA, American College of Surgeons, and instructor of many of these programs, course director too, or was. And to see that an Indian doctor trained in India by one of those courses didn't know how to manage a cardiac arrest. And I asked the question, then we had to get involved and manage the patient. And afterwards, I asked the question during debrief, why? I'm really sorry, sir. We've got video course. It's like a lot of videos. There's one facilitator. At the end, all of us get certificate because we pay a very high fees. Nobody fails. I took it up with Dr. Sachin, who's the current AHA president. He's trying his level best to improve quality now. He's shut down a lot of centers. So there is a problem in blindly believing that if there is an American or a European or a whatever heading, it translates to actual skills and quality. So please, wherever you go, wherever you pay the high money, please make sure that you walk away with the skills, not just a piece of paper. Okay? So this course was written to cover not just cardiac arrest, because in India, even a broken arm is an emergency, because hospital could be half an hour, 40 minutes away. A snake bite is an emergency. Most people still tie tourniquet, you know that? In a snake bite. And the recommendation changed more than a decade ago. So including stroke, diabetes, seizures, snake bite, fracture, burns, infections, heart attacks. There is a basic emergency care and life support course, which is a 1-day program. It also teaches them cervical spine immobilization and tying a tourniquet with whatever is at hand. They all have to tie off the blood supply in the arm so that the pulse is not felt within 2 minutes. Only then they pass the course. Then the 3 courses came along because hospitals started requesting us for programs. And we've got a trauma care and life support, obstetric emergencies, and hospital emergencies. The other 2 are self-explanatory. The last one is if you're going in as an intensive care consultant or a registrar or a trainee to a ward to stabilize a patient, what all things you need to know. Advanced airway, inotropes, IV fluids, emergency drugs, and how to package a patient and take them to an ICU. So those skills are specifically taught, and management of all sorts of shocks, from hypovolemic to anaphylactic and everything in between. So I've already told you the whole content. I'll just show you how it is delivered. So one, it is made in India for Indian scenarios. Okay, so you get what we have to face on a day-to-day basis. So you will get a lot more of TB and sepsis and other such injuries from trauma from our patients compared to what we normally get given in one of the courses from the outside. So they're boot camp styled. Even an emergency medicine SR or assistant professor will struggle with one of our courses because we keep challenging them. If they know everything else, at least we'll teach them communication skills. So there is everything involved. Everyone has to be a team leader. And it is 70% skills and only 30% theory. They have to actually perform the skills, including putting in a chest drain and getting in a cricothyroidotomy in a cadaver, and demonstrate the skills before they are signed off. And other than the technical skills, as I said, the soft skills are also taught, very important for our nation. And we are not taught it as a routine. We tend to get these skills through experience, but many patients would have suffered by the time we get to the right level of competency in those skills. Oh, going back. So assessment is formative. There is also a 360-degree feedback, and there is mentoring right from 2 weeks before the course starts. 5 to 6 candidates are given to one instructor, and there is mentoring with the theory material that they are already sent through in clearing doubts and taking them through. And through the course, 4 days, 3 days, whatever it may be, there is constant mentoring at every tea, coffee break. We don't like instructors sitting together and having coffee, tea, and the candidates sitting somewhere else. We push them to move into the candidate group. And for the summative assessment, you have high-order MCQs, high-order thinking skills, and OSCE stations. Okay, so proper trauma scenario is given to them, and they have to go through. What is the protocol for trauma? Which is the protocol that we use? ABCDE, because who says so? Americans say so, right? In India, what is better? If you look at the death rates in our country, especially from bleeding, what kills first? Hemorrhage kills. So HABCD protocol, which is actually what the American military uses, our country is a war zone. I'm sorry. Our roads are like a military zone. So HABCD will save more lives in our country compared to the ABCD protocol that we are taught and we teach on the ATLS. So that's what we follow for trauma in these courses. So quick summary, project started in 2013. First instructor course was in 2014. We had the trust registered in 2019. It was made mandatory for all the students of Rajiv Gandhi University of Health Sciences, which is around 40,000 plus in 2019. And the courses were accredited, as you can see there. So currently, we have 921 ECLS instructors, 127 emergency nursing life support instructors. It only started as COVID came along, so the training of trainer program kind of stopped in between. BCLS, we got 1,187 instructors. Providers are those numbers. And we've signed MOUs with around 9 universities and other organizations outside of Rajiv Gandhi University of Health Sciences. The program has also been conducted in Morocco, Uzbekistan, and recently in Bhutan as well, which was an interesting experience. I'll tell you towards the end. So I am here for all days of the conference because Tamil Nadu government has come and signed an MOU with us to take these programs to the taluks in Tamil Nadu. Not just the medical training program. They fully understand that healthcare can't improve unless our nurses and the para-pre-medics also come along. So they've gone for the full package, and I humbly request all of you to help us out in this endeavor, because this is not about state boundaries. It is about lives of all Indians. You demonstrate it in one state, the receptive levels in other states will improve. And which better state than Tamil Nadu to do it, given that the father of emergency medicine in India is from here. MEM to whatever else you look at started here. Others might have taken credit later, but the seeds were sown here and the movement started in this state. So this is a recent picture from the Bhutanese course. One thing I didn't mention you is about who are the instructors. Who are the instructors for ATLS that you come across? They are from which specialty? Surgery, orthopedics, anesthesia, emergency medicine, critical care, right? How busy are these guys? Do they have private practice? So teaching, where is it in the priority list? And if you want to get all of India trained, is it possible just to depend on these busy clinicians? From our workload, we know it is not possible. So this picture is there for a reason. The lady on the right extreme here, or your left extreme, is Jinsy Joseph, who is an associate professor in nursing from deemed university in Karnataka, who has resigned and joined us full-time now as a coordinator for the emergency nursing and life support program. The lady in the middle is Professor Gayatri Bhatt. She is an anesthetic professor from Nitte University, who has trained all her PGs and interns in that university, even though it was not mandated under the Rajiv Gandhi University circular. The boy sitting at the very right corner is Sharath. He's a professor and HOD of pharmacology. So we take in all the doctors, because the skills we're trying to teach are MBBS level. Come on, to intubate a patient, you don't need a PhD. Okay, so the skills that are taught are at MBBS level. So we're going back to the MBBS in each of the instructors, getting them trained up. They get a second lease of life as well, because for whatever reason they might have moved into other specialties. They take it with a lot more of pride and passion than our clinical instructors. And one lady's comment was, in the past when there was an emergency, people used to run looking for a doctor, and I used to run with them to look for a proper doctor. This is a comment after a course. But now that I've done this program, I'll run towards a patient. That's a confidence we instill in our pre-para colleagues and makes a huge difference in scaling up. So what have we learned from this short journey? And for me also, the learning curve was huge. I came from NHS, which is a really protected environment. Most things are taken care of. Our young colleague was telling you about all the cons and pros, but pros were far outweighing the cons, right? From there to come to India, to jump into the grassroots NGO sector, to try and do something from the other side. Because people like me come to a corporate hospital, sit and lead the game is so much easier, because everything is set for you. So what we've learned is, if you're planning to do programs like this, make it mandatory, because the shine of an American or a UK or a European program is always brighter. And people always have better value for that piece of paper, quite rightly, because they are based on true research, many years of experience, and good protocols. Okay, so I can understand why. So the initial intake or uptake will be very, very low. Make it mandatory. Make it sustainable. Just because it is delivered by an NGO, it is delivered from a grassroots level, doesn't mean money will fall from heaven to support you. Nothing like that. Whatever you're doing, you have to make it sustainable. So a 4-day program, can you guess how much it cost a candidate till 2 months ago to do a 4-day program for the doctors? Any guess? These boys came just now. They don't know that I run to them. How much would it cost? 4 days. There is cadaveric dissection, there is intubation, there is chest drains, all sorts. 5 to 8,000. He's too right. Yeah, he's gone for 5 to 8. How much would it cost, sir?
I mean, just look at the hotel. Okay, just do a rough calculation. You're staying in a hotel, it's going to cost you at least 800 to 1,000 rupees. 4 days itself comes to 4,000 rupees. You're going to eat for 4 days at the cost of 500 rupees a day? That itself comes to another 2,000. Where is that? That's already 6,000 rupees, man. Forget the course. Course is free. So therefore, I mean, that calculation of yours, costing was too quick. It wasn't detailed.
So any other guesses? So you're also not far wrong. He is also not far wrong. Because when this question was asked in 2014 after the first course in Bangalore Medical College, the question was asked to the interns. How much would you pay for this? One kid, the highest quote was 35,000. Another, I think it was your brother or relative. He said 5,000. Okay? And remember, it includes the food, the tea, coffee, and getting instructors in everything. But we are crazy people, Swami Vivekananda Youth Movement. We bet ourselves in providing the program for 5,000 rupees, and that is what it was running for till 2 months ago. 2 months ago, the cost got increased by Rajiv Gandhi University, and we were fighting it but couldn't win the battle, to 10,000 rupees because medical colleges started complaining that they couldn't make any money out of this program. So now it is 10,000 rupees for 4 days. Nurses program used to be 3,000, now it is 7,500. One day program used to be 1,000, now it is between 1,000 and 5,000, depending upon who is running it. So make it sustainable. You don't need to make it profitable, but make sure the cost for the program is covered from the fees. Skill up the existing faculty. Don't go around trying to find new people. There are enough people out there with willpower, passion to teach. Get it from your existing people. It comes slow, but it is so important. You might be a big professor of orthopedics, but if you are slaving for 4 days, teaching kids what to do, what not to do, even if it is 1,000 rupees you pay as an honorarium per day, they feel valued. It's more about respecting the faculty rather than, because you can never compensate what they earn from one operation. So it's more about showing respect to the faculty. Keep the skills training model intact. I find it a lot in our country, when there is a skill station going on, there also we stand and talk about our anecdotes. 20 years ago, when I tried to intubate this patient, you stand and talk in front of an intubating model and talk and talk and talk. The candidates never get a chance to perform the skills. So make sure that 70% is untouched and they walk away with the skills, not with the memory of somebody showing some skill and talking the rest of the time. Please share the good news. Like Sir said about the school kid who was shown how to do CPR, we're getting any number of good news stories from medical colleges, from gardens, from schools about lives that are saved which would have otherwise been not saved. Share the good news, keep the passion up. Enable leadership. One individual can't do it. What is the beauty of this conference? You got leaders from all sectors of emergency care coming together for one reason and one reason only. It's not because somebody wants to be president or somebody wants to be secretary. It is because we want to improve quality in our career, in our profession. If you take that as a primary driver, you will include as many people as possible. You will make leaders everywhere you go. It doesn't have to be known in any one person's name. Last but not the least, this is very important, especially for the youngsters. I'm sure the seniors would agree with me. There will come many an opportunity for you to take shortcuts, but please stay apolitical. Don't subscribe into any one vehicle because those things will come and go however unchangeable they look at any point in time. So if you take one side, that is it. When the next side comes, you're out. And for the business of saving lives, you can't mix it with vested interests. So I'm going to stop here because I think I've bored you enough with what we are trying to do. Any questions or any sort of inputs from your side to how to do a program like this better?
One thing is, in the US, all the ACLS, PALS, neonatal resuscitation, or OB, everything is done by nurses or the instructors. Even cardiology professors and all those people who have to be recertified, they go and the nurses are the instructors. They are because it is cheaper. Because physician's time is more expensive, you have to pay more to the instructors unless somebody is not bothered about money and there are. So can we do the trainer of trainers for the nurses so that it will be cheaper because, physicians are busy practicing. They are, they are in the operating room and ATLS. To call the surgeon, it's difficult, but a nurse, they can do, teach as good as.
So, good question, sir. Already we have incorporated in that model. So, if you look at the ECLS program, there are modules in there which are like the postpartum hemorrhage, eclampsia, cardiac arrest management, neonatal resuscitation. All those modules can be taught by our ENLS instructors also. Nurses can teach. Trauma, we haven't given it to the nursing team yet because they need to learn and come to a certain level, which hasn't happened yet. Now, the doctors can teach the emergency nursing course, but they have to at least attend one program supervised, even if they are an ECLS instructor, because many of the things that are taught are slightly different, challenges are different, communication styles are different. We don't prescribe to the, I'm a doctor, I write an order, prescription order, right? We don't do that ordering business. We do a request. It's one team. Healthcare has to be one team. You can't be a hierarchy. So for that reason and for some of the technical content, we get the doctors in, sort of teach them how to interact with people in a polite and equitable manner, and then they are opened up. And all those instructors can teach the BCLS program as well. And the BCLS program can be taught by even non-healthcare people. We just say that either a nurse or a doctor should be the course director. The rest of them can be journalists, engineers, whoever has done the training the trainer program. Now the training the trainer program is 10 days for the doctor's course, 10 days for the nurse's course, and 4 days for the one-day program, the BCLS program. 10 days because they have to first do the provider program, pass with 90% mark in theory and 80% mark in practicals, and then they have to undergo another 5 days. Day 0 is about preparing the program. Most of us are used to turning up somewhere and one poor Dr. Ashima and one Dr. Einstein and another Dr. Selvaraj will do all the work. We just waltz in. Where is my podium? Where is my presentation? Yes or no? You can't do that in this. You have to do day 0. How do you arrange catering? How do you arrange kit? All that is taught in day 0. That is where they become one team. And then the next 4 days are the provider course where they are supervised instructors. And only if they fulfill all the objectives, they get signed off as an instructor. Sometimes people take 2 to 3 step 2 programs to become an instructor. If you don't maintain the quality of your instructors, you will not get a good quality outcome for your providers.
Dr. Ram, I want to know, I have 22 paramedics students with me. How do they reach you for a training?
You have reached us already.
I have. Because I don't have these many mannequins to train. So what I could understand is that because you are working with Rajiv Gandhi University, so you would be probably getting all the Karnataka students only. So is it that first we have to introduce to Telangana government and then we can have it, or the Telangana students can also come to your center?
Thank you for the question, ma'am. We have already done a one-day program in Hyderabad. Over 3 days, we did 3 courses for 90 nursing students in Hyderabad in one private hospital. So we have mobile units in Ballari, in Bangalore, and in Mysore. So for us to nip across from Ballari to Hyderabad, it's not too far away. We got enough instructors in northern Karnataka, between Gulbarga and Raichur, to come across to Hyderabad and teach. One of the founding trustees is Dr. Vijay Bhaskar Reddy, whose mother tongue is Telugu, which also helps. So you don't need to go through Rajiv Gandhi University, or you can send them to one of our programs which is happening in Karnataka as well. What I would always suggest, again from our experience, is rather than taking it as a product, create instructors wherever you are, because then it is a continuous program. And whatever the fees of the course is, 30% is taken away by Rajiv Gandhi University and Jeevaraksha for the LMS, the support, the certification, because all the programs are 5 years certified by the State University of Health Sciences in Karnataka. The other 70 is kept with the organizer for all the expenses and leaving a little bit of profit as well. So that is the model. We don't take all of the fees away. And for the nursing and the medical courses, you have a handbook as well. A printed handbook is given. For the BCLS program, for the 1,000 rupees, we cannot afford to print a handbook and give. So we are only taking 300 rupees. So within that, I can't cover my observer who goes in, because most courses, the nursing and medical courses, has an external observer who comes in on the exam day to check for quality. If they don't sign off the course, the candidates don't get certified. Okay? And one other thing, this picture was put up because, can you see any simulation equipment there? Any high-end, high-fidelity simulators in there? 2-3 crore equipment is not the answer to spread emergency care skills in our country. Okay? All of that put together, there are some more because many of the numbers are less in there. Together it will cost about 28 lakhs in today's market price to get a lab enough to train 30 or 40 people at a time, depending on the courses. We limit the doctor's course at 30 because quality will suffer. Nurse's course at 40, same thing for the one-day program. And the instructor to candidate ratio is 1:5 for the doctors, 1:8 for the nurses and the other program. That is also fixed. Otherwise, you can't have the quality. And other than this, we use cadaveric lab for the nurses and doctors program, and also something as simple as Vala Pindi, is it? In Tamil? Bale Dindu in Kannada? Bale Tandu. Yes, so this, we are talking South Indian languages. This Vadatanda, yes. So a stem of a mature plantain tree, after it has fruited and you've taken it away, it is used for a little sort of health supplement. Nutritionists and holistic medicine guys will tell us this. We use that as our intra-osseous practice thing. Because you leave 2 layers above it, your epidermis, dermis, periosteum, and you go into the marrow. Perfect feel you get with a marrow needle. So we even use as simple as things as that to train. Because if you look at the little leg in a baby, that is a intraosseous trainer kit. But what we want our doctors to do is, how many of you do intraosseous in adult patients? Any? You do, thank you. Which hospital are you working in? Aster MIMS in Calicut, okay. You guys do, yes. Very easy and effective way to get some resuscitation drugs in and get some fluid in somebody who's dying. What normally happens? Junior most will try, can't get, next level, next level, next level. By the time the consultant comes and tries, 45 to 50 minutes of valuable resuscitation time is gone. And ultrasound helps, but not in a patient with peripheral edema or completely shut down. So sometimes intraosseous has got value, and it is as safe and as easy to use as in pediatrics. If you ask your pediatric colleagues, they use it all the time. Then why not use it in adults too? So we're teaching that skill as well. And umbilical vein catheterization is another skill we teach, because NRP resuscitation, so much easier if you can put a little feeding tube into that umbilical vein and start giving medications. If there are no other questions, I'll thank you.
Thank you so much. It was very inspiring talk. And we'll be in touch, we need you in Telangana as well.
Thank you so much.
Yeah. So before we go to our next talk, I need Dr. Abdur Rahman. He has won the best paper prize, and this boy has to go catch his train or flight. So congratulations, Abdur. And there is Johnny Saxena. Yeah, thank you. He has won the best e-poster prize. So congratulations, Johnny. And thank you to all the students who have participated. We move to our next. Yes, sir. Yes, sir. Sorry, sir.
I just will take just 1 minute of my time to compliment Ram for the excellent enterprising work that he is doing. I'm so happy to see an emergency physician leave the realms of the safe, secure environment of an emergency department, step out into the wild and set out to do something that nobody has thought of, and in an area which is of much need. You have been a trendsetter, and as a group over here and as a representative and a servant of emergency medicine, I'd like to congratulate you and salute you for the yeoman work that you're doing. Yeah. May God bless you in all your endeavors, and you have our unconditional support for any help that you need. And I'm sure all the young people here will be more than happy to come there and hold hands and help you with whatever you require. Am I right? Yes, you see this. See, there are only two kinds of people in the
Dr. Karthikeyan, please. Oh, sorry, sorry.
Good evening, all. I'd like to thank ma'am and sir for giving me this opportunity today. And then it's a more informative session. I feel that proud to be here. My topic is today is the challenging CPR guidelines in COVID-19 era. As we all have been faced very tough situation in this COVID, and my topic is also sharing our experience how we faced the COVID era from 2020. So today I'm going to talk the introduction, the rules of CPR, adult and pediatric life support, and outside hospital resuscitation, where it have conclusion with maternal and newborn life supports. So we know that in COVID was being first identified in Wuhan in 2019, and it causes severe acute respiratory syndrome, where COVID was being declared as a pandemic in the year 2020, March, where the hospitalization was around 12 to 19%. In that, we have saw death was around 2 to 3. Likewise, globally, from the study of being found in till 2023 February, there were around 13 billion population has been vaccinated, and the exposure was around 754 million. So likewise, in India, we faced very hard situation, and by the support of government, more than 22 billion people has been vaccinated, and we found that and the COVID scenario made many people to get into trouble. But likewise, even though we do our resuscitation as effective as we have already discussed for past 2 decades, we do effective resuscitation to resuscitate and life save the people by doing effective CPR. So in this infection have gave us more challenge to resuscitate both outside and inside hospital. Likewise, what is the different methods we use while doing CPR is like to involving or performing effective CPR with. We know that while doing CPR, we do a head till chin lift so that the airway is being opened. In this scenario, when it is a suspected or a COVID patient, the aerosol will be remaining in around 1 hour on this state, so that we should be very cautious in dealing the cardiac resuscitation technique. So there should be a effective communication within the team. So how we are going to deal, whether it is exposed COVID or it is suspected or it's a proven COVID, it should be very clear in the communication. So how we prepare? So we should have a proper equipped PPEs, and also we should be very clear in the communication between the team lead and the team people, and like we should be when we need to be intubated should be very clearly known. It should be at the when there is a cardiac arrest and the saturation level was not been maintained, and we have alternate techniques to be used, like by using ETT, we can go for supraglottic airway so that we can be prepared and make us very comfortable. Likewise, we can use video laryngoscope for airway management. Likewise, we should be very reduced, provider should be there, like, sorry. So all rescuers should wear a proper equipped PPEs to protect themselves in the resuscitation area. Likewise, the scene should be very clear and the limited persons involved in the area can be more supportive to handle the patient with care. And also the rescuer should consider replacing manual chest with the automatic CPR compression machines so that the exposure of the aerosol can be reduced. Likewise, when a new person or a team member enter into the scenario, he should be very clear about the scene that the patient has been COVID exposed or the positive or negative. It should be very clear. The history should be very clear. The communication between the team lead and the team member should be proper. Likewise, there are few rules to be followed in this scenario that we should know that do not check pulse, breathing. Only we should check the pulse. If there is any absent in the patient, if needs of rhythm analysis, it should be clear that with the need of DC shock. Likewise, to start, and we should not give a compression until that the team has been fully equipped with PPE protection equipments. So give meantime you can give an electric shock for a corona patient by using a defibrillator. So some causes like chest compression can cause aerosol droplets. Therefore, do only after you get full corona PPE. So for some rules to be followed, like the drug regimen has been not changed, and the maximum attenders for the CPR should be not more than 4. Like already we saw that we should be very full. We can use video laryngoscope for intubation. Likewise, we should be in this scenario we avoid to use BMB directly. We can use HEPA filters to support the aerosolization, and if the patient is being intubated, we can do with a cuffed endotracheal tube. Likewise, if we connect to bag and mask ventilation, likewise, and also in ventilator with the help of HEPA filters. So if available of HEPA filter, the path of any exhale gas to be manual or mechanical ventilation could be more helpful for us. So before intubation also we can use this with the bag and mask device. Likewise, considering manual ventilation, we can use video laryngoscope for doing the airway stabilization in a effective way. So the main changes we have in this AHA is like, so you can appreciate here that before getting into the scenario, we should don ourselves with PPEs, and the limited personnel should be managed. Likewise, while doing a bag and mask ventilation, we should have a tight seal with the help of HEPA filters. Likewise, for the ACLS protocol, we know that the limit personnels, and also to consider the proper resuscitation with highly trained instructor and the team members support us to make the resuscitation, and need of early intubation is not being recommended. If you are easy to manage with the ambu bag with a HEPA filter, it is advisable. Likewise, when you need to connect to the ventilator, do with HEPA filter. So in hospital, if you have experience in pre-arrest, you should be very clear in advanced care directive with and you should be very elaborated with the goal of the care, and consider proactive movement to the negative pressure room if possible. Make arrangement, and also the door can be closed to prevent the airborne contamination. Likewise, if patient is being considered at the cardiac arrest stated, please intubate. Until that, you can help with the ambu bag ventilation with the help of HEPA filter. So when in intensive care, you can consider high flow with continuing the ventilation with volume control or pressure control mode by increasing the FiO2. Like if needed for airway to be supported with airway ambu bag ventilation, don't make the team to be more cautious, and you should be very clear about the team management. So this is the next way of we usually do with the post COVID exposure. When we find that the patient is going for a cardiac arrest, we can do and proceed the CPR in a prone ventilation status, and also it the position where we need to be placed the our position is around in the thoracic vertebra 7 to 10, so that the effective resuscitation can be considered. Likewise, we can use the paddles on the anterior posterior area for giving a synchronized cardiac defibrillators. So in outside hospital, the rescuer for the adult, there will be a proper way of handling. We need not to go for airway like giving a mouth-to-mouth breath. Only CPR technique can be advisable. Likewise, if in especially household members plays the role in resuscitation, like non-household members can be helpful by covering the face with a towel or a polythene paper, which we appreciate in this image. Likewise, in the chest compression for children, it is considered to be have a proper chest compression, and also if needed, we provide mouth-to-mouth breath with the household members, and also those who have been got already exposed. So defibrillators, AEDs are more advisable as it is out hospital resuscitation. Likewise, the telecommunication should be very clear in explaining the condition and how we need to manage the situation to guide the lay rescuer about the risk of the exposure, and also to alert the EMS team before entering into the scene to be properly donned with PPE. Likewise, the family members, while transporting, it's strictly advised not to with the team with the patient. Like our when the team has been arrived to the scene, they will be with properly equipped and properly PPE has been done. And if they initiated the CPR and they couldn't able to resuscitate in their home, we can ask them to consider to stop that the ROS is not been achieved and does not need to transfer to the hospital. Likewise, in neonatals, mostly COVID mothers were the more potential to expose the team. Likewise, we should be very clear in resuscitating the mother. And endotracheal, while we are resuscitating the neonatals, sometimes the medications through the endotracheal medications like such as epinephrine or surfactant can be given, can be withholded, and also we can preferably go for epinephrine in IV route. Like closed incubator transfer and care should not be used for the neonatal ICU patients, and if and it's not going to be more helpful to protect from the aerosolization of virus. Likewise, in the maternal cardiac arrest, the unchange for the women with suspected or confirmed COVID, we should be more clear in preparation for perimortem delivery that can be occurred after 4 minutes of CPR, and if it has been initiated early, to resuscitate and follow the algorithm as earlier as for the adult cardiac life support. Advanced cardiac life support. Likewise, this is the call we follow for the resuscitation. Like if needed for any outside hospital for resuscitation, we should cover our mouth and nose with the face mask. Likewise, patient, and start to perform a high quality CPR. And if need of, if there is an available for AED, please resuscitate with the effectiveness. So for the conclusion, for the reduced provided exposure, don yourself with PPE before entering the room, limit the personnel, and also consider for using mechanical CPR devices if it's available. So communicate with the team for a proper equip and for proceeding the resuscitation. And for oxygenation, use HEPA filter. And if you are being equipped with video laryngoscope, please proceed with video laryngoscope. And mostly, the intubation can be proceeded with highly experienced or technical exposed candidates, so that we can more particular in saving the patient and also work for the resuscitation. And to consider the appropriate resuscitation, address goals of care should be discussed, and adopt policies to guide determinant taking into the account patient risk for survival. So these are some websites which I have been were supporting for me to take these details. Thank you.
Good afternoon, everyone. This is going to be a lecture on an approach to a gasping patient. Can anyone recognize this gentleman? Anybody? That's William Osler, and one of his quotes was, "The practice of medicine is an art." And this lecture is going to be more about the art of medicine behind the science of medicine. So it's going to be a lecture about how I approach a patient with gasping rather than what the textbook says. What exactly is gasping? There are two ways of looking at it. One is an entire spectrum of severity of respiratory distress. So you have a patient who has tachypnea to begin with, carries on being tachypneic for a long time, his intercostal muscles become tired, ends up with respiratory fatigue, and then that progresses further and ends up with respiratory failure. And then there is an impending respiratory arrest, and then they can have agonal breathing. On the other side, there are named breathing patterns, like Cheyne-Stokes breathing and Byard's breathing, which can also be called as a gasping state. So we'll look at these things, and I'll concentrate more on the respiratory failure and fatigue part of it. Right. Agonal breathing can also be seen after a cardiac arrest. So patient will have no pulse, but can have an agonal breath. Treatment, pretty simple. Just follow your standard ACLS guidelines or resuscitation guidelines. Is a peri-arrest situation where the patient is going to arrest any moment. You can already see the saturation drop. You can see the bradycardia setting in, heart rates dropping in front of you. What I call the cowboy approach. Shoot first, think later. So intubate the patient, take control over his breathing, and then start thinking what exactly is going on. 99% of the time, that's what is needed. I can probably just remember one instance where I pulled a patient out of peri-arrest without having to intubate. So 99% of the time, these patients need to be intubated. So just go ahead with it and then think about what to do next. Now, intubating a patient with severe dyspnea, or the cowboy approach I had mentioned, has its own advantages and disadvantages. The advantages, you get rapid control over the breathing, and the patient gets sedated. Now, a very tachypneic patient will be sitting up, breathing heavily, sweating profusely, will be a bit agitated. It's very difficult to get him to lie down, get an IV line in, or do an ECG. It's very difficult to do any of those procedures. Once you intubate, the patient is sedated, and then it becomes more easy to manage him, and you have more time to make your diagnosis and plan your further treatment. But it also comes in with some disadvantages. Crash intubation, there's a high chance of traumatic intubations. Imagine a very obese man with short neck coming in very dyspneic, and you decide to do a crash intubation. What are the chances of esophageal intubation, or the bougie going to the wrong place, or trauma to the vocal cords? All sorts of things can happen. The other main issue is when a patient is really gasping for air, he's having a really high adrenaline drive. And usually when you see these patients, they'll have a slightly higher blood pressure. The systolic will be around 150, 155. That's because of the adrenaline rush that these patients are having. The moment you intubate and take over their breathing, they lose that adrenaline drive. And you'll find that within 5 minutes of intubation, the blood pressure comes down crashing. And once you have intubated, assessing the neurology is going to be very difficult. You might do a CT scan, you're going to end up a brainstem infarct. And the next day, you're still wondering why the patient hasn't woken up. You start thinking of MRI. So all that will become the disadvantages. So just because you intubate doesn't mean you stop thinking. You still have to continue thinking and treating the patient further. Right. So this is my approach. How many of you heard the door to trolley time and the trolley to vitals time? Probably nobody heard about because I made this up last night. The door to trolley time is probably what I would describe as the patient entrance through the door of the emergency department onto the stretcher, or the ambulance stretcher, onto the ER trolley. And the trolley to vital signs, once you transfer the patient onto the ER trolley, you have to get him onto the monitor, check his blood pressure, check his saturation, and you get a vitals. So again, you have a little bit of time. Probably be a couple of minutes on either side. So what do you do during those precious moments? Right. I always go for a focused history. Okay. Just ask the relative what happened. There are two responses you can get. Either he's going to give you the diagnosis, or you're going to realize you're not going to get any information from him. Don't waste your time with the history. Okay? If he's got a referral letter, you might have the diagnosis in your hand. It makes your job that much more easier. Okay? Use that time to inspect the patient. Okay? Look at his breathing pattern. Look at his accessory muscles of respiration. Is he sweating? Is he sitting up? Is he lying down? Is he comatose? So all that information you can get during the door-to-trolley time. Another thing I do is when you're shifting the patient from the ambulance stretcher to the trolley, I always lift the patient's leg. Okay? There are two reasons why you do that. Everybody is concentrating on the head and body when shifting a patient. When very often the legs get caught in the bed. So that's one reason I do. The second reason I do that is, a wise man once told me, if you don't touch the patient's leg, you will miss the diagnosis. Okay? That is also a chance to examine the leg, and there's a lot of information you can get from it. You can feel the dorsalis pedis pulse. That will, if the foot is getting perfused, your vital organs are getting perfused. You can see if he's got pedal edema. Is there a cellulitis? Is there a DVT? Is the leg swollen? So there's a lot of information that can be got from just looking at the leg while transferring the patient. Okay. So the next is the trolley to vitals time. So these are two time frames that I have defined last night. So the trolley to vitals time. So what do I do in that? A bit more of the history. Usually I send one of my juniors away to get a bit more history from the patient. See if there's anything else in the history that will make sense as to what is causing the problem. Inspection of the chest wall. Remember, this is the time that the patient's clothes come off, the hospital gown goes in, he gets connected to the monitor. So this is probably the time you get to inspect the chest and also get an opportunity to auscultate the patient. Okay? And obviously the vital sign. If possible, get a saturation in the room air, but don't really insist on it. If the patient's on oxygen, leave him on oxygen, check what the saturation is. Right. Now you heard about the 5H and 5T of resuscitation. I call this the 10 P's of respiratory fatigue. So the idea is within this time you have to make a diagnosis. Not even a differential diagnosis, you have to get to a diagnosis, because if you don't get to the diagnosis, you're going to go end up the intubation route. Okay? So if you get a diagnosis, you probably will be able to get away without intubating these patients. Is there a possible foreign body? A child eating peanuts suddenly become tachypneic. There you have it. That's your diagnosis. Pulmonary asthma. Again, patient might have a severe wheeze, he might have a silent chest. Okay? But always consider asthma, especially if they have a past history of asthma. Then there are the PEEP seekers, the COPD patients. Okay? So again, if they are in respiratory acidosis or in CO2 narcosis, these patients can come quite uptended. Now these two category of patients probably start off with nebulizers. COPD patients probably start off with NIV. Now NIV is contraindicated in altered sensorium, but sometimes you just have to throw that aside, bite the bullet, put him on NIV, give him a few minutes, see if he responds. If he responds, good, you avoided an intubation. If he doesn't respond, you still have you've got yourself more time to prepare for a more elective intubation and thereby reduce the risks of a crash intubation. Pneumonia, again, from the history, you can get quite a few information to make the diagnosis. Pulmonary edema, you've already seen his legs, you already know whether he's got pedal edema. Again, history will tell you whether it's cardiogenic or is it a renal. So quite a few things you can get. And cardiogenic pulmonary edema responds brilliantly to CPAP and NTG. Okay? You put them, connect them to the NIV, give them some NTG, get the blood pressure under control, they respond beautifully. I've had gasping patients whom I've just bagged with an ambu bag, got them breathing, put them on the NIV, and they've come out very well. Right. Pneumothorax, again, you're going to auscultate. It's not just pneumothorax, even any trauma to the chest, hemothorax, the whole thing, again, can present in this. And attention pneumothorax, all you need to do is put in a needle, get him out of the gasping state, and then get your tube in. Pericardial tamponade, again, Beck's triad. You'll be auscultating the chest. Okay, can you hear the sounds? You can look at the ECG trace on the monitor. Are you getting a good ECG waveform, or is it all small waveforms? So that will give you an idea. Psychogenic. Psychogenic can be difficult to pick up at times. Okay, but if the patient has a past history, then you know that's where he is. When I was in the UK, we used to have a frequent flyer, as you call them, called Emma. It might be Veronica's friend, probably, for those who know who Veronica is. This lady has been to the pulmonologist several times, has been branded a brittle asthmatic. Every time she comes to the emergency department, she has an audible wheeze. The moment you enter the room, you can hear that audible wheeze going on. But if examined properly, she's actually making that sound from her upper airway. And every time she comes in, she stays there for a few hours and then walks off home. And she used to hate me because I suggested she needed a mental health assessment. But one day, she actually came in and didn't speak at all, looked quite sick. And she was actually having a silent chest. So she was really an asthmatic, and when she gets a wheeze, she goes into a silent chest and can be quite sick. So psychogenic breathlessness, again, can be a bit of a challenge to diagnose. pH, metabolic acidosis, is compensated with tachypnea. Typical history will be that of a DKA. Patient stopped insulin for some time, hasn't been eating, generally unwell for 3-4 days, and dyspneic for the past 3-4 hours. Okay. Now these patients, sometimes even a shot of bicarb will just get them out of the gasping state, buys you a bit more time, and then your insulin starts kicking in and you can get them out of this. And then poisoning, again, the history is going to give you a clue. Cheyne-Stokes breathing, we all heard of it. Cyclical episodes of apnea and hyperventilation, commonly caused by cardiac failure and stroke. Okay. Again, if it's cardiac failure, it's going to respond brilliantly to CPAP and NTG. Biot's breathing is basically variable tidal volumes, random apneas, and no regularity. It's like the respiratory fibrillation, the equivalent of a atrial fibrillation, if you want to call that. And typically seen in cardiovascular accidents of the pons and medulla, or uncle or tentorial herniation. Meningitis can cause this at times. Another differential of this is opioid overdose. I once had a patient being referred from a smaller hospital where he had undergone a lower limb surgery, was given combined spinal epidural anesthesia, and then was converted to a GA. Post-surgery, he was extubated and was having this rapid breathing. And they referred the patient on to a bigger center. So when he came in here, had this typical opioid breathing, all I had to do was give him a shot of naloxone and the patient was fine. So again, if you go by the cowboy principle, you're going to intubate this, you're going to wait for a long time for the opioid to wear off. Remember, even epidural morphine can stay in the system for a long time. It might be just 2 milligram or 3 milligram, but if it's given in the epidural, it's going to stay for a long time. Kussmaul's breathing, deep and labored breathing, typically seen in metabolic acidosis, sepsis, DKA. Apneustic breathing, it's a deep inspiration with a pause at the end of full inspiration and followed by a partial expiration. It can be a bit difficult to pick up because it's very similar to the Kussmaul's respiration and is usually caused by injury to the pons and upper medulla. Again, ketamine can cause this, but it's usually a very transient period. So if you see this apneustic breathing, very often it's a brainstem problem and probably will end up getting intubated. Right. I'll finish my talk with something for you to think about. Would you intubate this patient if he came in gasping? And I think Sir Robert Hutchison has given us the answer. Thank you.
Thank you, Dr. Pratap. And oh, this is the perfect timing. Yes.
Time for my flight, actually.
Yeah, time for your flight as well. So we are, Dr. Varun, you are going in the night? You are traveling? You will just bear with me for some more time, please. Thank you. Venu sir, I'm looking for. Venu sir, where is Venu? Venu sir, yes sir.
I just wanted to, sir, thank you. I just wanted to compliment you on taking up a facet of time when a patient is coming into the hospital and elaborating on it and creating your own algorithms for that. I must compliment you for that, because this is not something which is focused on. That is the time when a patient comes into the door, through the door, and is settled onto the bed in the emergency. So what Dr. Sanjeev was trying to do was, how do we utilize this time very well? And I think that's fantastic, because that time is not usually taken into account for any clinical assessment. So thank you for enlightening us on that.
I think you missed one of my earlier slides, and it was about the art of medicine. And I said
I missed
the
that.
presentation is about the art of medicine rather than the science of it.
Well done.
Yeah, good evening. Uh, Thank you, organizers, for inviting me for this wonderful opportunity. And I'm going to talk about one of the interesting topic which most of the ED physicians do face whenever they are finding an hypoxic patients. So when they in the ED, when you get an hypoxic patients, the ventilation part is the second thing. So as soon as you're intubated, what can you do for a refractory hypoxia? So I think that is an important thing which at the ED, at your triage, at your red zone, as soon as you intubate you can think about what to do. Subsequently, what happens in the ICU, also you will see the results. If you don't do it at the point, the results in the ICU won't be seen. Okay, so we'll be talking about recruitment maneuvers. Okay. So I just want to give a statement which I know it is a very important aspect in ARDS. So what you're talking about is purely about ARDS type 1 respiratory failure. So in ARDS, it's beyond doubt that you have to protect the lung. So that's when the ARDS net trial came in, which said that you have to ventilate these patients with low tidal volume. So normal physiological tidal volume, what we ventilate in routine practice is somewhere around 8 to 10 ml per kg. In ARDS net trial, they came to up to 4 to 6 ml per kg. So that is one of your lungs protective strategy what we do. So they say that low tidal volume, whatever we use, will cause derecruitment. Derecruitment means it causes lung collapse. So which was useful has some negative effect. That is called derecruitment. And it can also worsen the hypoxia. So what exactly you have to do? So you will have to do some maneuvers so that you keep the lung open. It does not collapse. So use recruitment maneuver along with some amount of PEEP so to prevent the derecruitment. So we'll restrict to the topic. So talking about ARDS, it's going to take a lot of time. So we'll talk what is this recruitment maneuver. So this basically a recruitment maneuver is you're deliberately giving some amount of pressure so that you open up the alveoli. There's a collapse. ARDS is a heterogeneous disease. So we have studied in our UG days that there are 3 phases in ARDS. One is the exudative phase. Next is a fibroproliferative phase which it goes to. So between these two is a wide time what is available. So you have to catch the patient very early. So when you catch the patient at the exudative phase, during the early stages, you can play around with the lung. If you catch up the lung at the end part, that is at the fibroproliferative stage, whatever you do will not work. So what you do is deliberately you're going to give some pressures, open up the collapsed alveoli. So basically you're trying to increase the driving pressures, what we say. So what is this driving pressure is your transpulmonary pressure. So that is nothing but your plateau pressure or your alveolar pressure minus your pleural pressure. So when you see a ventilator graphic, you see 2 pressures, plateau pressure, and the pleural pressures. So these 2 difference is your driving pressure. So you will have to make sure the driving pressure is enough to open up the collapsed alveoli. That is a basic thing. So why you do that is you think that that pressure will open up the collapsed alveoli. That is one thing. Second, obviously when the collapsed alveoli opens up, it gives more surface area of the alveoli. Once the surface area is more, better oxygenation and your hypoxia improves. So that is a basic concept of why you do a recruitment maneuver. Okay. So before talking into recruitment maneuver, it's very important for us to acknowledge Latchman. Okay, the Latchman is the first person who coined this terminology, very important terminology in ARDS, open up the lung and keep it open. So you have to do some maneuvers to open up the collapsed alveoli or the injured alveoli, and you have to keep it open. So you have to do 2 things. You have to open it up and keep it open. Okay, just remember these 2 things. I'll tell you what happens. So the 2 things what you're going to do to open up the lung is one is anatomical recruitment. The second one is functional recruitment. So what is this anatomical recruitment? So anatomical recruitment, as terminology says, you're going to open up the alveoli. So the basic thing is you can see in this diagram. So the first one is the upper one, the black. The black one is the collapsed one, okay? So this is the thing. So other one is partially collapsed, and the basal part, usually the dependent part, is the totally collapsed. So when you do a recruitment maneuver, basically your idea is to open up as much as alveoli is possible, okay? So you're trying to open up. So when you give a high pressure, the alveoli, the normal lung, which is, this is called as a baby lung. The baby lung is the unaffected lung. So that is what in ARDS they keep saying, we will try to protect the baby lung. Okay, this is already damaged. So your idea of ventilation in ARDS is open up these collapsed alveoli and at the same time protect this baby lung. So when you do a recruitment maneuver, you're going to open up this baby lung. So you're going anatomical, this is called as anatomical recruitment, where the majority of the lung is open and some part of it is diseased, which requires very high pressures. You can't do anything about it. So you open it up so that the hypoxia improves. But the problem is when you're too aggressive in opening it up, the alveoli is so much distended that the underlying blood vessels, which is going below the alveoli, it gets compressed. That is not good. So if you're too aggressive in opening up so that you expect the alveoli is open, you compress the underlying blood vessel. Once you compress the underlying blood vessel, even the gas which is coming in is not able to perfuse. So your ventilation perfusion mismatch still occurs. So we don't want an anatomical recruitment. What we want is a functional recruitment. In the functional recruitment, you open up the alveoli to such an extent that the underlying vessels are not collapsed. So this, what occurs here is shunting. So you don't want to worsen the shunting. So you want to keep it open. You want the blood vessels to be open so that better diffusion of gases, your PF ratios improve, your, the carbon dioxide, better washout occurs, hypoxia improves. So this is what Latchman tried to tell you, that you have to open up the alveoli and keep it open. So how do you keep it open? I'm going to talk to you later. Okay, so the two things which you're going to do in recruitment. One is you're going to decrease ventilator-associated lung injury. So that's called as a VILI. So what exactly happens in ARDS is there is a diseased lung. And if you don't properly ventilate such patients, your maneuver or your positive pressure ventilation itself can cause damage to the lung. So that is called as ventilator-associated lung injury. So how do you reduce this ventilator-associated lung injury? So imagine in a normal state, you have two healthy alveoli. Whatever, when you give a positive pressure breath, the gases go to both the alveoli and it gets distended equally. Now imagine you have an ARDS lung. So you have an ARDS lung, a healthy lung, and an abnormal collapsed lung or injured lung. So when you give a positive breath, our aim is to open up this alveoli. Right? So what happens is the gases go preferentially to the healthy lung because these pressures to open this alveoli is very high. So it cannot, the gases don't go here. It starts going here and starts over distending. So the normal lung, which was normal before you start ventilating, it starts over distending. So what happens when there is over distending is it starts over distending and there is break in the alveoli. So it starts getting injured. So your aim is to open up this. That is why you have ventilated the patient. But because of inadequate ventilator settings, this starts over distending, and this starts breaking up, and this also gets injured. So that is ventilator-associated lung injury which occurs. Second thing is, if you see in the right side of the diagram, you have a collapsed alveoli. So everyone try to imagine a collapsed balloon. So it's very difficult to blow the balloon at the initial stage. You require a lot of pressure. As it is expanding, you don't require much pressure. The same thing is this. So when it is totally collapsed, you require very high pressures to open it up. So once it is open, the pressures required to open and close is very less. Okay, that is one concept you want to know. So that is what you're doing in recruitment. You're trying to recruit so that the next cycle, when it starts to, when there is breath going in and out, there's less movement. And imagine you have a cut on your forearm or an injury. If you keep moving it, will it heal? No. The same concept is here. If a injured alveoli, like this alveoli, if it keeps closing and opening, if it keeps closing, it will never heal and it will require high amount of pressures. So that will cause something called as shear stress on the vessel. So the repeated opening and closing of the alveoli will not only cause insult to the alveoli, it will start releasing a lot of cytokines. These cytokines will go and damage the already normal healthy lung. So that is why you would have seen a ARDS patient you have intubated, the pre-intubation X-ray is something and the post-intubation X-ray is something. So it is because of your ventilator-associated injury, what you have done with the inadequate pressures, whatever you have said, the repeated closing and opening of the alveoli. So you have to open up the alveoli so that it is distended. And imagine now, I talked to you about the balloon. So you have blown the balloon. If you keep the nozzle open, will it be inflated? So you have to pinch the nozzle, right? That pinching the nozzle is applying a PEEP. So you blow it, you recruit it, you make it big. You can't keep it open. You need to keep something above so that the alveoli does not deflate. So you keep a PEEP. So you have to do two things in ARDS always. Recruit, open it up, keep it open. So keep it open is by applying something above. So you keep a PEEP. So these two maneuvers is the thing which will keep the lung open. Okay, so those two things. And if you see the graph in between, this is a pressure versus volume graph. As you can see, as the pressures increases, the curve is, it's straightened and then it becomes plateau. Okay, this is a PV loop. So there are 2 points which you will have to know about it. Point A is a lower inflection point. Point B is an upper inflection point. So what are these 2 points? Point A is the pressure below which the alveoli is collapsed. Point B is the point above which the alveoli is over distended. So your main area of ventilation, or after you intubate the patient, is you have to ventilate the patient in the safe zone so that your pressures are not too low so that it can't open up the alveoli, or your pressures are not too high to distend the alveoli. So this is a safe zone of ventilation, which is called as the safety zone. And based on this zone, we always tell you in an ARDS patients, your plateau pressure should not go beyond 30. Because if the plateau pressures go beyond 30, it's over distended. So this is the zone, it's where the protective zone, what we say. So yes, recruitment maneuver is important. So many of your guidelines in ARDS patients, the level A evidence is for low tidal ventilation, irrespective of type of ARDS. You have to have some amount of PEEP. And they have also included recruitment maneuver based on whatever the important aspects of it. But the second question should we ask is, yes, the guidelines have told that recruitment maneuver is good, but is it helpful for all? Does one size fit for all? So that is the next question we are supposed to ask. So this is a very important paper where they try to tell you whether the recruitment maneuver improves. What they found was, in ARDS patients, we have 2 types of ARDS patients. One is pulmonary cause for ARDS and extra pulmonary cause of ARDS. Like a patient with trauma can have an ARDS, right? So that is called an extra pulmonary cause for ARDS. And then you have pulmonary cause, like it can be a pneumonia, whatever it is, can be a cause. So they found that patients with increased extravascular lung volume, so those are the patients with pulmonary cause of ARDS, because of lot of interstitial edema, recruitment maneuver was not useful for the obvious reasons, because there is a interstitial edema, and if you're trying to open up the alveoli, it will prevent it from opening. So increased extravascular lung volume reduce the efficacy of recruitment maneuver and increases the complications, because you're going to give high pressures, it's going to cause complications. Next, what they found was patients with lobar involvement of the lungs. like only one lobe is involved. You try to do a recruitment maneuver, your recruitment maneuver fails. So what instead they found was if there's a patchy involvement in the lung, a recruitment maneuver worked well. So if a lobar involvement, you try to increase your pressures, you try to ventilate them, give high pressures, you're affecting the baby lung, whatever I spoke to you previously. So the unaffected lung starts getting injured. So lobar involvement had less response and more predominant hyperinflation and complications. So now we have two types of recruitment maneuvers. You would have read about recruitment maneuvers, there are plenty. But two important things what we follow most commonly is, the one is is called as sustained inflation. So in sustained inflation, what we did was, we'll come back to this, the same thing. Okay, so you have a patient who's ventilating. You transiently increase their airway pressures. So supraphysiological increasement of their airway pressures. So once you increase the airway pressures, you are anticipating the collapsed lungs to open up. So that is what you're going to do. There's something called as 30:30. You keep a pressure of 30 for 30 seconds, or you keep a pressure of 40 for 40 seconds. So whatever it is, you can use it. But transiently, you're going to increase it to very high supraphysiological pressures, anticipating the collapse alveoli opens. And then the patient ventilates again with the whatever the basic ventilator statistics stats what you're applying. So what is the problem with this? So we'll go back to the equation. I told you the driving pressures, the transpulmonary pressure is nothing but your plateau pressures minus your pleural pressures. So if you have most of the ARDS lung, as per the journal mentioned below, so what they found out, pleural pressures were very high. So pleural pressures in an ARDS lung is somewhere around 20 to 25 millimeter mercury, based on severity of ARDS. So if you have pleural pressure, which is measured by an esophageal probe, what you place in the lower end of the esophagus and measures the pleural pressures, this pleural pressure, if you kept an alveolar pressure of 30 minus 20, the transpulmonary pressure or the driving pressure is only 10. This delta P, what we say, so this driving pressure is very low to open up the collapsed alveoli. So what they found was sustained increasing the pressure did not show much benefit in recruitment. So, and most of the recruitment occurs in the first 10 seconds of your, whatever duration you kept. You kept a 30:30. So only in the first 10 seconds recruitment occurs. The next 20 seconds, you kept the alveoli exposed to such high pressures where you're going to see all the complications. So they found out that it was not benefit. It in fact increases complications, increases hyperinflation, and cause hemodynamic instability. So what commonly we practice and what recommended is something called as the stepwise approach, or the staircase phenomena, what we say. So how do you do a stepwise approach of recruitment? In the previous one, I told you directly you're going to high pressures, wait for 30 seconds, and it falls back to the baseline, and again patient starts ventilating. What is the stepwise approach? So what you do is, as soon as you have intubated the patient, in the ED you have intubated the patient, you have started with some arbitrary value of PEEP, 8, 10, whatever it is you have started. How do you know it is right or wrong? So stepwise you start increasing by 3 to 4 centimeter of water, giving an interval of 2 minutes. So every 2 minutes, you keep increasing the PEEP. So you put the first thing is you put the patient in the pressure control mode, and you should have a delta P. So I told you what is a delta P. Delta P is what pressure control you keep on the ventilator minus the PEEP. So imagine you kept in the pressure control, you kept a pressure control of 20 and a PEEP of 10. So the delta P is 10. Okay, that is your driving pressure. That is the pressure which is required to open up the alveoli. That is the meaning what you give it on a ventilator. When you keep a ventilator 20 and a PEEP of 10, that is the highest pressure. You don't want the alveoli to go, the airway pressures to go over, and you kept a PEEP telling the ventilator, I don't want the pressures to fall below this. So the difference between these two is your delta P, and this is your driving pressure. So that is a basic understanding of what is delta P. So you keep a PEEP of 10 so that your delta P should be fixed. It can be 10, 15. So maximum we keep is 15. So if you keep a PEEP of 5 or 10, so your pressure control you're going to keep will be, how much it will be? 10 plus 15, right? It will be 35. So you'll keep 35. So you keep increasing the PEEP gradually by 3 to 4 centimeters so that your delta P remains constant. So if you increase the PEEP by 5, your your pressure control also from 35 should go to 40. So you keep incrementally increasing up to a PEEP of 30. We are talking about a PEEP of 30. Okay, many of you might get very jittery, I understand, but you are going to a PEEP of 30 so that the pressure control, what you go up to 50. So gradually, stepwise, you're increasing so that this is more physiological. So slowly the alveoli starts opening up. So slowly the alveoli starts recruiting. So once you've gone to a highest pressure, then again you're going to slowly decrease it. So you keep decreasing in the same stepwise manner until a point where the alveoli again collapses. So I already told you in the previous diagram, okay, if you see this diagram, so you keep increasing from arbitrary value and you go to a maximum area where the lung starts distending, and slowly you again decrease it till the alveoli starts collapsing. So you basically trying to find is what is a point A. Point A is your lower inflection point. So what you try to do here is you slowly try to increase it to an arbitrary value till imagine you're gone to a PEEP of 30, that is supraphysiological, where the alveoli starts distending. Hoping all the lungs are recruited, you slowly start decreasing. So you start decreasing here, the same thing you're decreasing till this point. So this is a point where the lungs starts collapsing. So this is the point A. So this is the point below which the alveoli collapse. So again, here you found the lower inflection point. You again increase it. And till this, you again increase it to the supraphysiological point, and you decrease it 3 to 4 centimeters above the lower inflection point. So if you see here, the lower inflection point, point A was here, you keep the actual PEEP will be 2 or 3 centimeters above the lower inflection point. So where you started here, you started with a PEEP of 10, and see the difference. You've gone up to a PEEP of 14. So this much amount of lung you have recruited. Okay, this requires a lot of patience. This has to be done as soon as you intubate the patient. If you fail to do it, if you push the patient to ICU, whatever they do is of no use. So that is why recruitment maneuver has to be done by physicians. As soon as you've intubated, do it on the spot, and you should have patience, because you will have to, it's not an easy thing. You will have to slowly keep increasing it, again keep decreasing, find the lower inflection point, go back to the highest point, and again go 3 to 4 centimeters above the lower inflection point. Okay. So how do you do it otherwise? So by chance you don't know how to see this PV loop. So seeing this PV loop requires some amount of expertise, and it takes some amount of training also. So if you don't know to see this PV loop, how do you do it otherwise? Simple things. There is some parameter called compliance on the ventilator which keeps coming in. So you can see whether the compliance is improving or decreasing. Other ways, how can you see, is you can see the improvement in the saturation. Okay, you can use an ultrasound, simple ultrasound. You can see, if you see the first diagram, this is a totally collapsed alveoli. This is the pleura, is the totally collapsed alveoli, where you can see not much of A and B lines. So after you do a recruitment maneuver, you can see the B line starts appearing in the lower part of the lung. Okay, this will indirectly tell you that you have recruited the lung. Okay, so this, what we say, the gray, white and gray matter. This is a collapsed alveoli. In the collapsed alveoli, you can start seeing B lines. So that will tell you that the recruitment has occurred. Okay, you can use a bedside this one, and if you see the Western literature, they are doing portable CT scans. You don't have to shift the patient to radiology department. So in the portable ultrasound, in the CT scan also you can know whether the lungs are recruited. The same concept. When you're doing the recruitment maneuver, you go up to a point where the alveoli is totally distended. You come back when the alveoli is collapsed. So now you can see again the alveoli is collapsed. So you increase it to a point where it is optimal and the lungs are aerated. So the black shadows appears on the CT scan. So this is the advances which have occurred where, it's very more accurate than, even your ultrasound. Okay, there are different studies. I think I don't want to confuse you. Two basic things I have already told you. One, sustained inflation. Other one is stepwise inflation. Okay, what are the possible, the harmful effects? So I told you, you have to give supraphysiological pressures. So this supraphysiological pressures, what it can do is it can increase your intrathoracic pressures. So once your intrathoracic pressures are increased, your preload is decreased. So during your recruitment maneuver, patient can have hypotension, very important aspect. And because of your increased intrathoracic pressures, your intraventricular septum moves to the left ventricle, and again your cardiac output decreases. So that is why you will see that whenever you have very high airway pressures, patient will have hypotension. And when we are going to such high pressures, there is chance of barotrauma. So you can see because of the pneumothorax which is occurred because of the high airway pressures, which can be detected on the scans. And obviously, when we have high intrathoracic pressures, your preload are decreased, your intracranial pressures are increased. So the net effect of recruitment, it is less effective if most of the lungs are already open. So obviously, you can't recruit an already open lung. Okay. So the next is it's helpful when you're using lower amount of PEEP, okay, when compared to higher amount of PEEP. It depends on how many lungs are already collapsed, okay. PEEP, so I told you it has to go together. You just can't recruit and forget the PEEP. So recruitment is just opening it up. You have to keep it open. So PEEP can maintain the recruitment. So I told you based on the PV loop how you can decide the PEEP. Intermittent high pressures would be required to initiate the process. After recruitment has initiated, it is possible to maintain the airway pressures at a lower. So that is an advantage of using a recruitment maneuver. Okay, so now I told you, we talked about it. So which are the patients who are going to benefit? We can't do it in late ARDS, right? Obvious reasons I told you. It's a fibrotic stage. In the later ARDS, the fibrosis has set in. And if you do a recruitment maneuver, you are going to get complications of barotrauma, pneumothorax, everything. So do it when the lungs are in the early stage. So you don't go ahead and jump in and do a recruitment wherever in a hypoxemic patient who's coming to you an ED after 5 days or 6 days of ARDS or treated outside and come back. So do it only in the early stage. Later stage, you have a lot of complications. Next, second indication, do it as soon as you intubate, because as soon as you intubate, because you're intubating, you open up the vocal cords and the tube has gone in. So there is chances that the alveoli would have collapsed. So recruit the lung, put them on the ventilator so that the de-recruitment will not occur. Very useful in post anesthesia cares. They usually do it in the cardiothoracic surgeries. Important thing is, this is a very important thing. Most of the hospitals now, we are using closed suctions. So that is one of the reason you're not opening up the circuit. There's no loss of PEEP. So the alveoli don't get de-recruited. But some setups use open suction still. Okay, that is not a right way. But if you're using open suctioning, every time you do a suction, you have to recruit the lung. So it's not only causing trauma, you're indirectly putting infection to the lung too. Healthcare associated pneumonias. So, these are some of the changes what you can do. Okay. So these are some of the things which I wanted to, stress on. So recruitment maneuver prevents lung de-recruitment and fall in oxygenation. Patients who are already on optimal level of PEEP are unlikely to benefit. Extrapulmonary ARDS, I already spoke to you about, is more likely to respond to recruitment maneuver. Recruitment maneuver is more likely to be successful in early stages. Optimal techniques of recruitment is unclear. But important thing is, recruitment maneuver has a positive effect on the type 1 respiratory failure. So recruitment maneuver has positive effect on the type 1 respiratory failure and improvement of hypoxia, but they have not shown any improvement in the mortality and morbidity. So it has to be used only as a rescue therapy when you don't have any other options to improve the hypoxia. Okay, thank you everyone.
Topic, we all in emergency departments get refractory hypoxemic patients, and then we also acute intubate so many patients who need it. So we thought we'll discuss that how early we should start the recruitment maneuvers for the lungs. I would open it up for any questions from the students' side. Actually, it was very clear. Thank you. Thank you so much. Oh, sir. Yes, sir. Yes, sir.
Varun, that was an excellent presentation.
Thank you, sir.
You did teach. You didn't read aloud, and I was really impressed. And in fact, I'm unhappy that your lecture was not heard by many of the others. So I've been thinking in my mind, we will have to give you another opportunity to present it to more number of our youngsters who will be ventilating such patients in the emergency ICU. Yes. I have two questions myself. Yes. One is, what is the incidence, the realistic incidence of barotrauma when we are doing lung recruitment? And how often does it occur? How soon does it occur? When do we need to do a repeated ultrasound or something to pick up the pneumothorax which develops? So basically the one question is for you to tell us a little bit about barotrauma from a practical point of view. How do we identify? When do we anticipate? And how do we pick it up? That's one. The second question I want to know is, you talked about the closed suctioning in a patient who's I don't know about it. Is it something that you are all familiar with? You are all familiar with that? It's standard. Okay, very good. Anyway, so it's just ignorance on my part. Forgive me. Just answer the first question for me, please.
Okay. So you recruitment maneuver has to be done. One is early part of ARDS. So patient has features of type. Yeah. So okay, barotrauma. Even the barotrauma, the chances of pneumothorax is more in the fibrotic stage when the lungs are stiff. So you have to anticipate only in the later part of the disease. That's the one thing. It does not occur in the early part. Okay, that one thing. Second thing is, as soon as you have intubated the patient, you've done a recruitment maneuver, and for some reasons, your peak airway pressure starts giving an alarm. So once your peak airway pressures, you would have intubated the patient. Imagine the peak airway pressure was 30 and you intubated, and you are now monitoring the patient. Suddenly the airway pressures starts going to 35, 40 for no reason. So first what you have to do is, whenever you get an alarm, don't blame it on the machine. So this is for the youngsters. Always will think the machine is wrong. No, you are wrong. Please understand it. It's the monitors will always be correct. So once you get an alarm, the airway pressures can go up if there is any block in the circuit, if there is any secretions, right? That is one reason it can go up. Or patient is having active spasm. Okay, so first rule out common causes, whether there's any block, or you're transported the patient to a CT scan, whether the tube has come out, whether the tube has become kinked. You would have put some HME filter, whether it's become kinked. So rule out the common causes. Once you know these are not the causes, that's when you should start thinking pneumothorax, especially in ARDS patient. So easiest way is not a chest X-ray, do an ultrasound. You do an ultrasound, see the lung point sign, see the lung slide sign. If it is absent, if you see a lung point, it's a pneumothorax. So that is where you can pick it up. So you can pick it up, one, by a clinical examination. I think most of you know, decreased breath sounds, you'll have absent breath sounds, unequal chest movements. You can confirm it with the bedside ultrasound. So you can do it. Pneumothorax most oftenly is with the wrong ventilation strategy. Yeah. Incidence is very low if you've done it, if you're doing it in the early stage. But if you do a recruitment maneuver or if you put a ventilator settings which are very high, or peak pressure which is very high, or a supraphysiological PEEP which you're not know to monitor it, then the incidence is very high. Incidence of pneumothorax is very high, somewhere around 20 to 30%.
So, thank you, Dr. Varun. And sir, one answer I also have for you. 185 emergency physicians are hooked on live presentation. So, at present also. So, our live, this is going on YouTube live. So, there are presently, I just checked it outside, it is 184. So, because I looked, it became 185. So before we are late, but before we go ahead with Dr. Venu's presentation, which I really want to listen and become a part of it, Dr. Salesh, okay. Dr. Einstein, I request you, Dr. Rahul is there from Karat, KIMS. He has helped us a lot yesterday in doing our workshops. AME wants to honor him with the appreciation. Dr. Rahul, please. Sir, here he wants. Thank you, sir. Dr. Salesh, I never knew Dr. Salesh before. Dr. Salesh, your presentation is there. But the best part was he just wrote to me, I am there, ma'am. I am coming. Don't bother. If you have time, send me a mail. If you don't have time, no issues. So thank you. Once I read all these messages, we talked for 15 minutes after that. Thank you so much.
Thank you. Presentation. So actually, this disaster topic which we had, the CME which we have planned, is basically a workshop sort of thing where we had 4 sessions. Dr. Kasturi and Dr. Bindi also are there, and along with Dr. Venu. So this session is, so here what I'll be trying to do is rush through the basic things, but I don't know whether everybody would be interested in just going through the basic things. We'll just rush through the whole thing, okay? So I'll be more faster on some slides where I'll just move a little bit faster. Okay, so disaster has been a topic, I think, which most of them, it's a very dry subject, dry topic with most of the people will feel, very, to talk about it, teaching is a little bit off the thing. So I'll start off with what is disaster. So how did this term come up? So disaster it's a French and Latin word where disastro, which means that, they have something, this person, a bad omen, a star, an evil star or a bad star. So that's how this disaster came in. And this is the World WHO definition. So the very fact, the moment we hear disaster is the magnitude of it. That, it sounds, the damage which is caused, the amount of people involved, the amount of property damage, what all happens there, what affected part of it, and along with it, in terms of getting it, to correct that whole thing, the resources which we need is enormous. So WHO defines his definition, I would like to use the same words. So any occurrence that causes damage, economic disruption, loss of human life, deterioration in health and health services on a scale sufficient to warrant an extraordinary response from outside the affected area or the community. So you have seen, once there is floods, it is not just the people who are affected. You need, their livelihood is gone, the families are affected, and it is for quite some time.
So at the same time, the number of people required in terms of resources used to correct it, you need the medical personnel, you need the NDRF, the National Disaster Relief Force. You need so many people coming into, lot of resources are needed. You need to set up shelters. So this is where the seriousness of disaster comes into picture. So what all we'll be going through is the different types of disaster, the terminologies used, and if it is fine, there is a 5-minute video, which is a video on the disaster at Bangalore International Airport, a mock exercise, and then we'll talk, there will be a scenario, and then we'll talk about the triage. Triage being the most important part in any disaster. I think in terms of managing a disaster, and then we'll be talking about disaster planning in the hospitals. So these are the types commonly which all of us know is natural and man-made. So you can have a spectrum of drought, earthquakes, extreme heat, thunderstorms, lightning, tsunamis, and volcanoes, and all these things which are your natural. On the other hand, accidents happening, structural building collapses, bridge collapses, shipwrecks. So these are all these man-made disasters. So if you go further in this water and climate-related disease, you can have the spectrum of from the extreme where you have excess of water, floods, cyclone, hurricanes. On the other hand, you have droughts where there is no water. So geologically related are those which we are seeing now in Uttarakhand and all those places where building collapses are happening, and earthquakes, and chemical industrial where explosions happen. So these are accident related, that is fires, mining, oil spill, the nuclear tragedies, all those things. And more recently, the biological ones. We had some years back anthrax and all those things, which was big time. So bird flu, swine flu, and most recently, the COVID. Okay. So train accidents, these are the, I'm just showing the pictures, the seriousness of, just to show the seriousness of it, and how, just having this, going to these areas, providing proper care at that particular locations. So somewhere shipwrecks and all, there will be multiple things here. Here, not just about the drowning part of it, we have to handle the physical damage which happening to them. Fire disasters, smoke inhalation, some people jumping from the building windows, so multiple things in this. So the gas tragedy, Bhopal gas tragedy, chemical related ones, riots which happen, the bomb blasts. So some of the terms which are used in disaster is hazard, risk, elements at risk, vulnerability, capacity, mitigation, and preparedness. So these are the common ones. And so hazard is basically a phenomena or a situation which has the potential to cause disruption or damage to the people, their property, their services, and environment. So like there is a probable thing which is there. It is a dormant volcano which can explode at any point of time. So vulnerability is where we are not actually prepared. We don't know that this can happen. So it's a condition or a set of conditions that reduces these people's ability to prepare or stand or respond to any hazard. So we already covered that. So capacity is the ability of the organization or the country to handle the situation, which is happening, to deal with the hazards. So that is the capacity. So then we have risk, the probability that a community structure or a geographic area to be damaged or disrupted by the impact of a particular hazard. So risk is equal to hazard plus vulnerability minus the capacity. So you can see that was there. So response is something which we, once a disaster has already happened, So once there is a disaster which has happened, so how are we going to, mitigate that or help that people out from that trouble? And also the rehab, relief. So all those measures which are taken in terms of not just about rescuing their life, but also in terms of building their next level, providing them with the day-to-day needs. And recovery is something where you are trying to restore them to the pre-disaster level. The rehabilitation is where the further next actions happen, where you are trying to construct buildings, provide them with financial help, providing job, all that part of it. Reconstruction is building permanent structures so that we, so this is, you can click on that. Click on that link. You have to press Control and click. Click. Huh? Hello. Okay. It's not seen, no? Okay. 1 minute. Why is it not there? Not coming, eh? It's coming here, no? You have to, you minimize this, no? Just minimize. Okay, I think it's. No, it's gone from you. Okay, fine. I hope you can change. I don't know, something. It's playing, sir, but it's not, I don't know why it is not. Okay, just at least pause it. No? Okay. No, sir, that is this one. That is to 1 minute. Yes, that's what that whole. Okay, so I think one of the most important parts of this whole presentation would be stressing on the triage. So we had actually divided into 4 groups in this whole. The talks were like that, such a way. It was not. It was supposed to be stations, and we had. So I'm actually. It's all going simultaneously. So it's. So that's how it looks now as a stretch kind of thing. Yeah. Okay. I think it's coming. Not that. Not that. Not that. Not that. I think wrong. This one video. You just take it off. No? Not that. ಅಲ್ಲ ಲಿಂಕ್ ಪ್ರೆಸ್ பண்ணுங்க ಅಲ್ಲ ಇದು ಕ್ಲೋಸ್ பண்ணுங்க ಓಕೆ ನೆಕ್ಸ್ಟ್ ஒரு மினிட் சார் we provide the emergency services at Bangalore International Airport, sir. So the last every alternate year, there is a mock exercise which happens. So this is the exercise So each biennially when we present it, when we are doing this mock exercise,
In an unfortunate incident of a plane crash at the BLR airport, the casualties at the crash site are given immediate and quick attention. The ATC instantly alerts the aircraft rescue and firefighting team. The aircraft rescue and firefighting team who arrive at the crash site, and the rescue operation begins. Ambulances from the nearby hospitals are rushed to the crash site. The medical team, along with the ARFF crew, establishes a mobile command post at the site. A triage is set up by the ARFF to ensure the victims are given quick medical attention, while the CISF draws up a perimeter around the crash site to avoid further accidents. The water rescue team strives to keep the damage in check. The triage set up at the crash site is used to provide first aid and stabilize the victims. While the uninjured and walking injured passengers are shifted to the nearest care center. The relatives and the dependents of the injured are assembled at the meet and greet area, where they provide their details. The critically affected casualties are airlifted to specialized hospitals. While the injured passengers are shifted to Astor Medical Center for treatment, while the injured are given the right medical attention. Government rescue representatives, stakeholders of BIAL, and the affected airline meet at the Emergency Operations Center to aid decision making. The information provided by passengers and relatives are reconciled. Having streamlined the victims and the visitors list, the relatives and the passengers meet at the Taj. Once all the wounded and the hurt are taken care of, the NDRF inspects the crash site for any dangerous goods. After the NDRF provides an all clear, the operations resume normally.
In short, it's just a 5-minute video where all the steps go through in. So I've been fortunate enough to have been in for the last 9 years to see. So each time they choose a different scenario in terms, so more difficult. So one of the times where the terrain to reach is difficult. So each time it is different. So it's been amazing. A lot of my learnings have been from this, in addition to all the other. So continuing. Yeah. So mock exercise. Why do we need these mock exercises? We need mock exercises basically, to be prepared very well for any eventuality, particularly. Unless and until we are prepared, particularly in this, the airport thing which we're seeing, 59 agencies come into picture together, 59 different agencies coming together. It's a year-long preparation. And then so next whole year goes in, reviving all those, what all things, shortcomings which happened during the thing. And then those changes are implemented, and the next year again another thing happens. So this goes on year. And so here we have a scenario. So how do we start? So we're talking about hospital disaster and how should we be prepared about this. So in a hospital disaster, so this is the emergency department gets notified where about a building, there's a cylinder burst, and then there is people who are going to be brought in. So depending on who gets the information, that's the first thing, who gets the information here. It can be anybody from the telephone operator to somebody working in the lab or in a radiology unit. So this is where each hospital should have a disaster preparedness plan in place and need to be prepared for that part. So actually it should have been an interactive thing where we would give the scenario and they answer about. We'll do that. Okay. So your name, sir? Talapati. You're working in? Okay, very good. So you received a call. Huh? Yes, yeah. Very nice. Okay. So you received a call. There is somebody who's calling up and saying that, I have. Huh? We'll spare it. Yes, sir. Yes, sir. True. Yeah. One of you? Okay. You first front here. Yeah. Yeah. So you received a call. You are working? Oh, very nice. So you received the call. So what would you do? you received a call saying that, around 25 patients are, there's a building which has collapsed, cylinder burst has happened, and we don't know anything else more. You want to confirm the information. How do you do that? But this person will say, see, you're wasting time on all these things. You first send the ambulances now. What all things you would do in the hospital for being prepared? Very nice, very nice. Okay. Very nice, very nice. So there's a nice way of, getting that information. So what we call as the methane information. So this is the way. So M stands for whether it's a major incident or not. What are the things, basically if you are going to declare it, whether it has already been declared or not. That's the kind of thing, okay? And then you want to know what is the exact location, where has it happened, the approach, whether there are any hazards to reach that place, whether any restrictions to reach that place, and what kind of accident, how to access this place. So can the ambulances go? Can the big ambulances go, or you need a smaller vehicles to move in? So these are all probably not immediately in the first thing, but then we need to collect as much of information as possible. Then in terms of the number of casualties, what would be the possible number of people who are affected? So that is other thing. And then whether already any other emergency team has arrived, or do you need more ambulances or any other support kind of thing? Okay. So that is the building which is blasted, and you see a lot of rubble there, and there is one team of people who have reached there and they have set up this triage. The NDRF team has arrived and they have set up the triage. So any idea of the triage? What kind of triage would you want to do here? What would be your priority if you have to sort out? 25 is fine, but if it would have been something like much more, 100, 50. Okay. Is there any particular way you would want to sort them out? Color code. Okay. Okay. That was nice. Okay. Sir actually told the thing. Okay. So there are simple triads, there are advanced triads, but the simplest one which we commonly use in any of that is the RPM way. That is the respirations, the pulse, and the mental status thing. That is what we call as the start triage. Okay. So that is the start triage. So what happens in that? I think I'll stand there. Okay. So what would you first look at is respirations. Sorry. Extremely sorry. Okay, so respirations. So first thing is whether you look for whether this person is breathing or not breathing. Okay, if you find there is no respirations, you just do a head tilt chin lift, normal thing, that fast. Then there is no respirations, then this person is gone, black, deceased. But if you still find some respirations, then these patients go into the red category or immediate. Whereas if you find that there is respirations, it is less than 30 or more than 30. If it is more than 30, obviously straight away they go into the immediate category. If it is less than 30, then you look into perfusion. That is, you look at the pulse as a medical person. If you are teaching somebody, you can even look into a simpler one is capillary refill time, less than 2 seconds and more than 2 seconds. So if it is more than 2 seconds, then you control the bleeding and these patients go into the immediate category. If it is less than 2 seconds and the radial pulse is present, then you look for the mental status. Mental status, you use the AVPU scale, alert, verbal response, unresponsive, painful response and unresponsive. So you use the AVPU scale. So if they can follow simple commands, then they go into the delayed category, that is the yellow. Or if they can't follow the simple commands, then they become the immediate category. So I think the entire, in the disaster thing, it is triage, 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 triage. It's one single thing. If it is done properly, then I think the other things just fall in place. And what we have seen is each person needs to just stick on to their roles which they are assigned to. And that is what is done actually in the... So there is a new... when I was doing this presentation preparation, so I found something called as the SALT triage. So they say that is the newer thing coming up. I haven't had the chance to go into the details of it, but this is what it is supposed to be endorsed by the ASEP and the ACS and all. So I really haven't gone, sir, if anything, input.
I'm familiar with the STAR.
Start the same thing, sir.
Not as a mock drill, but as a person who has worked at on-site.
Correct.
Especially, we had an accident. I mean, I've dabbled with disaster medicine for a very long time. In fact, I was a member of the NDMA, the National Disaster Management Authority, which is the highest body which looks at disasters across the country, and it is not even under the Ministry of Health, it is under the Ministry of Home Affairs. So it was very uncomfortable to go for their meetings, because once every 3 months, I will get a call and say, be ready, you have to go for a meeting. So my wife would ask me, where are you going? So I said, I don't know. So the meetings would be held in an undisclosed place. All I know is take a cab and come to the airport. So you go to the airport and there in military uniform, a person will give you the ticket and you board the flight. And when you board the flight, you tell your wife, I'm boarding this particular flight. So I presume I'm going to Delhi. It could be anywhere. It could be Arakonam, as close as 60 kilometers away. It could be Arakonam. I've been to Delhi. We had a meeting once in Ladakh. So, but it's not disclosed where it is going to be held. So it is a bit difficult. And the reason why this is done is, as you know, the command center will have to be absolutely secretive. In a mass disaster, disaster medicine, by the way, people, is a subspecialty of emergency medicine. Okay, it's a total different ballgame altogether. I know that you know about triage, the simple 3-color code, the 5-color code, all that. But in disaster management, especially on-site management, we use the START protocol. Okay, and I cannot teach you the whole of disaster medicine, nor can he do that in one session. It's a workshop which usually we conduct over a long period of time. And in fact, I don't know whether you have heard of HOPE. Have you heard of HOPE? Yeah. HOPE is actually a course which 5 of us together developed. It's called Hospital. HO stands for Hospital, P for Preparedness for Emergencies. So this was sponsored by USAID, and we met in Nepal for 4 times. It's a group of 5 of us who sat down together. I was the only one from India. So we sat together, wrote up this book called HOPE, Hospital Preparedness, and we taught hospitals in all the countries from Pakistan up to Philippines. So all the countries in between, except India, we taught, because India felt that we don't need that. So, but that's fine. But USAID actually supported us, and we taught this for 4 days. So disaster medicine is taught over 4 days. And I don't think Silesh can actually teach that over 1 or 2 hours, leave alone half an hour or whatever. So just open up and read a little bit. It's very interesting. See, you never know when you will have to come. And that's what I was trying to say. You see, in the department once at 4 o'clock in the morning, I got a call saying that 2 trains had collided near Ambur, which is just about 60 kilometers away from Vellore. So I immediately drove down to the hospital. I alerted them that I'm coming down. We are disaster prepared, basically, because I have the exposure. So immediately my team rallied around together, and we left in 3 ambulances to Ambur. And we did on-site triaging. We had 175 patients. So we are looking at large numbers, okay? In disaster management itself, you have 2 things. One is called a mass casualty incident. The other is called a disaster. A mass casualty incident is something that you can manage with the resources that you have. And a disaster is something which sort of decompensates the hospital, and external assistance is required. That's one of the first definitions which I'm sure you would have taught them. So in a disaster management situation, you have an in-hospital management and you have an on-site management. So you've got to have 2 teams, one working there, one working here. I went for the on-site for 2 reasons. One is my team has not had real-time or live experience, and I could, on the phone, keep in touch with my department because we are only 60 kilometers away. So I can't really tell you everything about what happens, but triage is a very, very important component. And what he talked about, he said you have, when you do your start triaging and you find that the patient is not responsive because he doesn't have a pulse, and you open it and see whether he breathes, he's not breathing, he's actually black. But in real life situation, I have another situation where I had a patient who actually was, "Doctor, please help me. Doctor, please help me." So when I went near him, I can still see the image in my mind, although this occurred many years ago. One of the steel girders which was there had actually collapsed, and the broken fragment had actually gone through him. So he was actually skewered like a kebab. Okay, but he's alive, and he's asking me to help him. So actually the start triage there, although he's technically dead, he still is alive. So we have this category, but what did we do for him? I just told my chap to just give him 10 milligrams of morphine slowly. So we gave him the morphine, and then he quietened down. And when we came back again for re-triaging, he had passed away. So it's a different ball game when we have a mass disaster and when we go for on-site. It's very different. But you must learn, you must attend. I think when who's organizing this particular thing, is it through, you're all doing it together, is it? No, not now. No, but you are doing this, yeah. So try to get, if you're in training in emergency medicine, you should have some exposure to disaster management. I used to teach disaster management in BITS Pilani for 8 years. Now I don't. But you should grab an opportunity and learn it somewhere. Because remember, the disaster can happen in your hospital, where it's an in-hospital disaster. It happened to us. Our theatre complex, which Ram, I don't know whether you're aware, it is there together. There are 14 theatres. There was an electrical fire in that. This is at 4 o'clock in the evening. All theatres are functional. All patients are being operated. Some are already under the anesthesia. Some abdomens are open. Some brains are open. So, it could be anything which is going on to these patients. But they need to be evacuated, which we did, because we had a mass disaster management or a mass casualty incident protocol in place. MCI protocol. MCI is not your MCI. This is a different one. We had an MCI protocol in place. So it was activated. The whole hospital came into action. So we were able to evacuate all our patients without a problem. So at some stage, try to see whether you guys can have an exposure to disaster management. Okay, Dr. Venu and the team are all doing something. So at some stage, whenever your next program is, probably now they can register themselves. Because many of your teachers will not be able to teach you unless they've had a full training in emergency medicine. Okay?
Thank you, sir.
I had been in a couple of disasters. One is in Bombay, where there were like 13 bomb blasts, and 600 people were brought in, and it's like crazy. So, yeah, I was doing general surgery residency. It is your Babri Masjid, 1992 December, and 1993 March was this happened. And man, what I would say is, call all the specialty, all the doctors in. Whether medicine, surgery, pediatrics, everybody has to be there, and everybody was working, starting IVs, doing all these things, and the other thing was when I was in US in a small rural hospital. I was there. This is before I did the emergency medicine residency. I was working in a small ER. There was a tornado, and 30 people died. But 80, that was like a 5-bedded ER. It's not a busy ER. But they brought 85 patients in 1 hour. And the power was down because it was a tornado, and the hospital power was down. It was running on a generator, and so we had to call all the family physician. 40 physicians came. So you have to bring everybody. And I would just say the obvious femur fracture. Another guy had a vertebral, because they were sleeping and they were thrown out. They were living in a trailer, and it lifts and puts you down. And people are, even the EMS, they had headlights, and people are like, everything was dark because it happened at night. And so you just see, there was a patient with severe pneumothorax, almost tension, I put the chest tube, so that patient was there, and another patient. So like that, you have to do things, and everybody was involved, and and another thing is, third thing is, that MCI book has to be there, and everybody in the department should know about it, where things are and where everything is, and they have to take a test that they have read the book, and there is a multiple choice question which they have to know, and who is the head, who is going to do what role, and whom all you are going to call. Anesthesiologist, everybody needs to come, because you don't know what all is needed. You have to call the neurosurgeon, anesthesiologist, surgeon, surgery. Everyone has to be brought in, whether they are on call or anything, and everybody should know about that book. What are the protocols, what are this, and every 6 months you have to revise. And
just to give you one more perspective, once I became the consultant in NHS, I was in charge of pre-hospital medicine and disaster management for the region. And when you're given 50 different industries near your hospital, as the consultant in charge, you have to know exactly what is cooking in all these places. And like Sir said about confidential information, I was living in that area for more than 10 years. I didn't know that one of the factories there had a nuclear reactor. Top defense secret. And if it leaks, what we need to do as providers, that we need to know. I don't need to disclose where the facility is in the whole area. So the most important, or the senior people, should be on site. The triage, as they repeatedly said, is the most important part of preventing deaths later, because the ones who are dying in front of you and those who are already dead needs the least amount of attention. Ketamine is a drug beyond belief in pre-hospital medicine. You don't need IV lines. You can just shoot and forget. Second thing is, if you're a junior, it's easiest role. No matter what is happening, you just need to do your job. You get given 2 or 3 patients, you just manage that patient and be ready for the next 3. Third thing is communication. So again, SSD was talking about radio between institutions. So if you remember the Bombay attack, when they came and killed so many people, the mobile lines went down within no time because so many people were making phone calls at the same time. So what we think as a reliable communication device will go off. So that's why you need non-regular communication mechanisms, and that's why despite all the development in the West, each department has a radio frequency device which runs on battery. So even if a tornado hits, the communication between your EMS, your on-site team and the in-hospital team is never disrupted. So communication very, very important. Otherwise, you're in the dark, you don't know what is coming in. And to finish off, when the 7/11 bombings happened in the London Tube or the metro, it's a great case study of how a system responds to a disaster. The death rates were very, very small, and every single hospital which was at the receiving end worked like a dream. So there were institutions receiving only minor walking injury patients. They did nothing else. There were 3 or 4 hospitals receiving only critically unwell patients. But if you look at the whole story of how that evolved, it's a casebook study of how to take up disaster management in a perfect way on one side. That is because of preparedness. Because institutions have been preparing like the airport video you showed. So that brings in the resilience by which you can do and deliver good care. On the other side, something we saw in Kerala, which probably Dr. Venugopal was involved, the flooding in Kerala which happened, yes, Kottayam and nearby areas where the... Yes. So if you look at that incident where the preparedness is not high, in India nowhere is prepared for disaster. If you go to each district, wherever you're working, please go to the Deputy Commissioner or the District Collector's book. It's a copy-paste of American disaster medicine. It's a simple copy-paste job from somewhere from Florida. So, but it doesn't tell you what are the disaster-prone events or venues or what is your district's threat. There is no preparedness. It sits in the Deputy Commissioner's office in some back cupboard. Nobody is ready. And suddenly when it happens, the doctors are called. We are called to respond to this. So the Kerala incident, which the flooding, it was an up and down area. We Malayalis are very good at putting sharp spikes around our borders. We build walls and put spikes. NDMA was called from Coimbatore. They came in the rubber dinghies. And in no time, they became victims because they went round and round in the ears and got punctured in the metal hooks. So what the state government did was, the best thing that the state government did, gave the deputy commissioners or the district collectors full autonomy on managing, which is how disaster should be managed. The power should be vested right down to the person or the area who are responding to it. They were all young. Most DCs or IAS officers in Kerala come in because they know they won't get any money. So the good ones come there who want to make a change. So these guys took over the management. 2 things I'll say and stop. The rubber dinghies didn't work. Government laid out, they used that ESMA or whatever the act is to release all the tempo travelers and these kind of the trucks to take wooden boats from the shore. Fishermen who are used to the up and downs of the sea came into the inner state to help. That one thing made a big difference. Another thing which we can't predict is the communication. Communication went down because of thunderstorms and everything. Your me to Suresh David communication is gone. So they deployed airlines, helicopters and aircrafts with wireless communication so you could beam it up and then it was beamed down. The third and the last point I want to say is the community involvement in that flooding where people sitting wherever in the world recruited themselves through Cisco servers which is given free of charge, and they were taking calls, verifying whether it was a social media stunt or not, and vetting the stunts out and giving only the right information to the district collectors, who picked up and then decided which is a red, which is an orange, which is a green. That's why the death eventually was only 394. Many, many more hundreds would have died. So that is not a prepared event, but how a state responded with sort of, common sense. And no Western country would have managed as well as those guys did because of on-the-spot thinking, good leadership, and pooling in resources which you wouldn't have otherwise thought of. So as physicians, if we can think of all these scenarios and be ready in wherever we are working, we can do an excellent job.
Thank you.
That's amazing, sir, actually.
In fact, I want to add, actually all the session was, we are planning in such a way like a small lecture, then tabletop exercises that fixing the priorities of the, and small group, they will prepare their disaster plan and finally do a mock. This way we are planning, but now it is out of question. Anyway, I will add a few more thoughts about, like in 2018, 19, 20, 21, all these years we have something like, in Kerala I'm talking about, a series of disasters. See, that inaugurated by Nipah outbreak, and from there, that point onwards, we are surplus. We have two floods, large flood, 19 and 20. And then, yes, COVID like anywhere. But during the COVID, we have the plane crash, Black Friday, and also flood. Like that, a series of this. So, certain 2-4 things I want to add on this. First, the communication devices. The Chennai flood, I also came here for, stayed for a week, and like that. Those time, Tausif was here. Tausif Hercule, Tausif basically is a radio jockey. The effectiveness of radio system was well utilized in Chennai flood. All systems are there, but he's used to mobilize using the radio. That is the one thing, apart from that other radio or walkie-talkie, etc. But that was something one commendable one. Coming to, I want to share a small story that in the Aster Medicity, Kochi did that's a perfect scientific evacuation. Like the Aster Medicity, Kochi is exactly a waterfront hospital. It is very beautiful. It has got the healing domain, etc. But at the same time, when this kind of things will, picture is totally different. The 2019 flood, it is exactly waterfront, and when that all the dams are open, water started flowing with a symbol like they will put it one stick and put it measure it one time every day, initially every day, and after some time every hour, like that they will look it, and proportionately, like these all JCI and then other NABH accredited hospitals, so we have that frequent run and other incident command, everything is placed proportionately, and we already we have some calculation and all. When this coming to this level, we will announce the code, evacuate, like that, and naturally, like in some one day in the midnight, this has happened, reach this level, immediately we started evacuation. All those time when evacuating, 450 patients are in the hospital. All the 400 hospital, 100 patients are critically ill patient, and 80% of them are on ventilator. So all these patients were shifted within 18 hours to the neighboring hospital. And again, like previously, like our DBs and the generator, radiology, all these emergency, this is all in the ground floor. Gradually, we evacuated one by one. But it was even a single mortality is there. This is all again possible because of the disaster planning. Again, we have that tie-up and other things with communication with all the hospital where the patient go. So like that. That is the one story of the rescue, very scientific way. At the same time, we have a problem in Pathanamthitta. Pathanamthitta, one hospital, they don't have that one, even they go for this airlifting of few patients. Something, the importance of the planning, everyone, all emergency, everyone should know. Second one about the plane crash. Plane crash, we are all much worried about the COVID. Those time it is happened. This is the flight coming from Dubai with suspected COVID. Among the plane crash, 150 patients were involved. These patients were shifted to 12 hospital in and around Calicut and Malappuram. This is in Malappuram district. So 12 hospital in and around, which include Calicut Medical College, Aster, and a few hospitals in the Malappuram. And the best thing, there are two best things. One is
the civilian response on site, I don't know if it is correct or not. If it is happened sometimes, it is going to be another big disaster. Because, in fact, like as his like picture showing, like the wing is burning. If it is like something happen, that all the aviation fluids are on the both wings. If this is burned, the entire airport and neighboring everything will be charred off. But luckily, it has not happened mostly. See, that is the reason. Huh? Might be. Yes. Yeah. That is there. About their civilians and all, they didn't any looting, nothing is there. They are very decently involved. They helped in the rescue. That is civilian response of that particular Malappuram district was brilliant. That is to be like commended separately. Similarly, that golden hour care. Because, like the Kerala has got the highest number of emergency people. Emergency medicine, even in 2007 onwards, it started working there. And all these hospitals are having, there is emergency people. At least one or two emergency people are working, and at least the initial management and subsequent destination management was brilliant. Yeah. Yes. Yeah, that was started in 2007. Yeah, right. Yes. So that sparking, yeah, that sparking worked very well, because in majority of hospital have that reasonably good emergency department. Among these, 1/3 of the patient came to me. The biggest challenge for those time, we are all in complete PPE. A disaster which managed in a complete PPE because our eye, ear, touch, everything is through that. We manage it to some way. Yeah. Yeah. Basically, what happened was there was plenty of water which went in, destroyed everything, power lines down, everything down. But the worst problem was that the people who lived there were looting each other, looting everything that was available. They broke into shops. In fact, if people were drowning, they were not bothered. They were helping themselves to all the material of this drowning man who's watching it, and he is drowning. So, in fact, the president apologized on behalf of the country and on behalf of FEMA. Now, FEMA that we mentioned, for those of you who don't know, is the Federation of Emergency Medical Agency. Okay, Federal Emergency Medical Agency. They are supposed to be the doyens and the saviors of the world, and all disaster management protocols are based on FEMA. But he said FEMA, I am ashamed to say, has been a disaster itself. But on the other hand, the whole world applauded India for what we did in the tsunami. Yeah. Others wanted to help, but they had their conditions. If I help you, will you do this for me? If I help you, will you do this for me? Categorically, the Ministry of Home Affairs said, no, we don't want your help, we will not do that for you. So when I landed on the 26th, the tsunami occurred on the 24th. 25th I'm traveling, I'm coming 26th. Immediately about 8 hours after I arrived, I was traveling, I was at home, Christmas. Immediately I took my team, we went there, we landed there. There were signboards which were on the trucks. Jalandhar. Are you coming from Jalandhar? I said, yes. We've been traveling continuously in trucks, in open lorries for the last 2 days.
country came there to help. That is special about India, which is not happening in any other of these so-called high-income countries, because they are self-centered. They are interested in themselves. They are only looking at ways of evacuating, whereas our people are coming from outside to come in and help. So India did a phenomenal job on this, and I spoke about this in one of the international conferences there, I think in Singapore or somewhere, I can't remember. So I said, you see, this is what we as a country are capable of, because we have that innate sympathy and the desire to help our own people who need help. So that's what Venu was also saying. You were saying, no looting, nothing happened. Whereas if you find that in any other country, the first thing will be like scavengers, like vultures, they will come and pick.
Yeah.
There are stories where people with massive injuries who can't even lift because they have had fractures, people in other countries have come and taken off their watches, their rings, and they feel it. Finally, when they went to the hospital, this is what they complained and said, I'm in pain. But people came and took what I had with me. So, India, for all what we say, is not, we're not very good, we look up to America. But let me tell you, in disaster management, we have one asset which is not there in many of these countries, and that is the sympathy of people, which I am very proud of, and I talk about this wherever I go.
So, actually, Dr. Radhakrishnan was the collector in Nagapattinam during the tsunami, and there were like 100 families lost their house and everything. He built those houses in like 3 months and relocated them. And people have he was a district collector, and people have their photo of him as if he is God. And he managed it so well that Bill Clinton, when he came to India, he said, I want to meet him. And he came and talked with him and how he managed and everything. And then Bill Clinton asked him to come to US. He sponsored him, and he came to various cities, Seattle, New Orleans, and all, to teach how to manage disaster. Can you imagine? He was asked, and he was in WHO for 2 years for international disaster management. So, and he's not a doctor. He is a veterinary physician, but he had a good heart. You know what he did? He took two children who lost their parents. He paid for their college, school education, everything with his own money. And then he wanted to give a surprise visit to one of them in their college. They call him Appa, father. They came and both of them hugged them, and tears came and things like that. So I think you have to have in your heart that I have to help. That is what is important. Yeah, that's what is most important.
Two more points I want to. One is, I told you the best thing. Something annoyed me in the, it is there, in the plane crash. And second one, a coincidence. The two things I want to then find. The annoying things, like we are talking about and put a lot of effort in the area of pre-hospital care. 2011 onwards, you are working, many things, like Angels is working, it's all there. But here, this point, I received, I told you, the 45, in fact 49 patients in Calicut. And among these, including that the pilot, co-pilot, and the three patients brought dead. There is one the pilot, co-pilot, and one child. I received all these three patients, particularly pilot and co-pilot, in a prone position, hand is like that. No one is at least trying to make it in the other. That is something annoying. And even, even if all, Kerala, you take the ambulance registry and all, you can get 800 registered ambulances. Still, like many of the patients came here in Innova cars. In one car, there are 5 or 6 patients. This tragedy still exists.
something, this kind of forum, we have to look into very seriously. Again, we have to work more on that.
Sorry, I don't agree with you on that. You see, this is where the public comes in.
Yeah.
Okay?
Mm.
The innate desire to help, they bring in their vehicles, they will take these patients and then they will take. So that should not be annoyed, but that should be a seed in our thought that that's what we've been talking about. We need to teach these people, we need to teach the public how exactly can they participate when there is a disaster.
Yeah.
See, all they need to do is ask, who are the people that we can take?
Like, sir,
All these greens which are there, take them and go.
sir, these are a few more words about, sir. Some of the patients already get into one of the hospital nearby, and then they just they put it in 1 or 3 cars. No one is bothered about it. In fact, we have like almost all 40 of the 45 patients, majority 17 patients is having the long bone injuries, and 8 patients is spinal cord injury, and these 8 patients definitely improved after the treatment, but most of these SA1 or something like that, coding I forget, but it's all could have been avoided. Otherwise, anyway, last point I want to tell about that the coincidence. 2012, something same kind of a big mock drill we did in the Calicut airport. That is again like we like created a scenario like 150 patients on board and plane crash, and all these 150 patients is transported in and around the hospital, from the airport to hospitals. And also the post like mock drill, we identified 10-20 points. Almost majority of the points were corrected later. This when real things happened, that bottleneck and all not there. And coincidence, the present disaster and the plane crash exactly in the same place where did the mock drill. Same place. Almost in the similar scenario.
But I hope the
Yeah.
safety, Shailesh, a critique on your video. Okay, I'm sorry.
Please, sir.
Yeah. On the video that you showed me in the mock drill, I did not see the scene safety clearance being issued by the SNR group.
But that is first.
I did not see that in that.
Gives a cordon,
Because
sir.
what I saw
then only they
was
allow us to-
the whole team came in and then started picking up patients and running.
No, sir. This whole thing is totally almost around 1.5 hours.
No. I'm just saying from the video that you showed. See, what I'm seeing is what I'm commenting on. So I did not see scene safety, which is a very essential part. And also, as part of disaster management, especially on-site, you need to make sure that not everybody runs in. You have to send the SNR group to go in first. Make sure that the scene is safe. Otherwise, all these people will die. That's what happened on ground zero. All the people died because everybody rushed in to rescue. This we are talking about is the Twin Towers. Okay. Yeah, the scene safety was not done. Lot of firemen, lot of people died. Ambulance people, fire people, they all died because the scene safety clearance was not given. So for me, that is important. See, those who are dead, you can't do much about it. Those who are badly injured, you can't do much about it. But why should I lose live, healthy people who are, it's part of their job and they're going there to help. So scene safety clearance is very important. I did not see that in that video.
Yes, sir. No, it is not there in the video, but that's something which is followed. And the thing is that initial part, this one, CISF people go cordon off the area. Then only these people from the ARFF team, that is the airport rescue and firefighting team, they come into picture. They do the initial triage till we from the medical team goes there. So I think.
When compared with any part of, but still this is happening. That is my worry and annoy. Even we did that work.
And also there's a lot of done by Aeme-Con and all the others who are there, when it surges. That's the problem. Water surge is the problem. And we had the same problem in 2015 in Chennai and in Kadalur. So I was fortunate enough to have been on site for 2 major disasters. I also took my team from Pushpagiri. In fact, Mario fell in love with emergency medicine because he was one of the medical students whom I took. What I do is, I don't take the oldies. I am the oldest. But I was also the medical director of the entire medical college hospital, but I'm an emergency medicine at heart. You can't take that out of me. So I took 2 ambulances full of interns and medical students with me. Taught them while we went along, because we had a 13-hour travel. But we went there because in emergency medical response, EMR as it is called, there are 3 stages. There's an early response, there's an intermediate response, and then there's a late response. Early response is the immediate after effects of the disaster. Intermediate response is the recurrence of problems which occurs. Our problem was what's called as the second wave phenomenon. Second wave is not the water. It is the diseases which come up and have the second wave of deaths. No, we had problems because of water contamination, and also our problem was, see, all the people were put, I mean, I can talk about disaster for days on end, but what happened was they were all in schools. They were all just dumped into schools. And you know that a school has got only 4 toilets for boys and 4 toilets for girls. And there are 20,000 people in there. So therefore, major infection spread. Of everything which can be spread, it was spreading. That was our second wave. Third wave, of course, are problems of social and psychiatric problems.
Yes.
PTSD, psychiatric issues, children who have lost their parents. These are all the third. So that is where the social team and the psychiatric team and the rehabilitation teams come in. EMR is when you and I will go in, our early management response. That's where we go. Second wave is where community health people come into the picture because they know how to handle infections, they're going to have how to handle communicable diseases, etc., etc. So there is a role for each one of these groups. We study this if you study emergency medicine well. Fortunate for me, I had studied all these things. So the collector and I, we were actually on the phone all the time. And he was asking, sir, what shall we do? So this is what is happening. So what do you need? So it was a very, very gratifying thing because we started work at 5 in the morning and finished at 8 at night. And 8 o'clock was the debriefing. We sat down, all of us together, and discussed what did we do? What is it that we did not do? Because I was worried about PTSD among my team. Because there were major things which they were witnessing. And these are young minds. They're hardly out of school in their second year, third year, fourth year of medicine. You see, and these can have very bad, and there were boys and girls and everybody. So I made sure every night we had debriefing. And they went to sleep peacefully. It was a very exciting and a very interesting, and it's a memory which I can never lose in my life.
So if we just look back at our watches, I don't think so. Any conference has gone up to 7 p.m., past 7 p.m. on the last day, on all the 3 consecutive days. Yesterday we crossed 7, today we crossed 7, and first day we crossed 7. Dr. Salesh, if it is okay for you, you know, we have heard the words of wisdom. That is what it is. Yes. Yeah. Thank you, thank you, thank you. Einstein, sir, you have to do that last. And we'll have a photograph together on the stage after this. Thank you.
I sincerely thank you all for attending this Association of Emergency Medicine Educators Conference and making it as a grand success. And in future we will collaborate with each other and we will share our knowledge and we will have AEME as a platform. My vision is like, you know, this platform should be apolitical and share our knowledge. And I was planning to have a blog, so all interesting cases we can put and discuss, and I want all the, and like even career guidance, for the emergency physicians, like blog, ECG, X-rays. We can do all those things, and we can involve. I will also involve faculty from the U.S. Into it, and I think it is a good opportunity, and I am very much honored, and I am learning a lot from here. Like scrub typhus and all those things. I have never seen a case of scrub typhus, but even dengue, I have not seen one. I saw one case, and that patient had come from to here and went back, and he was having fever.
It's an African word. It should be pronounced as dengue.
Dengue, correct.
Everybody says dengue.
Dengue, but it is dengue.
All kinds of words, but it is dengue.
Yeah, dengue. So, so we all can share our knowledge and learn from each other. And I thank you once again. Like stalwarts like Professor Dr. Suresh David and Professor Dr. Venugopal and everybody is here. Thank you very much. Thank you for the students, for participating and, having so many paper presentation, 100 paper presentation, I was like very much happy that so much enthusiasm, young faculty talks and, people are presenting with enthusiasm and everything. I am very much thankful to you. Thank you.
As we are live, just one thing to add, that there are still some virtual papers and posters which are left out. And that we will be doing because I am traveling tomorrow. So all those who are part of it, please don't worry. We are doing it day after tomorrow in evening. Yes. Thank you so much. Thank you. Everyone, thank you everyone. It has been very overwhelming experience for us. And I'm also very sorry for the fact that I could not manage time. But I hope I managed the academics. Thank you. Thank you so much.